So, I welcome you all to today's discussion. This is pathology. My name is Dr. Babawale, and today we are going to be talking about the principles of pathology. And this is one of the areas of our step one that is very important. We are going to get good questions from pathology, particularly the principles. And it's not very hard. So we should just try to understand what it's all about, and just take it out of the way. Pathology is very, very important, very, very important, and the questions they are easy, relatively easy. So we are going to be starting by discussing the cellular adaptation. I know most of us, we are very familiar with what cellular adaptation is all about. So it talks about how a cell adapts to stress, because from day-to-day activity, all the cells of your body, they are subjected to one stress or the other. It can come in different forms, and there are ways by which these cells respond to the stressors, and this includes hypertrophy. This includes undergoing hyperplasia, atrophy, metaplasia. So those are the essential four true mechanisms of cellular adaptation. Dysplasia is not a true adaptive mechanism. So the dysplasia is just like a bridge to development of cancer. So let us take them one by one. So the first is hypertrophy. So let me give us a situation of a cell being stressed because there is elevated blood pressure. So let's take the cardiac cell, for example. When the blood pressure is very increased, we can say that there's an increased afterload. So that means that the cardiac cells, they have to generate more energy to overcome that pressure, to pump blood into the aorta. Because if the pressure in the aorta is too much, the left ventricle might find it very difficult to pump blood into the aorta. So we need to find a way to reduce that afterload. Or the cell have to adjust. The cells within the left ventricle of the heart, they have to adjust in order to overcome that increased pressure or afterload. So one of the ways by which they can adjust is to undergo hypertrophy. And we know that one of those cardinal signs of problems, in hypertension is when a patient is developing left ventricular hypertrophy. It means that this patient likely has an hypertension that is already long-standing, and the left ventricles are trying to compensate. They are trying to adapt to that pressure by undergoing hypertrophy. So please don't get too carried away with my story. I'm just trying to make it simple for us to understand. So what is hypertrophy? The only thing you need to hold on to with respect to your exam is that hypertrophy is associated with an increase in the amount of the structural proteins and the organelles in the cell. That is it. What you want to do in hypertrophy is that you want the cells to become larger. If the cells are larger, they have more muscles. They have a way to overcome that load. For example, we have a load of like maybe 100 kg. Let's say that my normal weight is like 50 kg. So because I'm 50 kg, I cannot carry a load of 100 kg. So one thing I can do to carry that load of 100 kg, if I want to carry it by myself, is to try to exercise so that I build more muscles and I weigh more than 50 kg. If I exercise, I build more muscle, then I weigh like 200 kg. I can conveniently carry that load of 100 kg. So that's what hypertrophy is all about. And the way you can gain more muscle is to increase the components of the cells that makes up the muscle. And this includes increasing the structural proteins like the actin, the myosin, the collagen, as well as the organelles, the mitochondrion, the endoplasmic reticulum to produce more protein, the mitochondrion to produce more energy in form of ATP, And all these things are going to culminate in an increase in the size of the cells, you know, so you can respond to that stressor. So that's hypertrophy. You are increasing the size of the cell. And how are you achieving that increase in the size? You are increasing the structural protein and the organelle. That is all. The next is hyperplasia. Now, still working with that example that I gave us, we have a load of 100 kilograms and I weigh 50 kilograms. I cannot carry it myself. So what do I do? And I don't have time to be exercising so I can achieve hypertrophy. There's no time. I can call on different people that, okay, my friend, come. Um, you come. Like 5 people like that, you know, come together, each of us weighing like 50 kg. Let's say that I recruit like 10 people. So we are already weighing like in totality, we weigh like 500 kg. So definitely we can carry that load of 100 kg. So that's what hyperplasia is all about. We are increasing the number of cells, not the size of the individual cells now, but you are increasing the number of the cells. That's hyperplasia. So hyperplasia is associated with an increased proliferation of the stem cells as well as the differentiated cells. So they can, be able to respond to that stressor. So what can be the stressor? For example, increased estrogen stimulation of the endometrium. So maybe an individual has PCOS, and we know that what are the hormones that is elevated in PCOS? Anybody remembers from reproductive class? Anybody remembers?
Luteinizing hormone.
Okay, so the ratio of luteinizing hormone to FSH is more than 2:1. Yes. So what does that cause? What other hormones are elevated?
Increased androgen.
Testosterone.
Testosterone. Yes. There's something else. There's something that is particular to PCOS. There's anovulation. So what does the anovulation cause? There's something that the anovulation cause. Anybody knows? So the anovulation increases the level of estrogen. Don't forget that. There's no way
Yeah,
you
like
can forget that. Hmm?
it
Yeah.
hypertrophy, like it cause endometrial hypertrophy.
Yes. So because they are anovulating, they are not ovulating. So that means that their follicular cells are preserved. And we know that the follicular cells, glandular cells, they secrete estrogen. So that means that if you are not ovulating, the glandular cells are still there. So they keep producing estrogen. And the estrogen is there acting unopposed because there's no progesterone to counteract that estrogen. Why is there no progesterone? If an individual does not ovulate, there's no way you can form the luteal cells, right? The corpus luteum. And if there's no corpus luteum, there's no progesterone. There's no progesterone. So it means that the estrogen is just going to be acting on the endometrium unopposed. So that can, lead to endometrial hyperplasia. So the cells of the endometrium, they are going to be increasing in number. That is an example of a pathologic hyperplasia. We can also have it, in physiologic situation. For example, maybe with age, especially in men, with age, we notice that the cells of the prostate, they kind of increase. So we have like benign prostatic hyperplasia. That's more like a physiologic thing because the longer you live, the higher the chance of an individual developing benign prostatic hyperplasia. So it's because the androgens, will have stimulated the epithelial lining of the prostate and they will become increased in number and, leading to the benign prostatic hyperplasia. So that is that about hyperplasia. You don't need to worry too much about it. Just know that it's actually an increased proliferation of these cells, both the stem cells that is giving rise to them and the ones that have already differentiated. Hypertrophy is actually an increase in the size of the cell, not the number, but the size. Why? Because you are increasing the individual structural proteins and the organelles that are forming that particular cell. So these ones are still like increase. What if the stressor is like you not giving that cell enough food, the cell not receiving enough hormonal stimulation, the cell not being utilized? So all this is not going to lead to hypertrophy or aplasia, they are going to cause atrophy. Atrophy. So atrophy is more like the opposite of hypertrophy and hyperplasia. So in atrophy, you are reducing both the size of that cell and also the number of the cells. So let me give us an example. For example, maybe an individual had an accident and the person could no longer walk. We'll notice that if an individual is not walking for a long time, you notice atrophy of the legs, the muscles of the legs. So that's atrophy of disuse. How does this occur? This is a form of cellular adaptation because the body is trying to reduce the number of those cells so that they can conserve energy for the other vital organs that are active. So if an organ is not working, we don't need to be wasting energy nourishing or that particular organ. Let's just channel that energy to another thing. So that's what atrophy is all about. And how do you achieve atrophy? You reduce that tissue mass by reducing the size of the cells and also the number of the cells. Now, what is important for the sake of our exam is that you want to ask yourself, how do you achieve a decrease in the size of the cell? How do you achieve a decrease in the size of the cell? We already know that in hypertrophy, the way we increase the size is by increasing the structural proteins and the organelle. So if we want to reduce the size in atrophy, we should also reduce the structural protein and the organelles. So how do you break down these proteins and organelle? We break down those proteins by the ubiquitin proteasomal pathway. So any cell, any structure in the body that is labeled for destruction, some of them can be taken out by this ubiquitinization process. So you just add ubiquitin to them. Any cell that is tagged with ubiquitin or any protein that is tagged with ubiquitin, they are going to be transmitted to the proteasome. The proteasome is one of the organelles in the body, in the cell, and it's going to degrade that particular protein, that particular structure, anything, whatever it is, it's going to be degraded. So if I had ubiquitin to something, it means that I'm telling that stuff to go straight to the proteasome for proteasomal degradation. So that's the way they can reduce the number of the proteins and the organelles. Another way they can reduce the size and reducing the protein and the organelle is by autophagy. So this is more like self-eating. So the cells just begin to eat themselves. So self-consumption, that's autophagy. So those are the two things you need to know. And of course, the normal process of protein synthesis too is going to drop. So these are the ways you can reduce the organelles. These are the ways you can reduce the structural proteins. And in concert, they are going to reduce the size of the organelles. So how can you reduce the number, which is like hyperplasia now? So hyperplasia, I want to reduce the number. The simple way to reduce the number of cells is to label those cells for apoptosis, apoptotic death. So apoptosis is one of the pathways of cell death, which we are going to talk about shortly. So just know that in atrophy, the number of the cells, they are reduced because they die by apoptosis. So don't forget, don't get too overwhelmed with information. Just know that the way you can achieve atrophy is by reducing the individual number or reducing the size. If I want to reduce the size, I take out the organelles, I take out the protein. How can I do that? I tell the cells to start eating themselves. And I also label some of those proteins, using the ubiquitin proteasomal pathway. How do I reduce the number of these cells? I tell them to be dying by apoptosis. Very simple. So what are the stimulus? What are the stressors that can lead to atrophy? If you are no longer using that organ, the cells of the organ will start dying. If there's a loss of denervation, so that can also cause disuse in a way. If there's damage to the musculocutaneous nerve of my arm, so that means that my bicep muscle is no longer going to be receiving stimulation, and there's no way I can flex my arm, there's no way I can supinate. So there's going to be weakness in that area, and it can lead to disuse and atrophy at the end. Loss of blood supply, the same thing. There's no blood supply, the cells cannot do any metabolism. They are going to die. Loss of hormonal stimulation, poor nutrition, all of them, they work together. You don't need to cram it. It's something we can relate with. Take out the blood supply, take out the nutrients, take out the hormonal stimulation, don't use them at all. All of them is going to lead to atrophy. Moving on to metaplasia. So metaplasia is very interesting, and they like testing metaplasia a lot. Now, metaplasia is more like an adaptive mechanism that occurs when you reprogram the stem cells. We know that the stem cells are the cells that should be dividing into the differentiated cells. For example, if the target cell is, let's say, cardiac cells, we are going to have some stem cells, in the heart that will give rise to those individual cardiac cells, right? Whatever it is, maybe the muscles, the component of, the cell, the organ rather. So just look at the organ in totality. So what are the stuff that makes up the heart? We have the, the what's it called? The blood vessels that supplies the heart. We have the muscles, and all those things. So we have stem cells dedicated to each of those cells. So, but we can reprogram the stem cells, to be differentiating into another cell type. So, in order not to cause confusion, let me just, back it up with an example. Now, if an individual is smoking, right? An individual is smoking, the smoke contains some, some particles, nicotine, coal and all those things that can irritate the epithelium of the airway. So, for example, the trachea, the bronchial epithelium is normally the ciliated pseudostratified epithelium. So, the respiratory epithelium is usually the ciliated columnar epithelium. That is the normal epithelial cell lining the airway. But if an individual is smoking is a stressor. That's an irritant. It can irritate that epithelium, and what will happen is what? Metaplastic change. And why are you having a metaplastic change? We're having that metaplastic change so that the epithelial cells of the airway can better adapt. They can better cope with that smoking situation. So they are going to differentiate into something more tougher, much more tougher than the pseudostratified ciliated columnar epithelium. They are going to change to the stratified squamous epithelium. That is an example of a metaplasia. So it means that we have reprogrammed the stem cells, from differentiating, from differentiating from, what's the word now? So we have reprogrammed them to differentiate into the stratified squamous epithelial cells from the pseudostratified columnar epithelium. So you have changed them. Instead of differentiating to pseudostratified columnar epithelium, they are now differentiating into stratified squamous epithelial cells. That is a metaplasia. Another very good example is when we have an individual having GERD, GERD, that's gastroesophageal reflux disease. And we have exposure of gastric acid refluxing into the lower esophagus. We know that the esophagus is lined by, anybody knows the epithelial lining of the esophagus? Anybody knows?
Squamous.
Yeah.
Second part is squamous,
exactly.
stratified squamous epithelium.
So stratified squamous epithelium. Now, once that acid is getting to the esophagus, it will get to a point that the esophagus will be tired and they want to differentiate into something that can cope with that acid. So they are going to differentiate into the epithelium that lines the stomach, because the gastric acid is coming from the stomach. So that means that the epithelium of the stomach is able to handle that acid. So it makes sense for the esophageal epithelium to differentiate into the epithelium of the stomach or the intestine so that they can cope with that acid. So they are going to change from stratified squamous to what? Intestinal epithelium or the columnar epithelium, that we have glands, because the epithelium of the stomach and the intestine have glands. So that is an example of a metaplastic change. We have so many of them. I'm just going to stop with that too. And there's another form that does not actually require epithelium, but this one requires changing in between connective tissue. And that is what we call myositis ossificans. So they can put it in the exam, as a joker, to destabilize some people, because most people are familiar with epithelial changes, but you can have metaplasia of connective tissue too. And a very good example of that is myositis ossificans. So what is this all about? I'm not going to go into too much detail. I'm just going to give you, the basis, and we move. So what happens is, if somebody suffers trauma, maybe to the muscle, there's a muscle tear bleeding into the muscle. Because there's a bleed, there's release of some factors from the endothelial cells. And this includes stuff like the vascular endothelial growth factor, the bone morphogenetic protein. Now, those bone morphogenetic protein are going to convert the endothelial cells of the blood vessel into mesenchymal cells, that give rise to bone morphogenetic protein. So they are going to commit them into mesenchymal cells that give rise to osteoblasts. Instead of them giving rise to maybe new muscle, but they are going to be differentiating into osteoblasts. And when it differentiates into osteoblasts, you are going to be having bone formation or ossification of that area. So when you're having ossification of a muscle, it means you're having bone growing into a muscle, because you are just leaking, some growth factors like bone morphogenetic protein and vascular endothelial growth factor, into that muscle. So there is a form of reprogramming of the endothelial cells to differentiate into mesenchymal cells that produce osteoblasts. And the osteoblasts give rise to the bone, and the bone will be growing in the muscle. So that is myositis ossificans. That is an example of a metaplastic change. Then moving on to dysplasia. So dysplasia is not considered a true adaptive response, but it's considered a sequel of true adaptive response. And just, consider the ones that have dysplasia at the end of their names, hyperplasia and metaplasia. So these are the two that can progress to dysplasia. So hyperplasia, dysplasia, hyperplasia can go to dysplasia, metaplasia can progress to dysplasia, provided that the insult is persistent. So now, what is dysplasia all about? We just hear all this terminology in pathology. You don't need to worry yourself. Just know that, number one, dysplasia is not a true adaptive response. So they can put it in our exam. Which of the following is not a true adaptive response? Dysplasia is going to be the answer. And what is dysplasia all about? Dysplasia is just a situation where you have disordered growth of precancerous epithelial cells. So the epithelial cells are already moving towards the path of malignancy or cancer, but they have not yet, become cancerous, but their growth is disordered. That is a word. I have to put it in red. Disordered growth. Very, very important stuff. Now, so disordered growth. So, so what do you want to remember with respect to dysplasia? So you have to remember the acronym PICA, such that when you see the examiners describing PICA in your exam, you already know that this is dysplastic changes they are talking about. Now, what is PICA? So I have it here. PICA, the P stands for pleomorphism. Pleomorphism. So pleomorphism is just when you have a loss of the uniformity of the cell size and the cell shape. So the cell size is no longer uniform, and the shape of the cells too is no longer uniform. So let us look at this image here. This is the cell undergoing hypertrophy. They are becoming larger in number. This is a cell undergoing hyperplasia. Hypertrophy. They are becoming larger in size. This is a cell undergoing hyperplasia. They are becoming larger in number. This is a cell undergoing atrophy, it is reducing in number and also reducing in size. These are the normal cells. The normal cells have differentiated into another cell type. So you have, a brand of the normal cell and you have other types. So that is a metaplastic change. You have the normal cells here, and now they are undergoing some dysplastic change. And we can see some differences here. We can see that this one, the size of this is different from the size of this, different from the size of this, different from the size of this. The shape of this one is different from this, different from that, different from this. So that disorderliness, is shared with, dysplasia. So that is pleomorphism, loss of uniformity in the size as well as the shape of the cell. Number 2 is increase. So the pie chart increased, the high is standing for increased nuclear cytoplasmic ratio. So you don't need to be looking at it in the image. They are not going to show you image. Everything is going to be stated in the question. So they will just tell you microscopic findings, details, or shows that there is loss of, there is differences in the cell size and the shape. You already know that is pleomorphism. They will tell you that there's an increase, the high increase in the nuclear cytoplasmic ratio. You cannot forget what I've said. There's no way, if you are doing pathology residency and they ask you what is dysplasia and you do not say anything about the nuclear cytoplasmic ratio, you have said nothing. It is very, very important. There's an increased nuclear cytoplasmic ratio. Although it's not very, very evident in this image, but just watch out for it in the question. The nucleus is going to be increased relative to the size of the cytoplasm. Then the next is the C. So the C is talking about clumped chromatin. The chromatin will become clumped. The chromatin are within the nucleus. We should not forget that, and they'll become clumped. Then the A stands for abnormally frequent mitotic figures. So mitotic figures are just like figures that shows that there's like increased growth within the nucleus. So once you see them talking about increased mitotic figures, chromatin clumping, increased nuclear cytoplasmic ratio, and evidence of pleomorphism, you know that this cell is undergoing, dysplasia. That is it. Also, you can have loss of tissue orientation. So the orientation of the tissue, meaning that you cannot really tell if this is the top of the cell or this is the base of the cell and all those things. It's kind of difficult. So because normally we expect the nucleus to be close to the base, but in a cell that is undergoing dysplasia, you notice that the nucleus sometimes might, be moving up. Instead of coming to the base, it's moving up. So you cannot really tell that this is the base, this is it. So they're kind of scattered. So that's like loss of tissue orientation. You cannot tell the polarity. If this is the top, if this is the base. Now, how do you grade dysplasia? It's usually graded into the mild, moderate, and severe. Severe form of dysplasia is also known as carcinoma in situ. Now, the way they grade it is by evaluating the extent of the dysplastic change. So if the dysplastic change is only confined to the topmost parts of the cells, you can say that it's mild. If it's getting to the middle part, so from here to here now, that is moderate. Once it gets to the base, but has not breached the basal membrane, but it's already at the base, you can say that that is a severe dysplasia, and that is what we call carcinoma in situ. So cervical carcinoma in situ. So that's like a grade 3 dysplasia that is already affecting the basal cells. But once they breach that basal membrane, they become invasive cancer straight. That's already cancer. Once they breach the basal membrane, that is cancer. So mild to moderate is still reversible. You can reverse them, by removing the insult. If it's smoking, stop smoking. If it's alcohol, stop alcohol. But once it gets to the severe dysplasia, otherwise known as the carcinoma in situ, there's nothing you can do again. The person is going to definitely progress into invasive carcinoma, right? And don't forget that they usually occur due to persistent hyperplastic response and metaplastic changes. So an individual having Barrett esophagus, in which the epithelium of the esophagus is changing from stratified squamous to simple columnar of the intestine. It means that that individual is going to be having glands in the esophagus. So it means that the person can progress to cancer. But what type of cancer is that person going to go to? So that person is going to progress to adenocarcinoma, not squamous cell carcinoma of the esophagus. Anybody knows why? So that the class is going to be a little bit interactive. Anybody knows why it's going to go to esophageal adenocarcinoma and not esophageal squamous cell carcinoma? Anybody knows?
Because of the epithelial lining there
So
being
lower,
mm,
in the lower
Secretory glands there.
of esophagus.
Exactly. You know, we have said it. We said it that it is changing from stratified squamous to what? To simple columnar, which is
Columnar.
epithelium of the intestine or the stomach, and they have glands. So it means that if they are going to be moving to malignancy, it's going to be, you know, a cancer that, you know, is derived from a glandular epithelium. And adenocarcinoma is a glandular epithelial cancer, right? You know, as opposed to
Yes.
squamous. Hello? Someone is saying something? Okay. As opposed to squamous, you know, epithelium of squamous cell cancer of the esophagus, which is not from a gland, right? So adenocarcinoma is a cancer of the glandular epithelium. And because the cells within the esophagus already contain glands, you know, from the metaplastic change, they would progress to adenocarcinoma. So that can be a trap for you in the exam, and you know, you can easily see through it. So now moving on to cell injury. When all these insult becomes too persistent, right, the cell can become injured. The cell can become injured. And a very good example they usually use is hypoxic insult. Maybe you have reduced blood supply, you know, to a cell. What is going to happen molecularly? So the first thing that you should not forget it, please, is that number one, at the early phase, the injury can be reversible. Now, what are the features of reversible cell injury? Using hypoxia as an insult. The first thing that will happen is there's a drop in the level of ATP. Because if there is reduced blood supply, reduced oxygen delivery, the individual cannot carry out oxidative phosphorylation again. So there's a drop in the level of ATP. Now, what happens when ATP drops? When ATP drops, the sodium potassium ATPase pump and the calcium ATPase pump within the cell membrane, they will stop working. Because don't forget, these guys are ATPase pump. They need ATP to be working from time to time. So it means that they will stop working and they can no longer pump sodium out, you know, against its concentration gradient, and potassium in, you know, against its concentration gradient. So it means that you are going to be having a lot of sodium inside the cell. And when you have sodium concentrated in an area, anybody knows what happened? If sodium is in an area, what follows it?
Water.
Yes.
water.
So water is going to
Water.
follow it. So water is going to follow it, and you are going to have cellular swelling. You cannot forget this stuff. I'm very serious. They can ask it, you know, very common stuff. So the earliest morphological manifestation of reversible cell injury is what? Cellular swelling. Cellular swelling, very, very important. Okay, sorry, I think there's a question here that I'll omit. Let's just quickly solve it before we go to cellular injury. I'm so sorry about that. I didn't know. So, an investigator is studying the cell morphologies of a respiratory tract. He obtains a biopsy from the main stem bronchus of a patient, and on microscopic examination, the biopsy shows uniform squamous cells in layer. Which of the following best describe the histologic finding seen in this patient? So the person took a biopsy from the main stem bronchus, and on microscopy, the person is saying uniform squamous cell in layers. So what is this?
Metaplasia.
That's metaplasia. That's good. A 57-year-old man comes to the physician for a follow-up examination of a chronic retrosternal chest pain. The pain is worse at night and after heavy meals. He has taken pantoprazole, blah, blah, blah. Upper endoscopy shows ulceration in the distal esophagus and a proximally, dislocated Z line. A biopsy of the distal esophagus shows mature columnar epithelium with goblet cells. Which of the following microscopic findings underlies the same pathomechanism as the cellular changes seen in this patient? Do we understand what they are saying?
Yes.
Okay.
Yes.
So we have to look at the options and choose the best fit.
The pseudostratified
Columnar
columnar in the
epithelium
bronchi.
in the end of service.
So let me read out the options, then we tell me our diagnosis and the answer. So A is talking about pseudostratified columnar epithelium in the bronchi. B is squamous cell epithelium in the bladder, Paneth cells in the duodenum, branching muscular mucosa in the jejunum, chief cells in the ileum, simple columnar epithelium in the endocervix. So what is our diagnosis? What is happening in this patient?
Metaplasia.
Metaplasia. So which of the following option is also talking about metaplasia?
A. Squamous epithelium in the bladder.
Yeah,
Bladder.
it's not A. People saying A. A is normal epithelium. Pseudostratified columnar epithelium should be found in the bronchial. That is what you have there, right? So pseudostratified columnar epithelium is what you have in the bronchial. That is it. But if somebody is smoking, it can change to stratified squamous, not columnar. It's going to change to stratified squamous, right? So that's when you can now say that, okay, the epithelium in the bronchial has undergone metaplastic change. So stratified epithelium in the bladder is metaplasia. So what is a normal epithelium in the bladder? Transitional epithelium. Exactly. So what do we think can be a cause of this metaplastic change? Anybody knows any insult that can lead to that? From our knowledge of Rena. Anybody knows?
It can be what's it called?
Schistosomiasis.
The viral
Schistosomiasis.
infection.
Yeah. Schistosomiasis is very good cause. Very good cause. You know, all those Schistosomia japonicum and the what's it called? Hematobium. We're going to talk about it in microbiology. So don't forget that. So just like I said, under cell injury, the reversible and the irreversible one. The reversible one, hypoxia, no ATP, you have failure of the sodium potassium ATPase pump. They cannot pump because the normal function of that pump is to pump sodium out of the cell. Sodium is already abundant in the ECF. So that means if you are pumping sodium again into the ECF, you are pumping it against its concentration gradient. So you need energy to do the process. So it's ATP dependent. When there's no longer ATP available, it means that you cannot pump sodium out of the cell. So sodium remains inside the cell and water will follow. So leading to cellular swelling. So the cytosol, the mitochondrion, endoplasmic reticulum, ribosome, everything in the cell swells up. So that is the earliest morphological manifestation of reversible cell injury. So the way I picture this in my mind is just to focus on that swelling. So everything starts swelling in a way. What will happen to the nucleus? The nucleus, they will start clumping. You know, in a way, they are swelling too. So the nuclear change includes chromatin clumping, just like we have in which condition? Which other condition do we have chromatin clumping that we said? Dysplasia. So you have chromatin clumping. What will happen to the plasma membrane? The plasma membrane too will start swelling, but the swelling that we are talking about is formation of blebs. So if you look at this image, these are the blebs. The blebs, they start forming blebs. Mind you, at this stage, the plasma membrane is not yet damaged, So don't make that mistake of picking plasma membrane damage. It is not yet damaged. So it's just forming blebs, more like protrusion. The nucleus will start clumping. The plasma membrane will start forming blebs. And you start having detachment of ribosomes from the endoplasmic reticulum, the rough endoplasmic reticulum. The ribosome will start detaching. The mitochondria will start swelling. The nucleus will start having its chromosome clumping. The plasma membrane will start forming blebs. You can see, you can relate all these things to fluid accumulating, right? So just for us to be able to remember. Then at the end of the day, you notice that the cell will start losing its function. So if you are looking at myocardial cell, for example, due to ischemic, injury, you notice that after like 1 to 2 minutes, the cells will not be able to contract very well, and there's a loss of function. Then you have formation of myelin figures too. So myelin figures are just formed from aggregation of peroxidized lipids. So because the formation of free radicals, when you don't have any oxygen again, you can have all those, and the oxidative phosphorylation process is not going well adequately. So I'm going to explain it when we get to free radicals, but that process can lead to inefficient transfer of electron to oxygen. So instead of reducing, I'm sure we have done oxidative phosphorylation in biochemistry, right?
Yes.
But I'm not going to be asking us anything, so that we just quickly move. So the idea thing is that you are trying to transfer electron to oxygen so that you can reduce it to water. But because of this ATP and the mitochondria not doing well, already getting swollen, so that transfer process is not efficient. So they don't completely reduce oxygen to water. So they'll be reducing oxygen to free radicals like superoxide, like. Hello? Okay, I think the network is lagging. So yeah, so we start forming superoxide, we start forming hydroxyl radicals. And all those things will start attacking the lipids of the membrane. So forming peroxide, and when they aggregate, they form myelin figures. That might, sound a little bit complex, but don't worry too much about it. The initial ones that we have said, those are the most important thing. Just don't forget about the cellular swelling. And when the cells start swelling, the nucleus starts clumping, the membrane start forming blebs, and the ribosome start detaching from the rough endoplasmic reticulum. So if the insult continues, then the damage becomes irreversible, right? At this stage, the plasma membrane will now break down completely. So that plasma membrane that's forming blebs, they will now break down. So that is the most important thing in irreversible cell injury. So if a consultant tells you, describe, what you see in, tell me why this cell, has suffered irreversible cell injury, you just say that, yeah, it has suffered irreversible cell injury because the plasma membrane has broken down. They know you know what you are talking about. Once the plasma membrane is gone, once it's compromised, and there's a breakdown, there's a dissolution, that is irreversible. And what is going to happen afterwards? You are going to have cytosolic enzymes like troponin, because we are talking about cardiac cell now. Your, creatine kinase enzyme, they are going to start leaking out of the cell because there's already a pathway for them to escape. So they start leaking out of the cell. And our chief, which is calcium, will come in. So the cytosolic enzyme, they come out while calcium comes in. And once calcium enters the cell, the next thing calcium will do is to activate degradative enzymes, proteolytic enzymes, endonucleases. That is what calcium is going to do. So calcium is a bad guy. You don't want calcium to enter because it's going to activate degradative enzymes. Now, once calcium comes in, and it releases the degradative enzymes, they are going to start degrading the mitochondria. So the mitochondria will start losing its function, and it further worsens that, reduced level of ATP. So ATP level drops because the mitochondria are getting broken down. They will start breaking down the lysosomes. We know that lysosomes themselves, they contain degradative enzymes. So if you rupture the lysosome, you further release more degradative enzyme, and that is going to lead to eventual entire dissolution of that cell. And that is what we call autolysis. So you break down the lysosome will start releasing their own degradative enzyme, and they are going to work together with the other degradative enzyme that the calcium has activated to totally destroy that cell. That is autolysis. Then also the nucleus is not spared. So the nucleus undergoes three changes. The first one is pekinosis, which is condensation of the nucleus. From pekinosis, it progressed to cryoexis. So the nucleus, they condense, just like chromatin clumping of a thing, pekinosis. Then they start fragmenting, they start getting broken into fragments, by the endonucleases, which are part of the enzymes activated by the calcium. Then after some time, there's eventual destruction of the nucleus. You don't even see it at all. That is cryolysis. So by the time I start talking about apoptosis and necrosis, apoptosis will only stop at stage 1 and 2, which is pekinosis and cryoexis. Apoptosis never causes nuclear dissolution, but necrosis is going to cause nuclear dissolution. So necrosis progress from pekinosis, which is a nuclear condensation, to cryoexis, which is a nuclear fragmentation from the endonuclease cleavage, to cryolysis. So necrosis undergoes the 3, while apoptosis is only the first 2. Then you also see amorphous densities in the mitochondrion, which is more like lipids, protein combining with the calcium that has entered, and they are now depositing in the mitochondria. So, that is what happens in irreversible cell injury. Do we understand, or we have any question? Is there any question?
No.
Okay, no question. So let us look at this case scenario. A 78-year-old man died suddenly from complications of acute kidney injury. An autopsy is performed, and microscopic evaluation of the kidney show pale swollen cells in the proximal convoluted tubules. Microscopic evaluation of the liver shows similar findings. Which of the following is the most likely underlying mechanism of this finding? So the man
Wait,
is...
this is
Yeah, I'm
oh
with you.
sorry.
I'm with
Explain.
you.
No, it's okay.
Yes, I'm with you.
Oh,
I'm
I
with
was
you.
about to say this look like that
Impaired.
irreversible. It looks like a reversible stage.
It looks like what?
Reversible.
Reversible cell
Okay.
injury.
So why are you
Yeah,
saying reversible? What did you
Reversible.
see? What did you see?
Reversible.
because pale swelling cells.
Exactly. That is what you need to bring out. The pale swollen cell. So that means that this is the initial phase of what? Reversible cell injury.
Reversible.
And what are the cells that are getting injured? The proximal convoluted tubule. I'm going to tell us the reason why the proximal convoluted tubule are the first to get damaged later, in the course of our discussion. So what is the pathophysiology? Which option are we taking?
The first one.
Impaired sodium
Impaired,
carbonate
yeah.
solution.
Exactly. Very, very simple. Very simple. A 59-year-old woman is admitted to the ICU after surgery following a motor vehicle collision. She has received a total of 4 units of blood. Physical examination shows dry mucous membrane and flat neck veins. Serum study shows a creatinine of 2.1, and urine microscopy shows granular muddy cast. So what are our diagnoses? From Rena, what is this? Sports.
Acute
Tubular necrosis.
Fantastic. So a renal biopsy is obtained and examined under light microscopy. Which of the following reversible cellular changes is most likely present in this patient?
Swelling of the mitochondria.
In fact, we are very good. Okay, so that is all about cellular injury. So moving on to cell death. So we have 2 forms, apoptosis and necrosis. So apoptosis and necrosis. So there's no way you will not get a question enough. It is not possible. There are some things that is not possible. Apoptosis and necrosis, they will ask you, one of them, cellular injury, they will ask you. Those are the common things in principle of pathology. So we have to understand them very well. So the first thing I'm going to say here is that apoptosis is ATP dependent. Please, many people don't remember this, but it is important. Very, very important stuff. Apoptosis is ATP dependent programmed cell death. So it is programmed. We know that it's going to happen. It is a programmed stuff. ATP dependent programmed cell death. And it occurs by 3 pathways. Actually, it's majorly 2. So the extrinsic and the perforin granzyme pathway are like together. But let's just work with what we have. Let's say 3. So the intrinsic pathway, the extrinsic pathway, and the perforin granzyme B pathway. The perforin granzyme B pathway. And what does all this pathway culminate to? Like this, what is the final common pathway? The final common pathway is that the 3 of them, they are going to activate caspases. So caspases are cytosolic protease enzyme that have the ability to destroy cellular proteins in the cytosol, so that you can, kill that cell at the end of the day. The end result is that I want to activate caspase. That is what apoptosis is all about. And when that happens, you are going to have, because if you break down the protein of a cell, what will happen to the size of the cell? Anybody remembers?
It reduces the
It
It reduces.
It's shrinking.
Exactly. So that's why they have cellular shrinkage. Then you just had what you expect for reversible cell injury. So which includes condensation of the chromatin, blebbing of the membrane, and formation of apoptotic bodies. So let me show us what we are talking about. So just forget about what we have here. I'm still going to explain them. So these are the caspases. So we usually have 2 types of caspase. We have the initiator caspase, which is like caspase 8. And we have the executional caspase. So the executional caspase includes stuff like caspase 3. So those are the caspases that will eventually kill off that cell. Executional caspase. And what do they do? So you can see that we have like 3 things they are doing. So they cause degradation of the cytoskeletal proteins, number 1. They go to the nucleus, they dissolve that nucleus, right? So there's nuclear fragmentation. Don't forget what I've said about apoptosis. What are the 2 phases? The nucleus is going to undergo with respect to apoptosis that we talked about.
Pycnosis and calypexis.
Exactly. So pycinosis, which is chromatin condensation, and cryohexis, which is nuclear fragmentation. They don't undergo cryolysis. Now, the nucleus has fragmented, the cytoskeletal proteins have been dissolved. So the next one is formation of what? The membrane blebs. Now, why are they forming this bleb? The idea is that they want to pinch off a component of this cell as an apoptotic body that is going to be transported to the phagocyte, like the macrophage, and it will be eaten. Let me tell us the clinical significance of this. The clinical significance of this is that they do not want to destroy this membrane, because once the cell membrane is destroyed and you have leakage of cellular content, inflammation will set in. If you do not take anything from this apoptosis necrosis lecture, please know what I've said. The cardinal difference between apoptosis and necrosis is inflammation. Apoptosis will never trigger inflammation, but necrosis will cause inflammation. So apoptosis, they are doing their job clean. They are very tidy in their approach. They just activate the caspase. Caspase will just break down the protein, destroy part of the nucleus, fragment it. Then they will now pinch off that part through cytoplasmic membrane blebbing, and they will pinch off a part, forming a apoptotic body. Then will now be labeled, to travel to the phagocyte, and the phagocyte will eat it. So they will do it for this part. They will come to another part. They will do the same thing till they eventually dissolve that cell. That is how apoptosis occurs. Is that clear to us? Do we understand that?
Yeah.
Yes.
Very good. So now, it is characterized by deeply eosinophilic cytoplasm and basophilic nucleus. So what are they talking about here? So any cell that has its nucleus undergone chromosomal clumping and nuclear fragmentation, they will always stain basophilic. It means that if you use the H&E stain, they are going to pick the hematoxylin component and they are going to appear blue. That is the basophilic staining. Now, they are going to stain eosinophilic with respect to the cytoplasm. Why? You don't need to cram it, just understand why, and it will forever be with you. The reason why they undergo eosinophilic cytoplasmic staining is because the proteins in the cytoplasm, they're already denatured, they are dispersed, they are destroyed. So once proteins are denatured, they are destroyed, they will take eosinophil stain. So H&E stain, they will pick the E part, eosin, right? But the nucleus will always pick the hematoxylin part and they will appear blue, while the cytoplasm is going to appear red. That is all. So if you are seeing a cell that is appearing, eosinophilic and the nucleus is appearing basophilic, you know that, okay, could it be this, apoptotic changes happening here? And don't forget the pykinosis and the cryoexis that we have talked about. Very simple. The cell membrane is intact.
Doctor, can you go again on that staining? You said the nucleus will pick
so we know the H&E stain. Are you familiar with the H&E stain?
Yeah.
So H is the hematoxylin that appears blue. The E is the eosin. Sorry about that. Eosin, and it's red. So when you have destruction of the proteins in the cytoplasm, that is going to make the cell pick the eosin. So because the proteins that are degraded, they are in the cytoplasm. So the cytoplasm is going to appear what? Eosinophilic. That is reddish.
Okay.
So the nucleus will pick basophilic stain because they are destroyed. So they will pick basophilic, stain, which is a hematoxylin, and they will appear blue. Do you understand that?
Yes.
So, so the cell membrane typically remains intact without significant inflammation. Can we see it has been stated? Unlike necrosis, one cardinal feature. So I've given an example of the nuclear changes difference, and I've also talked about the fact that necrosis is associated with inflammation, while apoptosis is not. Now, this is another place that they wait for people. Many people are not aware of this. They don't palm this point and they go for the exam. We have to know that in apoptosis, there's DNA laddering. So what are they talking about? All those enzyme that is activated, that is destroying this caspase that is destroying. One thing that it does in the nucleus is that it fragments the DNA in the nucleus. So in the multiples of 180 base pairs. So that means that it's going to be cutting the DNA in the multiples of 180. So you can just say a question telling you that when they did gel electrophoresis of the nuclear component of that cell, they are seeing that the DNA fragments are appearing in multiples of you are seeing 360, 540, and so on and so on, like 180, 360, 5. You already know that, okay, this is DNA laddering because of apoptosis. Because the caspase, they'll be cutting, the DNA in multiples of 180. So you're having 180 joining with another 180, another 180, another 180, piling up like that. So it's a very sensitive indicator of apoptosis. Don't get distracted with the big words. DNA laddering just means multiples of 180 base pair, indicator of apoptosis. Do we understand that? Is it clear to us?
Yes.
Yeah.
So moving on to the pathways. So we have the intrinsic pathway, the extrinsic pathway, the pathway. So what this is just telling us is that what are the pathways by which caspase can be activated? That is just it. What are the pathways by which caspase can be activated? So the first one is the intrinsic, otherwise known as the mitochondrial pathway. So don't forget this, please. Don't forget the names. Know the alternative names because you can see any one of them in your exam. So the intrinsic or the what's it called, or the mitochondrial pathway. So now there are so many things that can provoke the intrinsic pathway. One common example is tissue remodeling in embryogenesis. So let's say, what example can I give? Okay, so let's say that during development of the urogenital tract, we know that if somebody is a male, the mesonephric or the Wolffian duct will develop, right? Am I right?
Yes.
Yeah.
Why the paramesonephric duct will regress, right? So
Yeah.
so the mechanism of that paramesonephric duct dying is by apoptosis. That is a programmed cell death, apoptosis. So that is one example, tissue remodeling in embryogenesis. Another example is when you withdraw a regulating factor after cellular proliferation. So a very good example is a drop in the level of interleukin-2 after an immunologic reaction. So let me give us an example. For example, if there's an inflammatory response to a bacteria or to like maybe TB, and you need to recruit our cytotoxic T cells and the TFR cells. So we need an interleukin to make them surge, to drive them out, and that is interleukin-2. Interleukin-2 drives proliferation of your cytokine, your TFR cells and the T killer cells. It push them out. I know we have done this in immunology, but once that bacteria has been taken care of, we don't need our interleukin-2 again, right? So the production of interleukin-2 stops, but what will happen to the cells that are already there? What will happen to them? We can't leave them there, so we need to take them out by apoptosis. So if you withdraw a proliferative stimulus, the cells that are already there in response to that initial proliferative stimulus are going to die by apoptosis. That's do you understand that? Hello?
Yeah.
Okay.
Yes.
Now, the next one is now the common ones that they normally test in the exam. So, exposure to radiation. If a cell get exposed to radiation, there's a high chance that it will have acquired some mutation that is bad, that can lead to malignancy. So we need to take it out. We target it for apoptosis. Oh yeah, you go and die by apoptosis. You are already a bastard, in Dr. Babarinde's voice. So you can cause serious damage. Go and die by apoptosis. Toxin exposure. So it could be chemicals, chemotherapeutic agents, whatever stuff it might be. Hypoxia, very important stuff. Hypoxia, free radicals damage and all those things. Once you have a cell compromised like that from hypoxia, from toxin, from radiation, just label it, let it go and die by apoptosis before it starts causing harm. Now, a cell suffers hypoxic insult, radiation damage. What is the next thing? The next thing is that TP53 is going to be activated. TP53 is a tumor suppressor gene. I know we know this. So, tumor suppressor gene because it doesn't allow tumor to occur. And how does it do it? It gets activated and it activates some apoptotic proteins. And what are these apoptotic proteins? They are the bad guys that are killers. So the bad, the backs, and the back. So the backs, the back, BAX, BAK, BAD. So they are the, excuse me. So sorry about that. So we have the bad, the backs, and the back. So they are pro-apoptotic protein. Once they are activated, they would, trigger apoptosis. So how do they go about it? Ideally, we have some BCL2 family of protein. They include the backs, the back, and the bad that we have talked about, which are pro-apoptotic, as well as BCL2 and BCLXL. Now, the back and the BAD, they favor apoptosis. Why the BCL2, the BCL-XL, they are anti-apoptotic. Now, I'm going to explain what they do. Now, the back and the BAD, once they're activated by TP53, what they will do is that they are going to create pores within the outer membrane of the mitochondria. Now, when they create that pore, they are going to allow cytochrome C to escape, from the inner mitochondrial membrane into the cytoplasm. So cytochrome C is going to move from the inner mitochondrial membrane into the cytoplasm. Now, once cytochrome C enters that cytoplasm, it's going to be coupled with ATP and some other proteins that will now lead to activation of your initiator caspase, which will eventually now activate the executor caspases. So there are so many steps that have been omitted that we don't necessarily need, but where the ATP comes in is, coupling with the cytochrome C and other proteins, to activate your caspase. So the cell suffers an insult, maybe hypoxia, maybe radiation, and TP53 is activated, and we have said that, okay, this cell needs to die. Then we have to recruit the bad guys, which is BAD, the backs, and the back. And what would they do? They would go to the mitochondrial membrane, make pores for cytochrome C to move into the cytoplasm of that cell. And it's going to be coupled with ATP, and other proteins to activate the caspase. Then the caspase will now do these three things: cytoskeletal dispersion, nuclear fragmentation, and formation of the blebs, so that you can form your apoptotic body that will now be degraded by the phagocytes. So ideally, what keeps the activity of the back in check is the BCL2, BCL-XL. So once you have your BCL2, BCL-XL activated, they would prevent the pores from forming. But once TP53 activates the back and the back, there's nothing BCL2 can do again. So they will create the pores, cytochrome C leaks out, couples with ATP, another protein, culminate in activating the caspase, and there's apoptosis. So do we understand that up to that level? Do we get it up to that level?
Yes.
And the reason why we're calling it the mitochondrial pathway is because we can say that the mitochondrion is involved because it allows the leakage of the cytochrome C that will now activate the caspase. What is the clinical significance of that? So that is very, very important in the process of follicular lymphoma developing. We remember that follicular lymphomas develop when you have translocation between chromosome 14 and chromosome 18. Chromosome 14 and 18. Chromosome 18 codes for the BCL2, right? So once that translocation occurs, you tend to have overexpression of the BCL2. And what do we know about the BCL2? BCL2 is an anti-apoptotic gene, right? An anti-apoptotic protein, right? It does not allow for apoptosis to happen because it keeps the activity of the backs in check so that they don't make pores in the mitochondrial membrane. So it means that if you have overexpression of the BCL2, the gene that this BCL2 is coupled with will never die. And what is it coupled with? Chromosome 14. So that codes for the immunoglobulin chains. So it means that they will keep proliferating. The B cells, they will just keep proliferating like that without dying because they have overexpression of the BCL2. So there's no activation of apoptosis. They just keep, proliferating and they become cancerous. Do you understand that mechanism? Does it make sense to us?
Yeah.
Yes.
So that is very important. Then the extrinsic or the death receptor pathway is very simple. The hardest pathway is this intrinsic pathway. Once you know it, you are okay. Extrinsic and perforating granzyme pathway is almost like the same thing. Now,
sorry, sir, can you come again with the BCL2?
So,
expression over expression.
Yes. So what I'm saying is just picture that chromosome 14 codes for like a B cells, right? And chromosome 8 codes for BCL2. Now, you have a translocation between chromosome 18 and chromosome 14. That's what brings about follicular lymphoma. Once that translocation happens, what is going to happen is that you are going to have overexpression of BCL2 gene. And what did we say about BCL2? BCL2 is an anti-apoptotic what? Gene. They are not bad. They are not bad like the backs, and the back.
Yes.
So that means that the B cells, that this chromosome 18 has been translocated to, because of the overactivation of your BCL2, the B cells will never undergo apoptosis again. Okay. So if the B cells do not undergo apoptosis, are they going to die? No, they are going to keep replicating like that, and they'll become what? Cancerous.
Thank you.
So the extrinsic pathway is known as a death receptor pathway, just like the intrinsic pathway is known as the mitochondrial pathway. And what does it involve? So this one just involves receptor interaction, receptor ligand interaction. That is it. And what is the family of the receptors? The TNF alpha family. And an example of the TNF alpha family that we are talking about is the Fas ligand, the Fas and the Fas ligand. You see, this Fas is also known as CD95, and it is an example of a TNF alpha receptor. The Fas ligand is an example of a TNF alpha. So let me come again. TNF alpha is like a protein. No, it's not a protein. It's like a cytokine, right? And it is the same thing as Fas ligand because it can bind to something. While TNF alpha receptor is also known as Fas because Fas is also a receptor. So, and a receptor must have a ligand. So Fas has Fas ligand. Just like TNF receptor has its ligand, which is TNF alpha. Please, have I created confusion or should I come again? Do you understand?
Yeah, please come again.
Okay, so let me try and draw, I don't know, drawing to. So this is a receptor, right? This is a receptor, and you call that receptor Fas, CD95, Fas, right? Fas. Now, a ligand can bind to that receptor, and that receptor is known as Fas ligand. Fas ligand. Fas ligand. Now, this entire complex is a subtype of the TNF alpha family. What are they saying? They are saying that this Fas, that is a receptor, is an example of a TNF alpha receptor. Do we get that? Receptor. Why this Fas ligand is an example of TNF alpha? Because TNF alpha will bind to its receptor. Do you understand what I'm saying?
Yes.
Yeah.
So just look at this image. Focus on this image. So this is Fas ligand. This is TNF alpha. Both of them are like molecule binding to something. They must bind to their corresponding receptor. So Fas ligand will bind to its receptor, which is Fas. TNF alpha will also bind to its receptor, which is TNF alpha receptor. That is it. So this coupling has to occur before the extrinsic pathway can be activated, right? And what is the significance of this interaction? What they just do, the only reason why they exist in this life is just to allow for thymic medullary negative selection. Anybody wants to remind us what happens in thymic medullary negative selection? Anybody knows what happens?
The T cells that bind too tightly are undergo apoptosis because they
Nice.
bind too tightly to self antigens.
Exactly. So the AIRE, gene is going to dispose or release self-antigen into the thymus. So any one of the lymphocytes in the thymus that bind to those self-antigen, you need to take it out. You need to select them negatively by eliminating them. So how do they kill them? They die by apoptosis. So the pathway of the apoptosis is what you call the extrinsic death receptor pathway. That is it. So via this interaction. Now, what I just want to say is that the origin of the ligand.
Doctor, what did you call it again? You said thymic negative what?
Thymic medullary negative selection. This is immunology. So, doctor, do you understand? Did you get that name?
Yeah, I got the name. Can you expatiate on it a little bit more?
So I'm just going to say something. I'm not going to go into the details. You might have to go to the video, but what it's essentially talking about is that any of the lymphocytes in the thymus that react to self-antigens, they have to be eliminated. They have to die. So that you don't allow for autoimmunity. So the way they die is by the extrinsic death receptor pathway. So I would advise you check that video so that you grab that concept. It's very important. It's well tested. So so now if there's a problem with this Fowl's interaction, this TNF alpha, this Fowl's blah blah interaction, it will lead to autoimmune lymphoproliferative syndrome. Autoimmune lymphoproliferative syndrome. So what they are just saying is that if the Fowl's ligand, now I want to mention that the Fowl's ligand is present on the cytotoxic T cells. They are the ones that are destroying something. So the ligands are always present on the cytotoxic T cell. They are always present on the cytotoxic T cells, right? Why the receptor can be present in any cell, whichever cell it might be. It might even be another cytotoxic T cell. It might be any cell, but the ligand is always on the cytotoxic T cell. Now, if you have a problem with this interaction, for whatever reason, the individual can develop autoimmune lymphoproliferative syndrome. And what are we saying? So if we find it difficult to eliminate lymphocytes in the thymus that are reacting to self-antigens, it means that those lymphocytes will just be released into the blood and they'll be attacking self-antigens. So what they are going to cause is the autoimmune lymphoproliferative syndrome because they are going to travel to the reticuloendothelial organs. Can we mention the reticuloendothelial organs? Anybody knows anyone?
What's an example?
The spleen.
The spleen. What else?
The lymph node.
The lymph nodes. Yes. The liver. The liver too can be.
Liver, yeah.
So they will go to the lymph node. You know that they are not negatively selected. That is, they are not killed by apoptosis. So when they get to the lymph node, they are going to be replicating with joy in the lymph node, causing lymphadenopathy, right? They will go to the spleen. They will be replicating the spleen, causing splenomegaly. They will go to the liver, replicating the liver, causing hepatomegaly. Now, they'll even go to the bone marrow and start attacking the cells in the bone marrow, causing autoimmune cytopenia. So they destroy other things, but these are the common things that you see. So once you see an individual presenting with lymphadenopathy, hepatosplenomegaly, autoimmune cytopenia, you want to consider diagnosis of autoimmune lymphoproliferative syndrome. Very important stuff. Moving on to the last. The last is a perforin granzyme B pathway. What are they talking about here? They're still talking about the same thing. So this is just release of granules containing perforin and granzyme B by the immune cells. For example, the cytotoxic T cells and the natural killer cells. Now, we are still going back to immunology. Anybody wants to tell us the cells that the cytotoxic T cells are labeled to destroy? Anybody knows?
The virus.
The
Infected
virus.
cells.
Yes, and what
Viral
else?
vector cells,
And what
tumor
else?
cells.
And viral
And tumor cells.
And tumor cells. So it means that if they give you a question and they say that the cytotoxic T cell is destroying a virus or destroying a malignant cell or a cancer, which pathway are you going to pick?
perforin.
Perforin and Granzyme.
Perforin and Granzyme. You see, that is the way your exam will. You don't need to cram anything. Once you understand the pathways, you just need to figure out, okay, which is this one talking about? And you pick your answer. That is as simple as that. And what is a perforin and Granzyme B pathway? I share with you. Once the cytotoxic T cell interacts with that cell that it wants to destroy, so what will now happen is that the cytotoxic T cell is going to release perforin. And what will that perforin do? Perforin is going to perforate the cell that it wants to kill off and allow Granzyme B to travel through it. Once Granzyme B enters that cell, it's going to activate the caspase, and the three things are going to happen. Once for the extrinsic death receptor pathway, once you have that receptor interaction, it's going to activate the executional caspase, and the three things will happen. For the mitochondrial pathway, maybe from radiation, reactive oxygen species, toxin, misfolded protein, hypoxia, activation of P53, activation of the back and the back, they make pores within the membrane, cytochrome C enters, it will activate the executional caspase. Do we understand that?
Yes.
Yes.
So,
Yes.
please let me just plug my system. Just 1 minute. I'm coming. So, we must have that. If you have a jotter, scribble it somewhere in your jotter. Look at it every day, because it has to be with you spinal level in the exam. You would get a question on it. I got a question on this pathway, so definitely you can also get a question on it. So they can ask you anything, So
Sorry, excuse me. So
yes, I'm listening.
So this executional caspase is like the final common pathway. Is that right?
Exactly. That's the final common pathway. Yes.
Okay.
You are correct.
Thank you.
All of them, they are going to culminate in the activation of the executional caspase, which will do all those three things that we have said. They are going to do bikinesis, karyoexis of the nucleus. They are going to destroy the cytoskeleton protein, and they are going to cause formation of the cytoplasmic bleb, which will now, pinch off the cell as the apoptotic body. That's now going to travel to the macrophage for what? For phagocytosis. Very, very important. You can see that there's nothing to provoke inflammation here. Everything is neatly done. So, please, if we have any question, please ask. Very, very important too. So, let me go to, I think I have some questions here. Okay, so let's check this. An investigator is studying the normal process of shrinking the thymus gland with increasing age in humans. Thymic size is found to be gradually decreasing during puberty. Which of the following enzyme is most likely involved in the process underlying the decline in thymus mass with aging? Anybody knows?
Caspase.
Caspase. Very easy. Very, very easy. During an experiment, an investigator attempts to determine the rate of apoptosis in various tissue samples. Injecting cytotoxic T cells into the cell culture of one of the samples causes the tissue cells to undergo apoptosis. Apoptosis is most likely due to secretion of which of the following substance? Please be careful here. I'm not supposed to even say that.
Granzyme
B. Fantastic stuff.
Or porphyrin.
So, very fantastic. That's very good. So, okay, let's look at this. An investigator.
Doctor, can you explain more on that one? Why we chose Granzyme B? I know all of them will all come to that activation of execution at caspase.
Yeah.
But why grandstand B? Why not? My mind was going to the backs. Is it because it's not an extrinsic?
Yeah, so the reason why it's grandstand B is because they said they injected cytotoxic T cells. So the cells involved cytotoxic. And cytotoxic, they use the FAS receptor, which is the extrinsic, or they use the what? The perforin grandstand B.
Yes, I see. That's cytotoxic. Okay, I didn't see it. Thank you.
Yeah, you're welcome. So an investigator is studying patients with an autosomal dominant mutation in the long arm of chromosome 10. This mutation alters the structure of CD95 receptor. What is CD95 receptor? FAX. And impairs the binding of the ligand to this receptor. This patient are at greatest risk of which of the following complications?
Autoimmune
cytopenia.
So very straightforward questions, very easy. So moving on to necrosis. So we're not going to waste too much time with necrosis. Necrosis is very straightforward. The first thing we must remember with respect to necrosis is that unlike in apoptosis that we are forming blebbing of the membrane, here the membrane is damaged. There's no way you can forget this point. The membrane is damaged. And what? The intracellular component will leak. It's just like irreversible cellular injury. The intracellular component will leak, and there is, the cell, because, calcium will start entering, and degradation also happens. So there's enzymatic degradation and protein denaturation. Because when there's a compromise of the cell membrane, calcium enters, activation of degradative enzyme. So you have enzymatic degradation of the organelles in the cell and also protein denaturation. Then everything will now start activating inflammation. So inflammation is the major consequence of necrosis. It provokes inflammation. Apoptosis does not provoke. They keep repeating it. It's a very important clincher. You must remember it. So what are the types of necrosis? So we have the coagulative, the liquefactive, the caseous, the fat, the fibrinous, and the gangrenous necrosis. So this different type of necrotic pathway, actually depends on the organ involved. So let's start with the first one, which is the commonest, the coagulative necrosis. So it's usually very common when there is ischemic injury to solid organs except the brain. So once you have ischemic injury to any organ in the body except the brain, that organ is going to undergo coagulative necrosis. Now, because of that hypoxic insult, the enzymes in the cell of that organ, they are denatured. Now, if the enzymes are denatured, there is no way proteolysis can happen. So this statement I've said is only peculiar to coagulative necrosis. It is the only one that the ischemia, denatures the enzyme. It is only in coagulative necrosis. So because of that hypoxic insult, that ischemia, the enzymes, the proteins in the cell, they are denatured. So if the degradative enzymes are denatured, there's no way the enzymes can degrade the cell. So that means that in coagulative necrosis, you are going to have a preservation of the cellular architecture. You cannot forget this point. There's no way you can forget it. So once they tell you in the question stem that, following the injury, blah, 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 they did microscopy and they saw that there is preservation of the cellular architecture. You just smile and you go and pick your coagulative necrosis. Because in coagulative necrosis, because of the ischemia, the enzymes in the cell, the proteins in the cell, enzymes are proteins. So the proteins are denatured. And once they are denatured, they cannot do the activity of breaking down anything. So the cellular architecture is preserved. But the nucleus will disappear because, of course, that is one of the features of necrosis. So it undergoes the three phases: the pykinosis, the cryoexis, and the cryolysis. So for whatever reason, the nucleus disappears. It disappears. And don't forget what I said about what's it called? A protein picking up a stain. So I said, if a protein is denatured, what stain is it going to pick?
Sorry, doctor.
Yes, I'm with
Excuse
you.
me. Sorry. So you're saying that they preserve a cellular architecture. So that means that the shape of the cell is gonna be the same, like
Yes.
remain.
Mm-hmm,
Okay.
mm-hmm.
Okay.
It's not going to, change. Yeah, it's going to remain the same like that. So the nucleus disappears, just like we have said, the three phases is going to be experienced: the pykinosis, the cryoexis, and the cryolysis. And because of the denaturation of the enzymes, because of the denaturation of the proteins in the cytoplasm, they are going to pick up a particular stain. What stain is that? Eosine. So we can say that it is not only in apoptosis that we can have that. So even in coagulative necrosis, you can have, increased cytoplasmic, uptake of the eosine stain because of the denaturation of the enzymes, right? Very, very important stuff. So you don't need too much story. Just look at the pathophysiology of the injury. Okay, the person had accidents, so there is reduced blood flow to the organ, or the person threw a clot, embolus to the leg, and there is, ischemia to that leg. So this is definitely coagulative necrosis. And does my histologic finding corroborate this finding? Yes. What am I saying? Preservation of the cellular architecture with dissolution of the nucleus and increased cytoplasmic eosine staining. That is coagulative necrosis until otherwise proven. The next is liquefactive. Now, liquefactive necrosis is a form of necrosis in which that particular organ or the cell that is involved forms some liquefied substance. They become liquefied because they themselves, they look soft initially. So that's why the brain is a very good example of an organ that undergoes liquefactive necrosis. Just imagine, how can you preserve the architecture of the brain if the brain suffers ischemic insult? The brain that looks like, what's the word now? That looks like pap dissolved in water. Or is that a better example I can give? But you understand what I'm saying? The brain lacks connective tissue to give it a structural support. Do we get? So there's no way the brain is going to undergo necrosis and there's going to be preservation of the cell architecture. So the brain will just dissolve like that, So that is a form of liquefactive necrosis. So if the brain suffers ischemia, like a stroke, it undergoes liquefactive necrosis. Another example of liquefactive necrosis is, in bacterial abscess. So you have a bacterial infection of a particular organ or, a tissue, that tissue is going to undergo liquefactive necrosis because the neutrophils are going to come in. They are going to release their lysosomal enzymes. The lysosomal enzyme in the neutrophils, they are active. They've not become denatured because there's no hypoxia here. This is an infection. So the neutrophils are happy. They swim into that area, they release their lysosomal enzyme and to digest that tissue. So in the early phase, you are going to be seeing cellular debris and macrophages and the neutrophils. The same thing in people with CNS infarct. In the early phase, you are going to be seeing the cellular debris and the neutrophils and the macrophage. I'm sure Dr. Babande will have talked about it in neuro. Remember the phases of, ischemic changes in the brain. Anybody remembers? 12 to 24 hours, what happens? Anybody remembers? We have forgotten.
There's no change.
Eosinophils.
Eosinophilic changes, yes. So the nucleus is going to stain like, you see like reddish appearance of the cell. Yeah, that's correct. So then 24 hours to 3 days, what happens?
Necrosis.
What?
Neutrophils.
Neutrophils. So that is what they are talking about here as liquefactive necrosis. So the neutrophils will come in. they'll release, the enzymes to degrade that area and mop out the cellular debris. Then after that, like day 3 to 5, what happens? Or to 1 week? Macrophages, yes, they will try to phagocytose other remnants that the neutrophils did not take out. Then afterwards, what happens?
Reactive
Reactive glycolysis.
Scarring.
That is it. So, so at the early phase, you have the cellular debris, the macrophage and the neutrophils there. Then later, there's going to be cystic spaces, because there's going to be excavations, because your macrophage, your neutrophil will have taken out all the debris, so leaving the cystic spaces and the cavitations. So that will be a reminder that, something has happened here. It can never be the same as it is. There will always be some markings, that, something has happened here. So the early phase, you are going to be seeing the cellular debris on the macrophage, and later the cystic spaces and cavitations, particularly in the CNS. So that was about liquefative necrosis. Just think about somebody that experienced a stroke and somebody that has bacterial abscess from an infection. Everything is just due to the effect of the neutrophils releasing their lysosomal enzyme, which is digesting that tissue. Very important. The next is caseous necrosis. Very simple. They like asking caseous necrosis a lot. And we are going to talk more about it by the time we start talking about granulomatous inflammation. So what happens here is that caseous necrosis is a form of necrosis that happens in a cell when it is difficult for the immune system to eradicate that cell, that infection, or that, it might not be infection, it could be like
Organism.
Organism infection. It could be like an immune response. For example, let me say, let's stay with organism, because I'm saying another thing entirely. So because the immune response is not going to cause caseous necrosis. So don't let me say something that's wrong. So once you see caseous necrosis, it has to be infection. It has to be infection, because it's only infection that can cause the caseous necrosis. I'm going to shed more light on what I'm saying later. So infections that are very difficult to eradicate, like tuberculosis, leprosy, syphilis, the fungal infection. Think about all the fungal infection in this world. Like histoplasma, cryptococcus, all those things. They can form the granuloma. And nocardia also is notorious for forming granuloma. They are very difficult to eradicate. And the granuloma is such that the macrophages are going to start walling around that, focus of infection. Your T lymphocytes are going to start surrounding them too, trying to eradicate them. So this is a form of coagulative necrosis. You can see the eosinophilic staining. Everything is red. This is an infarct in the CNS, liquefative necrosis. This is the caseous necrosis, so cheese-like necrosis. So this is a gross specimen. So it appears white, like cheese, like what Yoruba people call wara. I don't know the cheese in Igbo or Hausa. So cheese is like cheese, we know cheese. So it appears whitish. So that is due to caseous necrosis, due to the T lymphocyte, the macrophages walling off that infection that is difficult to eradicate. So it's very common in granulomas. I'm going to explain that very well. Don't worry about it. I'm going to explain it very, very well. So once you see this, you think about caseous necrosis. And the next is the fat necrosis. The fat necrosis, they are of two types, enzymatic one and non-enzymatic. Now, let me start with the non-enzymatic, because that one is straightforward. So non-enzymatic fat necrosis is when you have necrosis of fat tissue due to trauma. So somebody, experienced maybe a stab injury to the breast, or maybe like a blunt injury to the breast, and you just notice that the contour of the breast becomes irregular. That's because of the fat necrosis. And you can also have fat necrosis due to enzymatic destruction. And the example that they like giving in the exam is going to be a situation of acute pancreatitis. So they will describe somebody having acute pancreatitis in abdominal pain, epigastric pain, released by bending forward, radiates to the back, takes alcohol, or they give you hypertriglyceridemia, all those risk factors for pancreatitis. And they ask you, what kind of necrosis is this person going to experience? That is going to be fat necrosis. Fat necrosis. So how does it happen? You see, people with acute pancreatitis, they release some of their enzymes. We know that the pancreas has so many enzymes, right? So lipase is one of them. So the mesentery surrounding the pancreas is rich in fats. So once you have acute pancreatitis, that is an inflammatory reaction in the pancreas. It is going to release some of its enzyme, which is lipase, and that lipase is going to destroy the fat surrounding the pancreas. And once you break down the fat, which is the triglyceride, you are going to elaborate glycerol and free fatty acid. Free fatty acid likes binding to calcium. That one, it has been a fact. There's no way you want to explain the pathophysiology of somebody having Crohn's disease, developing calcium oxalate stone, without talking about calcium having high fatty affinity for fatty acids. Excuse me, 1 minute.
Yeah.
Okay. So I think we are talking about the fat necrosis. So I said for acute pancreatitis, that's going to be an example of the enzymatic form of fat necrosis. And following acute pancreatitis, you have release of lipase, which breaks down triglyceride into free fatty acid and glycerol. And calcium is going to bind, to the free fatty acids. And calcium typically stains blue. So anything that binds to calcium would appear blue with the H&E stain because calcium is basophilic. So any cell that has undergone fat necrosis, you are going to see the outlines of the dead fat cells without any peripheral nuclei. I'm not sure I have any image here, but this is what fat cells look like. Once you see something ballooning like this white stuff, these are fat cells. So the surrounding ones are the ones that are already necrotic, but these ones are still like intact. But why the surrounding ones are they have undergone necrosis. But once you see something like this, it gives you an idea that okay, this is likely to be fat cells, and you can see that the surrounding areas are also appearing like blue in a way. So they are picking up the hematoxylin stain. So don't forget that the calcium deposit in the fat cells that are necrotic makes them pick up the hematoxylin component of the H&E stain, and they are basophilic. And you have two forms, the traumatic and the enzymatic form. So any of this necrotic stuff, you just have to ask yourself, what is the pathophysiology of this necrosis? Is it ischemia? You are dealing with coagulative necrosis. If it's brain abscess, it's going to be liquefactive. If it's due to like tuberculosis or histoplasma causing, necrosis, that's likely to be caseous necrosis. And if it's acute pancreatitis or trauma to the breast, that's going to be fat necrosis. So, you can figure it out from the Hello?
Is the calcium activated in both pathways, the enzymatic and the non-enzymatic?
Yes. The calcium is just binding to the dead fat cells. So calcium is activated in both pathways, yes. Then fibrinous necrosis is the one that, from the name fibrin is deposited in the vessel. That is it. But there are two pathways that can, cause this fibrinous necrosis. The first one is immune vascular reactions like vasculitis. That's what they are talking about essentially. So people that have all these leucoclastic vasculitis, polyarthritis nodosa, all these Wegener's, and because of the vasculitis, there's damage to the endothelial cells. You tend to have, fibrin being released from the blood, depositing into those blood vessel walls, so causing a fibrinous necrosis. The same thing for people with hypertension. So any form of hypertension, maybe malignant hypertension or from preeclampsia, and you have turbulent blood flow within the vessel, it can damage the endothelial cells. And fibrin is going to be deposited on those dead endothelial cells, and it's going to create a fibrinous necrotic appearance. So what you are going to see that's going to raise your suspicion is that you are going to be seeing like concentric, appearance of that lesion. Once you say like concentric, you know that, okay, this is concentric eosinophilic, deposit. You know that this is likely to be a blood vessel undergoing fibrinous necrosis. So don't forget the immune one. The commonest example is polyarthritis nodosa, but it is not only polyarthritis nodosa that can cause the vessels to undergo, fibrinous necrosis. It could come from other vasculitis too. Then the non-immune one is hypertension. Just think of anything that causes hypertension. Hypertensive emergency, preeclampsia, anyone. So for the immune one, it's just due to immune complex deposition, leading to leakage of fibrin and, deposition within the endothelial cells, deposition within the vessel wall rather. And also for hypertension, destroying the endothelial cells, leakage of fibrin, depositing. That's just it. So you just see the vessel wall containing eosinophilic.
Excuse me.
Yeah,
You said that so you said that there's something that they're gonna say that will raise our suspicions about fibrinoid. You said concentric something.
Yeah, concentric, appearance of the histology. This is not very concentric, but it's going to, let me see. So sorry about this. Yeah. So like what we expect is like a fibrinous, a concentric, eosinophilic deposit. Do we understand? Hello?
Yeah.
Okay.
Yes, hello. Yeah.
So fibrinous necrosis histology. Let me just see if we can get something online. And can you see something like this? Can you see this?
Mm-hmm.
So this is what we are going to see. You can see that it's red. So once you see this, you think of fibrinous necrosis. And also from the question stem, it's going to be described. So they can tell you that maybe the person has vasculitis or the person has hypertension. So you already know that, oh, this is fibrinous necrosis they are trying to tilt our minds to. The last one is gangrenous necrosis. And this one is a subset of coagulative necrosis. And it's just due to ischemic injury to the GIT and the limbs. So you use the word gangrene for the GIT or the limbs. So if there's ischemia of the limbs or the GIT tract, the bowels, you say they have undergone, gangrenous necrosis. So if there's chronic ischemia of the distal extremity or the GIT tract, there's development of gangrenous necrosis, and you have two types. So this is more like a gross diagnosis. It's not histological. If you say something has undergone, do we diagnose gangrene on histology? Is it not something that's clinical? Do we get what I'm saying? Hello?
Yeah.
So gangrene is something you can see. So it's more of a clinical thing than histology. Like all these fat fibrinode now, they are not clinical. You have to do histology to be able to say that something has undergone fibrinous necrosis. So you have two types, the dry and the wet. So the dry one is just coming from pure ischemia, which is a coagulative necrosis, pure ischemia, just like this. Now, when infection now superimpose on this, and you're not seeing like putrid discharge, foul-smelling discharge, then you can say that it's now wet. So that is a liquefactive, necrosis superimposed on a coagulative necrosis. So the initial coagulative necrosis is the one causing the dry gangrene. So if you see like a limb appearing blackish like this, no discharge, nothing, it's just dry like that, that's a coagulative necrosis. So, but you call it gangrenous necrosis because you can see it. It's like a gangrene. So gangrenous necrosis is a form of coagulative necrosis. But once you have superimposed infection on it, so the infection is going to involve, neutrophils coming around destroying that tissue, removing the debris, and everything is going to lead to formation of pus and all those things. So you can say that, okay, you're having a liquefactive necrosis superimposing on a coagulative necrosis. Do you understand that? Hello?
Yeah. But how for the GI tract, how will we know for the GI tract?
So like bowel ischemia. So they said somebody, had maybe road traffic accident, or the person had aortic dissection, and there's bowel ischemia when they went in surgery, and they saw that the bowels were already ischemic. So what kind of necrosis has occurred? You can say coagulative there, you can say gangrenous there. Both of them will not be there. Do you understand, Doc?
Oh, okay.
So
all right.
One of them will be there and you just pick your answer. So that's the way it works. So moving on to ischemia. Ischemia, we already know this from cardio. Ischemia just means that the blood supply does not meet the demand. So it does not necessarily mean that there's cessation of blood flow. It just means that the demand is not being met by the supply. Very simple. And what are the mechanisms? It can occur commonly by reduction in the arterial perfusion, which is what most of us are familiar with, atherosclerosis. Atherosclerosis, narrowing of a vessel, arterial perfusion reduces. It can also occur when there is a reduction in venous drainage. So if you remember the pathway of blood flow, so remember that blood flow moves from the artery, then it moves to the arteries, but let's ignore those arteries now. Arteries to the capillaries, right? Then to the veins, right? So if there is obstruction at the level of the veins now, let's say obstruction here, and you cannot have drainage of blood from here again, it means that all the blood is going to be pooling in the veins, right? And you are going to be having the blood, that pressure, being transmitted also to the capillaries. And the capillaries are very fragile. They can even rupture. And the pressure is also going to be transmitted backwards to the arteries. So definitely, when you have reduced venous drainage, it's going to impair arterial blood flow too. So that's how it can cause ischemia. And of course, shock. We know shock already. So a state of shock, reduced venous drainage, reduced arterial perfusion, all of them can cause ischemia. So with respect to our exam, we have to be familiar with some organs that are very susceptible to ischemia. Very, very important. They like asking it, and usually bonus question. So, okay, yeah. So, where are we? So the organs, so that are very susceptible to ischemia. The first is the brain, but it's not all part of the brain. The part of the brain that is most susceptible to ischemia are the boundary areas, like the watershed areas of the brain, like the junction between the ACA, the MCA, and the PCA. So I know that we have done neurology and we understand the cerebral arterial circles of Willi. We know the way it is. The ACA is just like this diagram I have here. The ACA is one here. The MCA is somewhere here in the middle. Then you have the PCA here. So the way I just want us to picture it in our head is that the major blood supply to the MCA enters at the middle. The major blood supply to the PCA enters at the middle. So it means that the pressure at the distal ends here is going to be less compared to the one at the middle. Do we understand that? Is that clear? Do we get that?
Yes.
So that is why the distal edges where they connect, that is where they are most susceptible to ischemia, because once you have a sudden state of shock now, bam, and you have reduced blood flow to the brain, bam, suddenly, the part that is going to undergo ischemia first is at those distal boundaries, because the pressure there is already, smaller relatively to the middle zones. So at the boundary areas where they interconnect, the pressure is at the weakest. So that is the most susceptible part to ischemia. So we call that the watershed area. So another place where you have the watershed area is at the colon. So in a way, we can look at the watershed area as where you have the distal vessels interconnecting. the distalmost vessels interconnecting. Another place is at the colon. And at 2 points at the colon, the splenic flexure that you call the Griffith point, and the rectosigmoid junction, which is called the Sudeck point. You can just know this for academic purpose. Nobody's going to ask you the point. It's very rare they'll be asking you putting the point. They would rather put the location, maybe the splenic flexure or the rectosigmoid junction. Nobody's going to be asking you Sudeck point or Griffith point, but you can just interchange. So if you are talking about splenic flexure, you are not going to be saying Sudeck point. So it's going to be Griffith point because splenic already has S. Sudeck has S, so you interchange it. So splenic flexure, Griffith point, rectosigmoid junction, Sudeck point. So at the splenic flexure, that is like the flexure where the transverse colon descends as the descending colon. That is where you have the splenic flexure. So let me show us. I know we know it, but just to see it again, the splenic flexure. So this is a point, of the splenic flexure. Now, at this point, the blood supply changes. So here you have the anastomosis between the distalmost portion of the SMA connecting with the high MA. So at the splenic flexure here now, you have the distalmost portion of the IMA and the SMA connecting together. So that is the watershed area. Then also at the rectosigmoid area, somewhere here, you have anastomosis between the distalmost portion of your high MA and the internal pudendal artery or the hypogastric artery. We call the internal pudendal artery also the hypogastric artery. So you have anastomosis between the distal portion of those two vessels connecting together, at the rectosigmoid area. So that is another watershed area. So those areas are susceptible to ischemic injury because they are supplied by the distalmost branches of their major vessels. So don't forget that. You cannot forget what I've said. You cannot. Very, very important, please. It's very important, the splenic flexure and the rectosigmoid junction. Those are watershed areas, just like the border zones of the ICAR, the MCA, and the PCA. Then the other ones are not watershed. They're just normal areas of, ischemia, but not because of the distal anastomosis, no. So the next is the heart. The most susceptible region of the heart to ischemia is the subendocardium of the left ventricle. Why? Now, this part is number one supplied by tiny vessels and not as strong as the epicardium, the one at the heart-thymus area. And again, the reason why they are further susceptible to ischemia is because when the heart is contracting, these areas are squeezed. The vessels there are easily squeezed, and there's obliteration of blood flow to the subendocardium. So that's why an individual can develop, subendocardial infarction faster. So, and subendocardial infarction is going to appear as what on ECG? Anybody knows? Anybody? Cardio? Anybody? Okay. So, subendocardial infarction is going to appear as non-STEMI. So, once the infarction is now transmural, right? It becomes what? Anybody?
STEMI.
It becomes
STEMI.
STEMI. Yeah, so don't forget that. It becomes STEMI. So that's that about the heart. Then the kidneys. The kidneys, the two portion that you don't want to forget is a straight segment of your PCT and the thick ascending limb, the medullary thick ascending limb. So both of them are in the medulla. The medulla is deeper part of the kidneys. So blood flow in that area is not very great compared to the cortex. So now they're already disadvantaged because they're in the medulla. Now, it is now the straight segment of the PCT and the thick ascending limb of the nephron because these two areas, they have a lot of sodium ATPase potassium pump. So they are actively using ATP. So they are the ones that are most susceptible to ischemic injury. And because they are now even, further down in the medulla, it becomes a problem. So if they put the option now to be cortical segment of the PCT, you are not going to pick that, or cortical aspect of the thick ascending limb. So it has to be the medullary part, the part that is, submerged deep down into the medulla, because the medulla is, ischemic initially. Now, the straight segment of the PCT and the thick ascending limb, they are metabolically active again. So they have a very high chance of, succumbing to ischemic insult. So don't forget, that is why, if we remember that question in the kidney that we are solving, what part of the nephron did they say was infected? Anybody remembers?
The PCT.
The PCT, yeah. So the last one is the liver. So the area of the liver that is most susceptible to ischemia is the area around the central vein. So I don't know. I know that Dr. Babarinde will have, talked about the vein, the zones of the liver. How many zones do we have in the liver? Anybody remembers?
3 zones.
So we have 3 zones. We have the periportal area. We have the zone 2, which is the area in between, and we have the centrilobular area. Exactly. So in the centrilobular area, we have the central vein, right? So in the periportal area, you have the triad. Exactly, portal triad, right? So where you have the bidot, you have the hepatic artery, and the hepatic portal vein. Exactly. Now in the central area, that's where you have the central vein. So in the central area, we have the central vein, where all the hepatic veins empty into. Now, the area that is most susceptible to ischemia is going to be the central vein, because the artery that nourishes the liver, they are located outwards, in the portal area here. So this is the area that is going to suffer the most, so that is very, very easy. That's zone 3. So there's something peculiar to this zone 3. Zone 3 again is the area where you have highest concentration of your cytochrome P450 system. And that has some clinical significance that we're going to talk about shortly. So do you have any question about this ischemia distribution? Any question? Okay. No question.
Please, can you go, boss? Can you go through the for that of the heart one more time, please?
The what?
Out of the heart.
The heart. So I was saying that the subendocardium is susceptible because the vessels there, they are tiny. And again, when the heart is contracting, it can be easily compressed. So shutting off blood flow to that area. Do we get that? Hello?
All right. Yeah, thank you.
So that's why the subendocardium of the left ventricle is very, don't forget that. So then there are some neurons in the brain too that are highly susceptible to ischemic insults, such as the Purkinje cells of the cerebellum, the pyramidal cells of the hippocampus, and the neocortex, layer 3, 5, 6. So all these things, we don't need to cram it. You will know them. It should become part of you, because once you see them, you know it. Purkinje cells of the cerebellum, the pyramidal cells of the hippocampus, and the neocortex, layer 3, 5, 6. So it's because these areas, they are areas of high metabolism. They need to be active. So the metabolic rate in the hippocampus is very great because that is where memory consolidation happens. The Purkinje cells of the cerebellum is needed for high activity like coordination, balance, and the likes. And also neocortex, they are 3, 5, and 6. Very important for cognitive function, motor planning, and all those things. So the neocortex, the Purkinje cell of the cerebellum, the pyramidal cells of the hippocampus, they are highly susceptible to ischemia because they are highly metabolically active. So that is that. Moving on to the type of infarct. So this is very simple. You don't need to stress yourself. We have 2 types of infarct, the white or the pale infarct and the red infarct. The way I remember this is just to assume that, number 1, the primary cause of red infarct is when you have venous occlusion, not arterial occlusion. If somebody has a single arterial occlusion, it means that blood is not going to go to that organ. So that organ is going to be pale. So that's the cause of pale infarct. But if an individual has venous occlusion, just like we have said here, you are going to be having blood pulling behind the capillaries, pulling behind the artery. So is that organ going to be pale? It is not going to be pale. Blood is just going to be pulling around that area. So that area is still going to be red because it's going to be congested with blood. Do we understand that? Hello?
Yes.
So that is why venous occlusion causes red infarct. Why a single arterial occlusion will cause pale infarct. Now, another cause of red infarct is when you have an infarction affecting an organ that is supplied by multiple blood vessels. Let me explain why. Let's assume that this is an organ, like the liver now. Two blood supply. One from the, what are the two blood supply to the artery, to the liver? Anybody knows?
Hepatic artery portal.
The portal vein and the hepatic artery.
Exactly. So hepatic portal vein and the hepatic artery. Let us assume that the hepatic artery is blocked and there's, infarct in this area. Now, the hepatic portal vein is still active, right? It means that blood is still going to be coming to this area. So you'll be seeing areas of infarct surrounded by, red areas because blood is flowing into those areas from the other source. So that is why another cause of red infarct is going to be, infarct in an organ that is doubly supplied with, blood. Do you understand that?
Yes.
So that is another analogy that you can quickly use to palm it. And these organs include stuff like the liver, just like I've said, hepatic artery, hepatic portal vein, the lungs. Many people don't know that the lungs is, doubly supplied. Number one, the pulmonary artery. The second artery is the bronchial artery. The intestine, of course, SMA, IMA. They are everywhere. Celiac trunk is plenty. The testes from the testicular artery and also the artery to the vas deferens. Both of them supply the testes, so it is double. So 2 testes, intestine 2, lung 2, liver 2. So the only one that is single is the heart and the kidney. The heart and the kidney. But before I jump into that, let me quickly talk about the perfusion injury after angioplasty. So, of course, this one is self-explanatory. The perfusion after angioplasty is also a cause of red infarct because if there's an infarct, if a single vessel is occluded and you have the organ that is downstream to it already infarcted, if you come back and you thrombolize, what will happen to the vessel? It will open. Blood flow will come back, right? And you see redness appearing around it again, just like what we have here. Does that make sense to us?
So can you take the perfusion injury, please?
Can you explain that again, please?
So now let's ignore the injury part. So what I'm trying to explain now is the red infarct. So we have said that causes of red infarct includes venous occlusion, occlusion of an organ that has double blood supply. So when you occlude one, the other one is still there. It will reestablish the blood flow. Or another cause of red infarct is when you have the perfusion of an already occluded vessel by doing angioplasty. So what I'm saying is you have an organ that is infarcted due to occlusion of the vessel. Now you come and you do angioplasty or you thrombolize. What will happen? Blood flow is going to be reestablished, right?
Yes.
So that means that you are going to be seeing redness surrounding the already dark infarcted areas. Do you get? So that is a red infarct. Do you understand? It's very simple. So the reperfusion injury is another thing entirely, which I'm going to explain. I think I should be able to explain it here. Is it here? I'm not sure where I'm going to explain it, but I think let me just explain in case I forget. Let me just explain it there. So reperfusion injury is a serious problem. And it is a problem that is mediated by free radicals. So you don't want to forget this. The perfusion injury occurs due to damage by free radicals. Now, what do we mean? Now, if an organ is ischemic, the organelles there, they will start failing. The mitochondria, everything is gone, right? Now, if you establish reperfusion and you have blood flow being reestablished, oxygen is going to be delivered to the mitochondria. And we know the function of mitochondria. Mitochondria is there to transfer electron to the oxygen, to reduce it to water so that it can form energy in form of ATP, right? Right?
Yes.
Yes.
Oxidative phosphorylation. But do we think that after we have reestablished, the circulation, the mitochondria are going to remain the way they are previously? No. So instead of them completely reducing the oxygen to water, they are going to reduce the oxygen to free radicals like superoxide, O2 minus. I'm sure we are familiar with this, right?
Yeah.
Yes.
And hydroxyl, free radicals because of incomplete, reduction of oxygen. So it does not completely reduce it to water because they are not very functional. So now these guys will not be swimming around and they will cause inflammatory injury to the organ. So that is reperfusion injury. It's free radical mediated. Very important. Don't forget. Scribble it somewhere in your notes. Jot it down. Please don't forget. Because they may test you. Now, the pale lymphat is just very simple. It just occurs in solid organs with single blood supply. So like the heart. Please, nobody should say that the heart has 3 blood supply now. RCA, LCA, and now in that situation, your RCA only supplies the right, your LCA supplies the left. So it means that if the left, if the LCA supply undergoes occlusion, only the left side is going to develop the infarct. The right coronary artery is not going to perfuse the left side. So can that cause a red infarct?
No.
No. So that is it. So don't get, distracted and be saying, okay, right, true. No, it doesn't work that way. And of course, the kidneys have only one vessel, the right artery, the renal artery. So the heart and the kidney, single. The liver, double. Testes, double. Intestine, double. Lungs, double. Okay. So moving on to free radical injury. So free radical injury is a very serious problem in pathology. You are going to come across free radical injury a lot of time. And we need to know the way they cause their injury. And it's just affectation of 3 structures: the lipid, the protein, and the DNA. That is it. So free radicals cause breakage of DNA. Please don't go and pick free radical cross-linked DNA. What's cross-linked DNA? Anybody knows? Anybody knows? Huh?
Cytotoxic
Yeah,
medications.
chemotherapy. I'm sure you want to say chemotherapy agent. Yeah,
Or
so
chemotherapy.
chemotherapy agent. But
Yeah.
free radicals do not cross-link. They will break it. They will break the DNA. They will modify the protein. What did they do to the protein? So they can misfold the protein. Protein misfolding. They can denature the protein. That's what. And for the lipids, I've already explained this when I was talking about, one of the injuries, I think reversible injury. So like you tend to have peroxidation of the lipids. So the free radicals, they interact with the poly unsaturated fatty acid component of the cell membrane, and they are going to convert them to lipid peroxides. So it's just forget about the chemistry. It's just free radicals interacting with the lipids. What's the word now? So there's something called peroxide, which is OOP, O minus. So these peroxides are like free radicals that can interact with the lipids. and they can cause some damage to the lipid component of the cell membrane. So you call that lipid peroxidation. So that's one of the effects of the free radicals. They can cause peroxidation of the lipids, they can cause denaturation of the protein, and they can break the DNA. So this is the way they would kickstart any damage they want to cause to any organ, by doing these three things. Now, how do you generate these free radicals? You don't need to cram all these things. You will know it. It's not something you need to cram. I don't encourage cramming, because if you cram, you forget. So you just have to understand how it happens. So the first is radiation exposure. So people that get exposed to radiation, even for treatment of cancer, can still have free radical injury. Why? Because when you get exposed to ionizing radiation is going to get in contact with water, which is 60% of our body system. And it's going to split water into, it's going to cause radiolysis, splitting water into H plus, and, sorry, it's very difficult to write with this thing, OH minus, OH free radical, dots here. Now, this OH radical is a bad guy. It is a free radical. So that occurs following radiolysis from radiation exposure due to splitting of water. We can generate free radicals by metabolism of drugs, and in the phase 1. So which is what happens during phase 1? We just did pharmacology. What do we expect in phase 1?
Lipophilic drugs undergoes oxidation, reduction, and hydroxylation.
Exactly. So hydrolysis, reduction, and oxidation. So now, what's it called? A very good example here is acetaminophen. So acetaminophen is paracetamol, and it can be metabolized in the phase 1, converted to a product that we call napkin. So I call it napkin. NAPQI. Have you come across this anywhere before? Maybe when we are doing
Yes.
So thank God we know it. So napkin. So N-acetylparabenzoquinolamine. So we don't need to know the full name. It's not, in fact, this napkin serve is not really very, I don't think they can, but it's good to know it, so that you can explain to yourself and maybe to, people. So the process of generating this napkin is also coupled with generation of some free radicals, like superoxide, like hydroxyl free radicals. And don't forget that you need to you need to produce a particular hormone. Did I say hormone? A particular substance to neutralize this NAPQI. So what is that substance that we need in the liver?
Glutathione.
Very good. Very good. Glutathione. So what do we give to replenish the glutathione stores? Anybody know? N-acetylcysteine.
N-acetylcysteine.
So that's the basis of giving N-acetylcysteine to treat acetaminophen toxicity. So when you come to the step 2 class, we'll talk more about that. So you just don't give N-acetylcysteine to anybody. So there has to be some, some basis. But that's the summary of the whole thing. So redox reaction, oxidation, reduction reaction, they can generate free radicals. Inflammatory response, like involving nitric oxide. So nitric oxide can easily combine with superoxide and form other free radicals like peroxynitrites and the other things. So, but all those ones are not very important. But just know that inflammation can generate free radicals. Then transition metals. So this one is very, very important. Transition metals like iron, like copper, they can generate free radicals. And that brings us to the Fenton reaction. I think I have the equation here. So Fenton reaction is just a reaction involving some of those metals, which explains the reason why they produce free radicals. So if somebody has iron overload, too much iron in the body, that's why too much iron in the body is not good. The iron can combine with hydrogen peroxide, and it will be oxidized from Fe2+ to Fe3+, and in the process, hydrogen peroxide is going to be reduced to hydroxyl free radical. Can we see this equation? Do we get this equation? But can we appreciate it? We don't need to know if it's balanced or not balanced, but we can appreciate it, right?
Yeah.
So ion combine Fe2 plus combined with hydrogen peroxide, and it is oxidized to Fe3 plus, and in the process it generates OH minus. So that is Fenton reaction. The same thing can occur with copper, but instead of copper to be Fe2 plus, copper is going to be Cu plus, and it's going to be converted to Cu2 plus and hydroxyl free radical. That is your Fenton reaction. Now, we are going to talk about the clinical significance of that shortly. Then the last is the oxidative burst. So we know this one from immunology. I know everybody will, if I start asking people now, they will go to town with oxidative burst. So everything starts with what? What is the starting molecule in the oxidative burst?
NADPH.
Yeah,
Oxygen.
NADPH. Exactly, oxygen. So NADPH, act on oxygen, converting it to what?
Hydrogen oxide.
Hydrogen peroxide.
O2 minus.
O2 minus.
We have used this thing to chop about. So like NADPH oxidase is going to convert the oxygen to superoxide, which is the O2 minus.
Yes, superoxide. Yeah.
Then what happens next? What happens next?
Then breaks to water and oxygen.
No, it has to go to something.
Superoxide to hydrogen peroxide.
Superoxide to hydrogen peroxide. And what is the enzyme involved?
That's myeloperoxidase.
Superoxide dismutase.
Yeah, so of course you have to name it with the starting molecule. So if you say you are converting superoxide to something, so that means superoxide, something. So superoxide dismutase.
Yes.
Right?
Dismutase.
So then catalyst will now come in and break down that what's it called? The
hydrogen
peroxide to to water. Yeah. So and there's a phase that you combine the oxygen now with chloride, to form hypochlorite. Is that what myeloperoxidase does?
Yes.
That pathway is even gray in my head. I can't remember the pathway again because you need it for, it's only for step 1. So I think myeloperoxidase not converted to HOCl, which will now destroy the bacteria. Okay, so we can see that process also helps to generate numerous free radicals. So oxidative burst, you cannot forget. So the key ones there, oxidative burst, the transition metals, and radiation exposure, and of course, drug metabolism. They are very important. Drug metabolism, just remember your acetaminophen. Radiation, your transition metals, and the oxidative burst. Now, how do we eliminate these free radicals? Because all these things we have talked about kind of happen day to day. You cannot stop oxidative burst from happening. It happens. We cannot stop, we cannot eliminate all the iron in our body. Of course, we have little copper, little iron. What we are even using to eat contains copper. So definitely there will be some rudimentary copper in our blood. So, and all these things are going to be generating free radicals. And we even need copper to help us catalyze some of the reactions in our body. Copper is a very excellent cofactor. So we need it. So, but at the same time, they can also be generating free radicals that could be toxic. So there's a way God has designed some, mechanism to also help us eliminate those free radicals. So number 1, they can undergo spontaneous decay. They just decay, bam, spontaneously, and they leave. Or they can be eliminated by scavenging enzymes. So, there are some scavenging enzymes in the body, like catalase. So catalase is there to scavenge for any potential what? What will catalase destroy? Any potential what?
Microorganisms.
No. What does catalase break down?
Hydrogen peroxide.
Hydrogen peroxide. Yes. Hydrogen peroxide. Exactly. So catalyst is always scavenging for any potential hydrogen peroxide to break it down into water and oxygen. So it's a scavenging enzyme. Superoxide dismutase 2 in its own stuff is kind of ambiguous. So superoxide dismutase can generate, and at the same time it can help us eliminate. So it eliminates in terms of the fact that it helps to convert the superoxide to hydrogen peroxide. But hydrogen peroxide is still, a free radical. So that's why I'm saying that it can generate and can eliminate. So it helps to eliminate because once you have your superoxide being converted to hydrogen peroxide, you can easily degrade the hydrogen peroxide, into water and oxygen by the activity of catalysts. So they work together. Do we understand that?
Yeah.
Then the last one is a glutathione peroxidase. So this one is very simple. You have to know this reaction. Very important. Not that you have to know the reaction, but you need to understand what each of these parameters stand for. They can ask you your exam. Arrow question. They like asking this thing. Arrow question. So superoxide glutathione peroxidase is an enzyme that oxidizes what's it called? Glutathione. So it will convert reduced form of glutathione, which is GSH, that is reduced form of glutathione, to GSSG, that is the oxidized form. Let me tell us the clinical significance of this. You see, this is hydrogen peroxide. It is a free radical. What form of glutathione do we think we need to eliminate free radical? Is it reduced form or oxidized form?
Reduced form.
Reduced form.
Reduced
Reduced
form.
form. Exactly. So it means that reduced form of the hydrogen peroxide, reduced form of glutathione, the reduced form of glutathione, when it is combining with a free radical like hydrogen peroxide, it must be converted to its oxidized form. Do you understand?
Yeah.
Which is a GSSG. So, and you need an enzyme to do that for you, which is where your glutathione peroxidase will come in. So, glutathione peroxidase will catalyze conversion of glutathione from reduced form to oxidized form so that it can help us neutralize, the hydrogen peroxide to water. So, if you calculate the oxidation state now, you will have seen that as we are oxidizing glutathione to GSSG, we are reducing what's it called? Hydrogen peroxide to water. But we are not doing chemistry. We don't need to palm all those things. It's not relevant. Just know that once you see GSSG, you know that this is oxidized form of glutathione. Once you see GSH, H there means it is reduced. And that is the form that you need. Please don't joke with what I've said. You will see it in your exam. It's very important though. Very, very important. So, and glutathione is the enzyme that will help you with that reaction. Now, the next one are the antioxidants. So you need to take a lot of antioxidants like vitamin A, vitamin C, vitamin E. They help us mop out the free radicals, the antioxidants. They prevent oxidation by free radicals. Then, some certain metal carrier proteins, they are protective. Transferrin and ceruloplasmin. Why? Because once you have transferrin will help us transfer the ion maybe to the macrophages so that they will not be available for the microbes to use for Fenton reaction. Ceruloplasmin is also going to bind to copper, mop out the free coppers, so that copper will not be available in the blood to be utilized by microbes, or to be freely combining with hydrogen peroxide to generate free radicals. Do we understand that? Is that clear to us?
Yes, it is.
Okay. Now, moving on to the examples of free radical injury. So the first is oxygen toxicity. Now, if we expose somebody to too much oxygen, the problem is what? Generation of free radicals and injury to that person. So a very good example with respect to oxygen toxicity is going to be the preterm babies. Don't forget. So if somebody tells you, explain, how oxygen toxicity can lead to free radical injury, just remember your preterm babies. They are the ones that we have to bombard with a lot of oxygen. They take a lot of oxygen because of, neonatal acute respiratory distress syndrome, and you need to place them on oxygen for a long time. So what will happen? If you give them too much oxygen, what is going to happen is that there's going to be suppression of production of vascular endothelial growth factor. Now, anybody have an idea of what vascular endothelial growth factor is normally does from the name?
Angiogenesis.
Exactly. Angiogenesis. Exactly, angiogenesis. Now, if somebody is taking a lot of oxygen, do you think the person will need angiogenesis? Because the end result of you doing angiogenesis is because you want to deliver more blood flow and oxygen, right? So we are giving somebody already high amount of oxygen. Do you think there's a need for angiogenesis?
No.
No. So what will happen to the level of vascular endothelial growth factor production? It's going to be high.
Reduced.
It's going to be reduced.
Reduced.
So when it's reduced, it means that you will not be able to form good vessels. So there's going to be abnormal vascularization. So particularly in the eye, so they suffer retinopathy of prematurity due to abnormal vascularization in the eye. So you notice that the vessels that they will be forming is going to be weak. It's not going to be well formed, and they can easily leak, leading to bleeding, hemorrhage. So that's, retinopathy of prematurity is one of the consequences of oxygen toxicity and free radical generation. So the free radicals, the high oxygen is going to suppress production of vascular endothelial growth factor receptor, which is going to lead to weak vessels and bleeding. The next one is bronchopulmonary dysplasia. So the high oxygen that you are bombarding that baby, the more the oxygen, the more the tendency to form free radicals, and these free radicals are going to be causing insult to the developing lungs. So the lungs are not going to be well developed, so causing bronchopulmonary dysplasia. They'll just tell you that they did X-ray. They just saw that the lungs are very tiny in a preterm baby. That is bronchopulmonary dysplasia. Just want to ask, has this baby been on long-term oxygen therapy? Yes, you see, that is the reason. Reperfusion injury after thrombolytic therapy. I'm sure that we understand this now, right? Hello,
Yes.
we're not talking, Do we understand this one now?
Yes.
So there's no need to explain that one. So drug and chemical toxicity. So this is a very good example of free radical injury too. And I've talked about acetaminophen overdose causing hepatotoxicity. So because acetaminophen will be metabolized to NAPQI, which will be coupled to generation of free radicals that are going to be destroying the liver. As simple as that. Then the second example is exposure to carbon tetrachloride. Now, this carbon tetrachloride, watch out for it. If somebody is exposed to carbon tetrachloride, what will happen is it's going to be metabolized by the cytochrome P450 to CCl3 free radical. Now, this is going to now cause the three things: the lipid peroxidation, protein modification, and DNA breakage in the hepatocytes. Now, all these things are going to lead to destruction of the hepatocytes with which form of cell death do we expect?
Coagulating.
No, we are giving. See, look at it. Look at what I said. So somebody takes CCl4. That CCl4 is converted to CCl3 free radical. CCl3 free radical is now causing membrane lipid peroxidation, DNA modification, and DNA breakage. So, what form of cell death do you think is going to be provoked?
Apoptosis. Necrosis.
Apoptosis.
No,
What form of apoptosis?
They will
Which
take
stage?
them off.
Which form of apoptosis? Which pathway is it going to follow?
Intrinsic?
Intrinsic.
No, extrinsic. Okay.
No, it's not going to be extrinsic. Why is somebody saying extrinsic? Extrinsic is for which one?
It's a fringe.
Negative selection.
That is the fast and
That's like that.
Yeah,
fast
and they
ligand.
are utilized by which cell? I mean, the CD8 cells only. But
Yeah.
if it's something related to DNA injury, toxin exposure, radiation, like we explained, it's going to be intrinsic. But if you are talking about maybe negative selection in the thymus, we talk about death receptor pathway, or if the cytotoxic T cells wants to eliminate virus or cancer, they will use their granzyme. That's it. But anything else, intrinsic. So we cannot pick coagulative necrosis here because there's no ischemia. We are not talking about any ischemia here. There's no blood flow that is reduced. This is toxin, So the fat cells, the hepatocyte are going to undergo, apoptotic degradation. Now, what will happen? If the hepatocytes are dying, what will happen to, production of protein? The liver produces protein normally. So protein production is going to be reduced. And which particular protein are we talking about? The apolipoprotein. Now, when there's a drop in the level of the apolipoprotein, it means that there's no protein to receive the VLDL, because VLDL is an important component of triglycerides, right? Do you remember that from biochemistry?
Yes.
So that means that you cannot, form the VLDL and other things like that. So all those fats, they are going to accumulate in the liver, so causing a fatty change in the liver. And the pattern of the necrosis is going to be centrolobular, meaning that the zone of the liver that is affected is what? The central area. And anybody knows why it's going to affect the central area? Anybody knows why?
It's more
Yes, because
High energy.
No, we explained it.
because metabolically active.
Yeah, so because the cytochrome P450 is highest at the central area, so it means that at that point you're having a lot of CCl4, which is a carbon tetrachloride, being converted to CCl3. And the more the CCl3, the more the damage to the hepatocyte and the more the fatty change. That is it. So it's because of the concentration of the cytochrome P450 in the central area. Then the last one is the metal storage disease, like hemochromatosis and Wilson disease. So in hemochromatosis, you have overload of iron. In Wilson disease, you have overload of copper. So of course, how are these guys going to generate free radical? Fenton reaction, and they are going to be causing damage. So Wilson disease, you expect injury to the descemet membrane of the cornea, causing which rings? The Kacher, Fleischer, blah, blah rings.
It's a Fleischer ring.
So which other organ is also affected? Which other organ is affected in the Wilson disease?
The brain.
The basal ganglia. So I'm just trying to revise with you so that all those information, are arranged, because that's what the USML is all about. You have to be able to interlink your knowledge. You don't compartmentalize it. That, okay, I'll just hope when I'm dealing with neuro, that's when I'll be talking neuro. When I'm dealing with no. So you have to be able to relate all those, information together. That's how you can appreciate them more. So hemochromatosis, the free radicals damage the liver cirrhosis, damage the bone, the joint, the gonads, the heart, the skin, the pancreas, and all those things. So moving on to ionizing radiation. Ionizing radiation toxicity. So this, can cause damage to DNA and also cellular damage. So we have said it. Ionizing radiation, once somebody gets exposed to ionizing radiation, the next thing that will happen is there's going to be radiolysis. And radiolysis is going to generate free radical. Anybody remembers? We have forgotten. So I said...
Can you repeat that again?
I said radiolysis is going to generate which free radical? So like, what is the radiation?
Hydrogen and superoxide.
Yeah, so it's going to split water into H plus and OH minus. So that is the hydroxy free radical, right? And that hydrogen free radical can do three things, which is what? Membrane lipid peroxidation, protein modification, and DNA breakage.
Okay.
So that's going to be the effect of the hydrogen free radical. The ionizing radiation can also damage the DNA, can also break the DNA without need for producing free radicals. So it can do it directly, or it can do it by producing free radical. So it's going to damage the DNA, break it. It's going to cause lipid peroxidation, and it's going to cause protein modification by denaturing the protein, and also causing protein misfolding. So most of the common sources of ionizing radiation is maybe a patient is exposed to radiotherapy or all this Hiroshima stuff like nuclear reactor accidents. And what do you expect? So depending on the intensity, so if it's like localized, you can just expect localized inflammation and fibrosis. So you just see that area is reddish and it can be fibrosed due to an attempt to repair it. And in some situations, you can have neoplasia. So because of the double strand breaks. So if there's a break in the DNA, that could lead to some mutations in maybe proto-oncogene. And you can change, a proto-oncogene to like an oncogene. So we are going to get there when we get to neoplasia. Proto-oncogene is just like a gene that codes for like a growth factor. Like, not like growth factor, like a gene that allows for growth, right? So if you have a proto-oncogene changed to an oncogene, it means that it is now, proliferating uncontrollably. So that is when you say that, okay, your proto-oncogene has been changed to an oncogene. So let me give an example of a gene that codes for, let me say, epidermal growth factor. So epidermal growth factor is a proto-oncogene because it allows for growth of the epidermis. I'm just using that for an example. So if you have a mutation in the gene that codes for that epidermal growth factor and it becomes mutated, it can be, proliferating uncontrollably. Sorry, 1 minute, guys. I'm so sorry. So please, if there's any area that is not clear to us, please feel free to drag me back. I'm going to explain. So because all these things they are like related to one another. So if we get lost at one point, it might be very difficult to understand, the next thing that I'll be explaining. So if I'm too fast, just try to let me know. I'm going to slow down.
Yeah, just curiosity. Can you be helping us with some questions, like after some topics, if you have some questions? I don't know if you're forgetting or just you don't.
There's a question here. It's just that I don't have, much question on the ischemia part, but once we understand this, I'm just going to show us some questions. Once we get the gist, we can go to our UWorld and solve as many as we can. So the questions are not very technical. Like once you understand the pathophysiology, you are going to be fine. So, but I have, I think I have some questions here. Yeah. So, okay. Yeah. So I was talking about neoplasia. So this ionizing radiation can also, lead to cancers due to the DNA break. And a very good example is leukemia and thyroid cancer, particularly the papillary form of thyroid cancer. So people with history of exposure to radiation, they can develop thyroid cancer, papillary thyroid cancer. And there's also something we call the acute radiation syndrome, which usually develops after a whole body exposure to high doses of ionizing radiation. And this is because the ionizing radiation causes breakage of DNA, just like we know. And the cells that are more susceptible to this DNA breakage are the cells that are rapidly dividing. Because we know that if a cell is rapidly dividing, it means that it's rapidly undergoing DNA replication. So at that form, they are highly susceptible to the DNA breakage. And once there's DNA breakage, what form of cell death pathway is going to be activated? Anybody remembers?
Apoptosis.
Yeah, so the apoptosis pathway, which is the mitochondrial pathway, the intrinsic pathway.
Yeah, intrinsic.
So now, we know from our immunology, we know the rapidly dividing cells. So it includes the hair, the skin, the GI, the gonads, right? So that individual is going to be having apoptosis of the cells in these organs. So provoking nausea and vomiting because of loss of cells in the GI, and also diarrhea. They would start experiencing hair loss, erythema of the skin, cytopenias because of the cells in the bone marrow. They are rapidly dividing too, and there's going to be cytopenias and headache and altered mental status. So this is more like a neurologic side effect of the high exposure. So that is acute radiation syndrome. So if you tell us somebody starts, developing headache, nausea, vomiting, after high radiation exposure, you have to think of acute radiation syndrome. So they can ask you, what other injury or what other complication do you think this individual can develop? So just pick something like hair loss, cytopenias, or anything related to what we have discussed. So I've mentioned this fact, which is the rapidly regenerating tissues like the skin, the bone marrow, the GIT tract, the gonads, they are the ones that are more susceptible. Why? Because they are actively replicating their DNA, they are actively dividing, and we know that radiation is going to cause radiolysis with generation of free radicals, like hydroxy free radicals. So the hydrogen free radicals and the radiation itself can both break the DNA. And once the DNA is broken, it is going to label those cells to be killed off by apoptosis. So that is that. So the radiotherapy can also damage the cancer cell. Of course, that is a therapeutic utilization of the radiotherapy. It can also help us, even though it's going to affect the regenerating cells that are normal, it also helps to take care of the cancer cells. So because cancer cells have a dysfunctional DNA repair mechanism. So we are going to talk about neoplasia, and I'm going to talk about this. But I'm sure that we remember from our biochemistry some of the DNA repair genes. Anybody remembers anyone? DNA repair genes from biochemistry.
We have the repeat.
Are you talking about
Homologous and non-homologous.
non-homologous?
If it's single, if it's
No,
double
for
or
double,
single,
then
yeah, for double,
singles,
then single is nucleotide.
mismatch.
Mismatch repair.
And
So which one is single? Which one is single?
Single stranded are the mismatched ones.
that's the
Okay.
nucleotide repair or base excision repair.
Or base excision, yeah.
Okay, so what disease can develop from single?
We have zero
Xeroderma pigmentosa.
Then we have
Then Lynch syndrome.
Yeah, Lynch syndrome.
Okay, what we are talking about is more like nucleotide like excision. No, that's not what we are saying. We are talking about break. We have already talked about, we have limited it to break. There's a break, right?
Okay.
So we said, single or double, right?
Okay.
So the single, I think there's a part of biochemistry that talks about that single break. Or am I the one that is forgetting that stuff? Which one is ataxia telangiectasia?
That's the double. That's the
non-homologous and joining.
Non-homologous.
Non-homologous. So you just join it end to end. It's not accurate. You just
Yeah.
join it end to end.
Yes.
Yes.
That's correct. That's correct. So why the homologous one that you have to form like a backbone?
Like two
The
organs.
breast, the
Ovaries, paired
yeah.
organ.
So that's the BRCA. My point is, nobody mentioned BRCA.
Yeah.
So BRCA is, the DNA repair gene. Very important. So people that have BRCA mutation have a very high problem repairing DNA breaks. So they can develop ovarian cancer, they can develop breast cancer. So now, let's say that somebody has the breast cancer or ovarian cancer now due to BRCA mutation. So it means that once you expose that person to radiotherapy, the radiotherapy will further induce breaks in other part of the cancer, and they will label them for apoptosis and they will be eradicated. That's it. Now, if that cancer was normal, was healthy, once that radiotherapy comes and it induces the breaks, because of the fact that they are healthy, they will be able to repair the breaks and they'll be fine. But because they are already cancerous, and the pathophysiology of their cancer is that they have a problem repairing DNA breaks. So that means that once you come and you use radiotherapy to induce some breaks, they will not be able to repair it. And once they cannot repair that break, the body is going to flag them out for apoptosis, and they are going to be eliminated. Does that make sense to us?
Yes.
Yes.
So
Yes.
what I've said,
I don't really get when you mean healthy cancers. Like, I was lost at that point.
okay, you know what? This is just a little advice. You see, some of these things they were explaining, if there's a way we can be noting them down, it's going to help us. Because the information can be volatile. So I'm going to explain it again. So what I'm saying is that, you know that breast cancer can develop from BRCA mutation. So BRCA mutation meaning they have problem repairing their DNA, right? So now we now want to treat that cancer. So what are we doing? We're exposing the person to radiation. I'm now saying that, okay, if we expose a normal person to radiation, a normal person, the person does not have cancer, the radiation can induce a DNA break. But there is a mechanism that's already been designed by God to repair the DNA breaks, which could be homologous repair or end-to-end joining, right? You are going to repair the breaks and the person is going to be fine without any problem. But if you expose somebody with cancer from BRCA mutation to radiotherapy, the radiotherapy is going to induce a break. But because of the BRCA mutation, they cannot repair the break. Doc, do you understand what I'm saying now? Is it clear?
Yeah,
So
I
if
got
they
it.
cannot repair the break, what will happen? The body is going to label it that, this one has to go by apoptosis, then it will be eliminated by apoptosis. That is it. But the reason why they can develop cancer from the DNA, from the inability to repair DNA break is because if they suffer, maybe, I don't know, probably let's say that they are replicating, the breast cells, they are replicating normally. And in the process of the replication, there's error. There is how do I explain this now? Okay, let me say that. An individual inherits a BRCA mutation from, our mother. Now, the BRCA mutation means that if the breast cells of the daughter are replicating and they develop a particular mutation, they cannot repair it. Now, let's now calm down here. If that mutation affects something like a tumor suppressor gene, then there will be problem. So they are replicating their DNA. There's now mutation affecting a tumor suppressor gene. For example, maybe like TP53 or retinoblastoma or there's so many tumor suppressor genes. It means that individual is going to have a problem suppressing tumorigenesis, and there's going to be free channel for tumorigenesis to occur because you have a BRCA mutation that cannot repair a DNA break. I know that it sounds very complex, but I don't know. Let me just try to explain it with a drawing. So let's say that this is a breast. These are like sequence of DNA, maybe B, A, what's it called? A, C, G. I'm finding it very difficult to write with this thing. So C, A, let's say that this gene now codes for a tumor suppressor gene. ACGCA. It codes for a tumor suppressor gene. Now, this individual is now replicating. This individual have acquired a BRCA2 mutation from the mother. The BRCA2 mutation is there, but the person doesn't have breast cancer yet. Now, if this individual is replicating this sequence of this DNA, and suddenly, maybe due to one error, there's like maybe a break in the DNA. There's a break. Now, ideally, if this person doesn't have BRCA mutation, the person can easily come and repair the break, and everything will go fine. But because of the fact that the person already has a BRCA mutation, they cannot repair the break in this tumor suppressor gene. So what do you think will happen to the function of this tumor suppressor gene? Will it be lost or it will be retained? Anybody?
It will be lost
It
because
will
they
be
can't
lost.
repair it.
It will be lost. Now, when you lose the function of your tumor suppressor gene, what do you think will happen?
Cancer.
The tumor will grow.
That's it. So that means that you'll not be able to regulate your G1 to S phase again. And you just have your cells entering G1 to S, you're just replicating abnormally, leading to tumor regenesis. So I'm just giving us a background, because once I get to cancer stuff now, I don't want it to be complex to us, so that we'll be able to understand fast and quick. So that is it. So that's how cancers develop. So moving on to the type of hope I have explained this. No, I think am I done explaining this? No. So radiotherapy damages cancer cells more than healthy cells, because cancer cells have dysfunctional DNA repair mechanism in addition to high replicative rate. Yeah. So I have said it. So they said because cancer cells have dysfunctional DNA repair mechanism, so that is why they are more susceptible to radiotherapy injury. And I gave example of a cancer that has problems with DNA repair, which is what? Which example of cancer did we give?
BRCA.
So if somebody has BRCA problem and you expose them to radiotherapy, because of the BRCA mutation, they will not be able to repair that DNA break, and they will be labeled for apoptosis and they will be eliminated. So that is how radiotherapy can be useful. So moving on to type of calcification. So don't forget, they have stated the point here. Calcium deposits appear deeply basophilic. We have said this when we are talking about which type of necrosis. Anybody remembers?
Was to do with the pancreas.
Fat necrosis. Fat necrosis.
What was your question?
So I said calcium deposits appear basophilic, and I said we stated this point when we were talking about one form of necrosis, fat necrosis. So there are two forms of calcification: the dystrophic and the metastatic calcification. The dystrophic and the metastatic calcification. I think I have a question here before I go further. Let's just quickly solve it. An 84-year-old woman comes to the emergency department because of lower back pain and lower extremity weakness for 3 weeks. Over the past week, he has also found it increasingly difficult to urinate. He has a history of prostate cancer, for which he underwent radical prostatectomy 8 years ago. His PSA level was undetectable until a routine follow-up visit last year, where it began to increase from 0.8 to 64. And normal should be less than 4. An MRI of the spine shows infiltrative vertebral lesions with collapse of the L5 vertebral body, resulting in cord compression at L4 to L5. This patient receives 1 dose of intravenous DEXA and subsequently undergoes external beam radiation. Which of the following cellular changes is most likely to occur as a result of this treatment? Anybody? So we have oh my God, the options is not complete.
Please, can you enlarge the question?
Yeah,
we can hardly see it.
No, I have a problem. I'm not sure the options are complete. The options are not complete.
The answer isn't there.
Yeah, the answer is not there. Okay. But I know the answer. The answer should be what? Okay, what do we think that the radiation will cause?
The
DNA
DNA
break.
radical.
Generation of hydrogen.
DNA breakage, right?
The DNA. Okay, no, the answer is there.
Yeah.
Oh my God, the answer
Is
is
it
there.
not a generation of hydrogen radical?
Yeah,
Yeah, D.
generation of radical.
There are two
Yeah.
methods. You told us two.
I'm so sorry
So
about.
we're looking at the radiation, not the dexamethasone. Okay.
Yeah, the radiation. So generation of free
Let's see.
radicals. So sorry. Thank you,
Radical.
No,
doctor,
they
for.
said which of the following cellular changes is most likely to occur as the result of this treatment?
Mhm.
The treatment with Dexa now, right?
No, no, no.
Radiation.
No, the radiation.
Oh,
Radiation.
okay.
And subsequently
Okay.
undergoes external brain radiation. So
Oh, okay.
so what is going to be the effect of the hydroxy radicals? So what did they do? What will the
They'll prevent
They
they'll
would
cause
need to DNA break.
I would
hydroxyl.
need to generate strand
they will
breaking,
cause DNA break. What else?
lipid peroxidation,
Lipid
And
peroxidation
And the natures the protein.
Protein
protein
modification.
modification
and protein
and
mod.
DNA
Those
breakage.
are the three
linking of
things. Those are the three things I
proteins.
want us to be hammering: the lipid peroxidation, the protein modification, and the DNA breaks, because they can
Break.
put the any one of the three in the option. It's still going to be the effect of the free radical. So very, very important to understand that. Always link it to those three things. Yeah.
So the DNA breakage is done through the free radical, through the
It can be
process of
done.
free.
It can be done through the free radical or without them.
Okay.
Yes. So so moving on to
Did you
classification.
say lipid peroxidation?
The what?
Lipid.
Yes, lipid peroxidation. Yes.
Lipid peroxidation. This is it here. Lipid peroxidation.
Membrane lipid peroxidation and denaturation.
So very, very important. Very, very important. So moving on to the classification, the dystrophic and the metastatic classification. They like testing these things, but it is very simple. All what you just need to look out for is that what is the underlying cause of the classification? That is your own assignment. What is the cause of this classification? That is how you are going to know the parts. So in dystrophic classification, you're having calcium being deposited in diseased tissues. So they are not healthy tissues. They are already diseased. Maybe there's already a necrosis or there's infection somewhere. That's allowed for that calcium deposition. For metastatic classification, they occur in normal tissues. For dystrophic classification, it is localized to that diseased segment. For example, an individual with aortic stenosis can have calcific aortic stenosis. While for metastatic, it is widespread. So affect the entire organ. So what are the causes of dystrophic calcification? Anything that can cause necrosis. Liquefative, coagulative, fat, any of the necrosis, they can get calcified. They can get calcified. Although it's very, very common with fat necrosis. Infection sites can get calcified. So people with infections like toxoplasmosis, rubella, all this chronic infection, schistosomiasis, tuberculosis, they can have some form of dystrophic calcification. Even atherosclerotic plaques can get calcified. So CREST syndrome, calcinosis is part of the C of CREST syndrome. So calcification can happen there. Now, the one that gets a little bit confusing is the metastatic one. So we've said that it occurs in normal tissues. So we need to understand all these things because the US7, they can be wicked. They want to test that understanding. It will just give you a scenario of someone that has, a particular cause of metastatic calcification, and they will ask you that, what do you expect in the tissue? Normal tissue. They can say that, fat necrosis, something necrosis. Anybody that doesn't understand that metastatic calcification occurs in normal tissue, we fail that question. So, metastatic occurs in normal tissue. They are not disease. They are normal, right? And the calcification is widespread. If it happens, it will happen to the entire organ. So, what are the organs that are susceptible to metastatic calcification? Now, once acid leaves, calcium enters. So they go opposite ways. Acid leaves, calcium replaces. Acid leaves, calcium will replace. So any tissue, any organ that is actively losing acid, H+, can, have metastatic calcification. For example, the kidneys, number one. We know that, what is the function of the intercalated cells of the kidneys? Anybody knows? Intercalated cells in the DCT. What do they do?
Intercalated cell.
Aldosterone.
They
what-
like for this like where the hydrogen leave the cell and stuff.
Yeah. So in the intercalated cell, you have secretion of hydrogen, right? In the parental cells, you have reabsorption of sodium and secretion of potassium. Do we remember this thing? Principal cells, rather.
Right.
Doc, can you repeat it? You said
Is it in DCT or collecting dots?
No.
Okay.
It can be DCT collecting dots. Both of them have principal cells and intercalated cells. The late DCT and the collecting dot, they have principal cells and intercalated cells. So what is the function of the principal cells?
That's where the ADH and the aldosterone works.
It's where the
insertion of the V2 channels.
The aquaporin channels.
No. Aquaporin is in the collecting dots. Down. What I'm saying is where the aldosterone works. Aldosterone works on the principal cells and the intercalated cells.
Yes.
Aldosterone on the principal cells absorbs sodium, secretes potassium. In the intercalated cells, it secretes proton in exchange for potassium, but just focus on the proton secretion. Very important. That is why it can cause metabolic alkalosis and hypokalemia, right? Aldosterone can cause hypokalemia and metabolic alkalosis. Why we?
Yeah.
This is it's like it's strange to us. Is it strange?
No.
It's not strange. We are trying to remember and put the whole thing together.
Okay, so sorry about that. So, but don't forget the principal cells and the intercalated cells. They are sites where aldosterone works, and you have to know what they do. Very important.
Doc, please, not to take you back in the principal cells. You said they secrete sodium.
No. Aldosterone likes taking in sodium. Aldosterone brings in sodium, right?
Okay.
Into the body. It secretes potassium in exchange for the sodium. And in the intercalated cells, it secretes proton, H+, right? It secretes H+. So that is why
they are losing hydrogen.
Yes, they are losing hydrogen. So that's why they can, be a potential site for calcification. The gas Hello?
Yeah, I said, and potassium also follow hydrogen.
Yeah, potassium also is being secreted. Yes.
So, Chief, can we just say it's a site where the sodium and potassium levels are regulated? Can we just
Yes, it's correct. Sodium and potassium levels are regulated in the principal cells. Yes, that's correct. That is correct.
Where is ENaC? Is it the same thing?
ENaC is early DCT. ENaC is also one of the is in the DCT2 and is one of the receptor that aldosterone also hacked on. So it helps to reabsorb sodium primarily, not coupled with anything. Do you understand?
Okay, not collecting that. Okay.
So just reabsorb sodium. That's what the ENaC is all about. So we have epithelial sodium channel blockers. What agent are those ones? What drugs? What drug is an epithelial sodium blocker?
Triamterene and amiloride.
Triamterene and amiloride.
Exactly. So, and we have the ones that, aminocorticoid receptor antagonist. What is that one?
Spirulactone and epinephrine.
Exactly. What is peculiar to all these two drugs?
Aldosterone antagonist.
They are potassium sparing. There's no
Mm-hmm.
potassium sparing. So it makes sense that if something is absorbing sodium and secreting potassium, and you block it, and it's not able to secrete the potassium again, and potassium is being conserved in blood, you can call it potassium sparing. That's it. That's why you are calling it potassium sparing, because it doesn't allow for that exchange again. Ideally, aldosterone should be there to reabsorb the sodium and secrete the potassium. But once you block the aldosterone, there's no way it can secrete potassium again. Potassium is in the blood. So it's potassium sparing. That's it. So
just want to clarify where you said the intercalated cells were.
Intercalated cells. You see, there's something about the intercalated cell I'm trying to avoid to mention because I don't want to create confusion. So the only thing I just want to say for intercalated cells, just know that is a point where hydrogen is being secreted. That is the only thing I want to say there.
Oh, okay.
That is a place where hydrogen is being secreted. In the principal cells, sodium is being reabsorbed and potassium is being secreted. Okay. So aldosterone secretes two things, hydrogen and potassium. So, but different cells. Potassium is being secreted in principal, hydrogen is being secreted in the intercalated cells. So, gastric mucosa, they can lose acid. Acid is, in the gastric mucosa, they can lose acid either maybe from, carbon monoxide, from what's it called? Vomiting, or maybe from CO2 diffusion, or whatever way. So they can lose acid because they are very rich in acid. And again, the parietal cells in the gastric mucosa can secrete H+. We remember that it has the proton ATPase pump, right? Do you remember that? And it can secrete H+. So they can lose acid quickly. The lungs can lose acid because we in our breath we expire CO2. So CO2 is being moved out of the lungs, and that is a form of losing acid. So all these three structures, the kidneys, the gastric mucosa, and the lungs, are channels where we can lose acid, and they favor calcium deposition because of the increased pH. If you lose acid, that means you have more base. pH is going to be high, and can favor calcium deposition. So all this stuff can favor calcium deposition, and if you have calcium deposit in the kidney, that can lead to nephrocalcinosis, right? Leading to nephrogenic diabetic insipidus and renal failure. What is nephrogenic diabetic insipidus? I don't want to assume that one too.
So when
that's resistance.
Receptors.
So what are the causes? I know Dr. Obande, what are the electrolyte derangement that can cause nephrogenic DI?
Sodium.
Sodium? No. We have mentioned one now. We have mentioned one now from our lecture now.
The proton.
No. What is the proton that you are losing is going to cause?
Hydrogen ion.
Metabolic alkalosis.
Okay.
Metabolic alkalosis.
But what is the end result of everything? From what we have seen, from the topic of discussion,
we're losing sodium.
Calcification.
Okay, so you're losing the blood of
calcification, hypercalcemia.
Okay.
Hypercalcemia is the cause of nephrogenic DI, because of calcification of the renal tract. So if the ducts are calcified, they are not going to be responsive to ADH. So that is the take home. Here, all this acid exchange, I'm just trying to explain how the acid can live to allow calcium to come in. Calcium is a major concept. Don't forget, what we are talking about is calcification, please. Calcification is what we are talking about. So, hypercalcemia is a cause. That is why if you go to your renal, you will see it there. Hypercalcemia is mentioned as one of the causes of nephrogenic DI. Another thing is there again. There's another electrolyte derangement.
Hypokalemia.
Hypokalemia. That's the way you can palm all these things. Me, I just know that, okay, hypercalcemia is there. And I just look at, okay, how can I relate it with hypokalemia? Okay, just reverse it. So if there's hyper one, there's going to be hypo of the other. Hypokalemia, hypercalcemia. Then now start talking about other things, other drugs. Drugs like what?
Lithium.
Lithium. You know, the information is a lot. So we have to find a way to compartmentalize all those things. So nephrogenic DI, because of the calcium deposit.
I got lost when you mentioned the hypokalemia. I understand the hyperkalemia being the cause of nephrogenic DI.
Yeah.
How come we put, what's the hypokalemia all about?
So the pathophysiology of hypokalemia might not be very, very well explained. There are different school of thought. But me, I do not worry myself, looking for it because there's so many things to learn. So that's what I'm saying. Like, I just know that, okay, hypercalcemia can cause it because of the deposit, and I just do the reverse. So if it's hypercalcemia, it's going to be hypokalemia. Do you understand, Doc?
I see.
So
Thank you.
Because that area of diabetic insipidus is a little bit tricky. If you look at the treatment too, it's paradoxical. You are using diuretic to treat it. I should have asked that question. What is the treatment for diabetic?
Thiazide, indomethacin,
exactly.
Amiloride.
So there are different schools of thought. There are different schools of thought for the explanation, but me, I do not, because USML is not really written, and you cannot know everything. There's a lot of information. So, there are just some things you just have to leave unexplained, because if you want to start reading that explanation it's a little bit complex. It's paradoxical. So that's that. So the etiology is secondary to injury and necrosis for dystrophic, and for metastatic, just think about anything that can raise the level of calcium in a normal, and that calcium is going to be depositing in normal tissues. So let me come back again with the explanation. The tissue that gets calcified in dystrophic, they are diseased, they are already injured, they are necrotic. The tissue that gets calcified in metastatic, they are normal. The kidney is just on its own, doing fine. The lungs are there, doing fine. The stomach is there, doing fine. The only problem, what's the word to say now? The only reason why they are at fault is because they lose acid. That is the problem. They don't have any issue. They are doing fine, but the only fault is that they lose acid. That's why calcium is attracted to them. Now, what is that? What is the condition that even caused the calcium to be elevated in the first instance? So, hyperphosphatemia. So, if somebody has hyperphosphatemia, maybe due to CKD, secondary CKD, phosphate is notorious for chelating calcium. So, phosphate will just go and be binding to the calcium and be depositing it in all these organs, right? They can have hypercalcemia too from different causes. They can have hypercalcemia from hyperparathyroidism, from sarcoidosis, from hypervitaminosis. Anybody knows the reason why sarcoidosis can cause hypercalcemia? Anybody? Maybe that will save us time.
Because activated macrophages, they activate alpha-1 hydroxylase that now causes vitamin D that now causes PTH to activate the storage form of vitamin D to the active form, something like that. But the activated macrophages express alpha-1 hydroxylase.
Nice, fair attempt. But don't forget that vitamin D is 1,2,5-cholecalciferol, right? So the 2,5 form is produced from the liver. So
Mhm.
for you to complete it to 1 to 5, you need to hydroxylate it in the kidneys, right? So
Yeah.
once you hydroxylate it in the kidneys, it becomes 1 to 5, which is the active form of vitamin D. Now, in people with sarcoidosis, the granuloma that is formed there, the macrophages in the granuloma, they have one alpha hydroxylase activity. So that means that they can hydroxylate the 25 cholecalciferol form to 1 to 5 cholecalciferol, which is vitamin D. And the vitamin D will start stimulating the kidneys, the bone, the intestine to be reabsorbing calcium. And that's how they cause hypercalcemia. Do you understand? So we don't even have to mention PTH at all. PTH is not really involved. It's vitamin D straight. So don't forget. So the same thing for hypervitaminosis D. We've already explained that. So don't forget, hyperphosphatemia and hypercalcemia, these two conditions can cause metastatic calcification. And what are the tissues that are affected? Tissues that lose acid, like the what? The lungs, the stomach, and the what? The kidneys. Right?
Yes.
Okay. So moving on to Samoma bodies. Let me see, I think there's a question here. A 36-year-old man is admitted to the hospital because of one-day history of epigastric pain and vomiting. He has had similar episode of epigastric pain in the past. He drinks 8 bottles of vodka daily. 5 days after admission, the patient develops aspiration pneumonia and sepsis. Despite appropriate therapy, the patient dies. An autopsy of the pancreas shows gray, enlarged, nodular pattern. Microscopic examination of the pancreas shows localized deposit of calcium. This finding is most likely similar to an adaptive change that occur in which of the following conditions? Anybody?
Oh Lord.
Congenital CMV infection.
Fantastic.
Is it dystrophic?
Yes.
Okay.
That is
Yeah,
the next thing you
okay.
want to ask yourself. So this person died of what? What condition did the person die of? The person died of
Pancreatitis.
alcoholic pancreatitis. That you see, that's
Chronic
your assignment.
pancreatitis.
That is your assignment. What is the background? Okay, this person has alcoholic pancreatitis. The pancreas is injured. It is injured, Of course, it will be necrotic, fat necrosis, everything is there. So that's why calcium is depositing there. So this is a dystrophic injury. If you look at all the causes that they have here, they are what?
These ones are other metastatic.
They are metastatic. You can see there's no catch. It's not hard at all. And you pick your answer, you move. That's it. So
I'm not sure I get how it linked it here.
Okay, what was CMV?
Yeah, CMV is in dystrophic. And the cause was like mainly pancreatic deposition of calcium.
So the pancreatic deposition of calcium means that it's because the pancreas is injured. So that is a dystrophic calcification, right? So they're now saying that this finding is most similar to an adaptive change that can occur in which of the following conditions? That is, which of the following option 2 can cause a dystrophic calcification?
Right. Indirectly.
Hyperparathyroidism is metastatic calcification because it causes hypercalcemia, right? Same with CKD. What will CKD cause? Anybody?
Secondary
Hyperphosphatemia.
Hyperphosphatemia.
Yes.
Hyperphosphatemia that is going to chelate the calcium and deposit calcium. You see, vitamin D is going to cause hypercalcemia too. Multiple myeloma is going to cause what too?
Hypercalcemia.
Hypercalcemia. Don't forget the crab. Have we forgotten the crab? Don't forget the crab.
Crab.
So everything we have here is metastatic except congenital CMV infection that is dystrophic. That is it.
That's true.
So Samoma bodies. Samoma bodies are just concentric laminated calcified spherules or lesions, that are seen in tumors. You don't need to worry yourself. They are just like circular lesions that you see in cancers, which is due to calcium deposits. So if you see Samoma bodies, what form of calcification is this?
Dystrophic.
Calcification. Dystrophic. See, that is why you have it here. Samoma bodies. you can see that I do see. To be honest, when I went for my exam, I did not cram this thing. I did not cram anything that is here. I just understood the mechanism and I went for my exam. There's no need to be cramming. I can't cram everything that is there. I just need to understand the pathophysiology. That is all. You can't cram. You can't, because you'll be disappointed. You get to the exam and racking your brain. Even the tension in the exam, is too much to be forgetting something. So, but if there's tension, but you know that you just tell yourself, say your name, Adioba, calm down. Okay, this is calcification. Okay, so what does this patient have? Dystrophic. There's a disease. Okay, I'll pick dystrophic. Okay, there's no disease. This is CKD. I pick this because it happens. We can have that block. So that's why you now have to calm down and retrace, your pathophysiology that we have used to understand it. That is it. But if you are memorizing and your code disappear, there'll be problem. So that's why I try to encourage understanding, as much as possible. So for the Samoma bodies, the acronym is just the same word, Samoma, right? Don't forget they are concentric calcified lesions in tumors. So the P stands for papillary thyroid cancer, polyartinoma, or papillary renal cell cancer. So papillary thyroid, polyartinoma, or papillary renal cell cancer. You might not really need to really cram it. By the time you look through the option, you are going to pick it because it will be, once you familiarize yourself with those things, you know it. So the S is somastatinoma or the serous ovarian cancer. The serous ovarian cancer or somastatinoma. The A is adenocarcinoma of the lungs. The M is mesothelioma. So what is peculiar to mesothelioma? Anybody?
The pleural thickening.
Pleural thickening, yes. Yes.
And they have the carcinocarcinoid positive.
Yes, but the chance of you seeing
it's rare.
cytokeratin in the exam, it's not really. So you need something like that pleural thickening that you have said is high yield, pleural thickening, hemorrhagic effusion. Yeah, mesothelioma. What else? What would be the predisposing?
Asbestos.
Yeah. So asbestosis is the only cause of mesothelioma. True or false?
True.
False.
True.
So asbestosis is the only cause of mesothelioma. That is true. The commonest cancer caused by asbestosis is mesothelioma. True or false?
Okay, it's
bronchogenic.
So those are the ways they can wait for us. So they can put that the most likely cancer this person is going to develop. They will tell you that the person is a plumber, the person is a mechanic, the person is a roofing somebody, and the next thing is in the next 15 years, this person is most likely going to develop what cancer? Somebody will just rush and be mesothelioma, and they will come out more fucking here than but they don't know that they've made a mistake. So,
Doc, please, with the numerous response, I couldn't pick up the way you asked the second question, please. Can you repeat the second one? I got the one that asbestosis is the only cause of mesothelioma. The second one that you asked.
So I said that asbestos is the only cause of mesothelioma. That is true.
Okay.
That is true. Then the second question I had was the commonest cancer that is caused by asbestos is mesothelioma. So that is false. It is bronchogenic lung cancer, not mesothelioma. So we have to pay attention to that. I know Dr. Van must have hammered it. Then the next is the O, which is still the serous ovarian cancer. The next M is the meningioma. Meningioma. I'm sure they mentioned it in the neurology section. Meningioma. That's the Samoma. So P for polyartinoma, papillary thyroid, papillary renal cell. S for the somastatinoma, serous ovarian cancer, A for adenocarcinoma of the lungs, M for meningioma, M for meningioma, the other M for mesothelioma.
Mesothelioma.
The O for the ovarian cancer, the serous type. The M for the mesothelioma and the meningioma. The A for the adenocarcinoma of the lungs. That's Samuma bodies. You can see them. Look, once you see this image, concentric, calcified, body, think of Samuma body. Please, this is not the time to now be thinking of, because somebody will now quote me now and say that we said this is how fibrinous necrosis will look like. From the question, you also get the idea of what they are testing. They will not be talking about vasculitis here or talking about hypertension. So because they look alike, but once you say wall-like concentric stuff like this, Samuma bodies. Moving on to amyloidosis. Amyloidosis is very interesting. Once you see amyloidosis in your exam, just shout hallelujah, because you cannot afford to miss it. You will get it.
Amen.
Is too basic. I join you in prayers. Amen. So, and what is peculiar to amyloidosis? Amyloidosis is just a situation where you have misfolding of protein. Now, ideally, protein should be in they should have a secondary structure, and that secondary structure should be the alpha helix. So, in the exam, they will just give you a scenario of someone that has amyloidosis, and the next thing they will ask you is that what is the normal structure, or what is the abnormal structure? I'm giving you hints. They can ask you what is the normal structure or what is the abnormal structure. So the normal structure of a protein should be the alpha helix configuration. Alpha helix configuration. The alpha helix teaches you, tell your friends, don't forget it. Don't ever forget it. You can't afford to forget it. The alpha helix configuration is a normal, while the abnormal is a beta pleated sheet. So once a protein assumes the beta pleated sheet configuration, it becomes difficult to fold and it becomes difficult to degrade. It becomes an amyloid protein. That is it. That is amyloid. That is all. You are done. So they'll start accumulating in the tissues, and when they cannot be degraded, they'll just be like, okay, apoptosis, your package don't come and eradicate it. So if apoptosis is going to come and eradicate this, what pathway is it going to use? Anybody? Intrinsic pathway. There's no catch. Intrinsic pathway. So what are the organs that are affected in amyloidosis? The number one organ you cannot forget is renal. Amyloidosis is a cause of nephrotic syndrome. Once you are saying +3, nephrotic syndrome, amyloidosis. What else are you going to see in the question stem? I'm not going to list them sequentially like this. I'm going to list them according to the order of importance. So the nephrotic syndrome, the musculoskeletal features are very important. You are going to see macroglossia. They will tell you that the person is having a big tongue, macroglossia, because of the position of those amyloid proteins in the tongue. They can tell you that the person is having features of Carpenter syndrome. That's why you have to open your mind. Carpenter syndrome, macroglossia, due to amyloid deposit in those areas. Now, the finisher is now when they tell you that the skin is thick, waxy, and easily bruised. You tell them until otherwise proven. This is amyloidosis. Thickened skin, waxy, easily bruised, large tongue, Carpenter syndrome, nephrotic syndrome, amyloidosis. You know that it's kind of resembling hypothyroidism when they start saying macroglossia, Carpenter syndrome. But by the time you see nephrotic syndrome and a thick, waxy skin that is easily bruised, that is amyloidosis until otherwise proven. It can affect other organs too. Deposit in the GI, and they will have big liver, big spleen. Can affect the nerves, they can have peripheral neuropathy, particularly the transthyretin type, which I'm going to explain shortly. And it can also affect the cardiac. They are going to have restrictive cardiomyopathy. An individual with restrictive cardiomyopathy is going to have what type of heart failure? Anybody?
Diastolic dysfunction.
Diastolic
Diastolic.
dysfunction.
It's preserved.
So that heart failure with ejection fraction of 60, right?
Preserved.
No,
correct.
reserved.
Normal ejection fraction.
Reserved.
So
It's
60 is
preserved.
preserved. There's no catch. It's
Yeah.
correct. 60 is preserved. So that is amyloidosis. Now, how do you identify it? So you can do your Congo red staining, or with non-polarized light, or you can use polarized light. But you are going to see different things. So if you do Congo red staining, because of that Congo red staining, you can look at it with polarized light or non-polarized light. So if you apply Congo red stain and you are looking at it under non-polarized light, you are just going to see the red, which is a red or orange coloration. So if you are looking at the Congo red staining with polarized light, you are going to see apple green birefringent. So this one now, image A is which one? Is it polarized or non-polarized?
Non-polarized.
Non-polarized.
Polarized.
Then image B is polarized.
Polarized.
So they also talk about using H&E stain, seeing amorphous pink. It's not very common. Don't worry yourself. Now, what are the types of amyloidosis? Now, this is where they wait for us. So we have the systemic type and the localized type. So the systemic type affect different organs, right? And the number one cause of amyloidosis that you can never forget is the primary amyloidosis from multiple myeloma. So all those plasma cell dyscrasias like Waldenstrom, like multiple myeloma, in which you have abnormal proliferation of the plasma cells, they can cause amyloidosis. Why? Because when the plasma cells are proliferating, they'll be producing what? What does plasma cell produce? Immunology.
Globulin.
Antibodies.
They produce antibodies. They produce immunoglobulin. Yeah,
Immunoglobulins.
they produce immunoglobulin. Now, immunoglobulin have heavy and light chain, right? So when they become too much, you tend to discover that it becomes very difficult to fold and arrange that light chain. So they begin to assume this beta pleated sheet configuration, and in that way they are going to be transformed into amyloid protein. So you are going to have amyloid protein from the light chain of the immunoglobulin. So that is what you call primary amyloidosis. That's the commonest form. Plasma cell dyscrasia, multiple myeloma, Waldenstrom, macroglobulinemia. Now, the next one is the secondary cause. And don't forget the fibrillary protein. You are going to see AL. L standing for the light chain and A for the amyloid stuff. So that's where it is encoded, AL protein. So AL is telling you it's coming from plasma cell issue. And that's a primary amyloidosis. So for secondary, the protein that is accumulating is serum amyloid protein A. Serum amyloid A, SAA. This is an aqueous phase reactant that I'm going to explain shortly. And the fibrillary protein is called AA, not AL, AA. And this is the secondary amyloidosis. What are the causes of elevated SAA? Anything that can cause chronic inflammation because it's an acute phase reactant. So chronic inflammation like rheumatoid arthritis, tuberculosis, inflammatory bowel disease, name them. Your own assignment is just to look at the question. Okay, you have identified that this is amyloidosis. I've seen the features, but what is the cause? What does this patient have? We are seeing features like rheumatoid arthritis. This is secondary amyloidosis. We are seeing features of multiple myeloma. This is primary amyloidosis. It's as simple as that. Now, moving on to the next one. This is called the transthyretin amyloidosis. What is the fibrillary protein that is accumulating? Transthyretin. Now, transthyretin is otherwise known as prealbumin. So it helps to transport thyroxine from the name. Look at it. Transport thyroxine, THY, and retinol. That's what it does. So it helps to transport thyroid hormone. So it's like thyroid hormone binding albumin, and it typically deposits in the heart and the nerves. the heart and the nerves, the heart and the nerves. So if it deposits in the heart, it can cause restrictive cardiomyopathy. If it deposits in the nerves, it can cause peripheral neuropathy. So we have two forms, the sporadic form and the hereditary form. So the sporadic form is the wild type. It's just normal. It just happens suddenly, bam, no trigger. And it's usually associated with aging. It's like as you grow, it can develop. Why the hereditary? There's usually like a family history. So don't forget, both of them typically affect the heart and the nerves. Then the last one that you should not forget for systemic is dialysis associated amyloidosis. And what is a protein that misfolds there? The beta-2 microglobulin. The beta-2 microglobulin. So people that have been on dialysis for a long time, they find it very difficult to eradicate this beta-2 microglobulin through the filters. So this one accumulates in the blood and it starts misfolding and becomes amyloid protein. And it has affinity for depositing in the joint. So they just tell you somebody has CKD, underwent dialysis, and suddenly start developing shoulder stiffness or carpal tunnel syndrome. Beta-2 microglobulin is a cause. Beta-2 microglobulin is what? Is a cause. It can occur without dialysis and it can occur with dialysis. Once the child don't get that end-stage renal disease, they are highly predisposed to developing that amyloidosis. Then moving on to the localized form. So the number one is Alzheimer's disease. So many people don't know that Alzheimer's disease is a form of amyloidosis. It is. And the amyloid protein that is accumulating in them is what? Beta amyloid protein. That is what is forming the plaques. And it's cleaved from amyloid precursor protein. So you have a lot of this amyloid protein forming. They start misfolding because of their abnormal configuration, the beta plated sheets, and they start developing in the brain, depositing in the hippocampus and other areas. The next one is the isolated atrial amyloidosis. And the problem here is with aging, just like transthyretin. So with aging, you have increased level of AMP. What does AMP stand for? Anybody knows?
Atrial natriuretic peptide.
Atrial natriuretic peptide. And this peptide is in the atrium, right? So when it starts misfolding, it deposits in the atrium, and it can be a trigger for atrial fibrillation. That makes sense. Atrial fibrillation is a complication of isolated atrial amyloidosis. So the reason why it's separated as isolated atrial amyloidosis is because so that you don't confuse it with transthyretin amyloidosis, depositing in the heart too. So they are different things. Then moving on to type 2 DM. Type 2 DM is a type of amyloidosis too, because there's elaboration of amylin. A lot of amylin is being produced, and amylin is also known as islet amyloid polypeptide. And that amylin misfolds deposit in the pancreas, destroying the pancreas, leading to type 2 DM. The last one is medullary thyroid cancer. So people with medullary thyroid cancer overproduce a protein, which is calcitonin. Calcitonin too can start misfolding, and it becomes an amyloid protein and deposits in the thyroid gland, further causing more damage. So all these things are not things we need to cram. We just need to look at them, understand them, and once we see it in the exam, we know what they are talking about. So amyloidosis, Alzheimer's disease, diabetes, medullary thyroid cancer, and AMP. Then as well as the primary form, which is the plasma cell dyscrasia, the secondary form, which is related to the chronic inflammatory conditions, elaborating serum amyloid A protein, the transthyretin one, and beta-2 microglobulin for people with end-stage renal disease. And this one has a high affinity for depositing in the joint. Okay, let us look at one or two questions here. What is happening? Okay. A 66-year-old man comes to the physician because of fatigue and swelling of the legs and feet for 6 weeks. During this time, He has felt like the eyes have been unusually puffy in the morning and the urine has been fruity. There's hypertension and there's rheumatoid factor positive rheumatoid arthritis. Current medication includes amlodipine, methotrexate, ibuprofen. He does not smoke. There's history of use of alcohol. Temperature is normal, pulse is normal, blood pressure is elevated. Physical examination shows pallor, periorbital edema, pedal edema, and ascites. He has swan neck deformities and nodules on multiple fingers and swelling with restricted range of motion of bilateral knees. Okay, the protein is 3+. So this is the laboratory parameter. I don't think we need it. Ultrasound of the liver and kidney shows abnormality. Which of following is the most likely cause of this patient finding? Anybody?
So this is like chronic inflammation.
Rheumatoid arthritis, amyloid AA.
Amyloid deposition.
Amyloid AA deposit. Very simple. Okay. So I think.
Sorry,
yeah, I'm with you. I'm with you.
Yeah, which one was the amyloid AA among the options? I thought it was only AL that was there.
Yeah, serum amyloid A. Increased serum amyloid
There's
A.
AA.
Okay, there is. Okay, thank you.
Hey, brother.
So, moving on to inflammation. So, inflammation, we don't need to be reading all these things. So, the take home here is just that inflammation is a response that helps to eliminate the cause of an insult to a cell. It helps to remove any necrotic debris, and it helps to attempt repair. So, if there's an infection, inflammation is going to be made in response to that infection to eliminate the infection, to treat the damage that the infection have done. Maybe there's any necrosis, to remove it, and also to attempt repair. That is inflammation. We have to know it can be divided into acute or chronic, depending on the time duration and the cells that are involved. And we have to know that inflammation is not in every situation helpful to us. Sometimes it might be excessive. For example, people with septic shock. When the inflammation is so rigorous that you now have eventual damage to the blood vessels and, persistent hypotension, recurrent fever, and all those things, septic shock. Sometimes it might be prolonged. You are trying to remove an infection and it's not removing. Maybe you leave it, but the body will not leave it. So they'll keep trying to wall it off, fighting it, and that can lead to damage to some of our organs. For example, people with tuberculosis, they have persistent inflammation with granuloma formation, destroying different organs. And sometimes it might be inappropriate, when you have inflammatory response to self-antigens. That is in autoimmune disease. So inflammation is bad when it's excessive, when it is prolonged, or when it's inappropriate. So moving on to the cardinal signs of inflammation. So what are the things that you see that can tell you, okay, this is likely to be inflammation? So the rubor and the calor, we know all these things, redness and warmth. The redness and the warmth at the site of inflammation, maybe at the site of an infection, is due to vasodilation, the relaxation of the arteriolar smooth muscle to allow blood to flow to that area. And one thing I want to mention is that we have to have it baseline that histamine and bradykinin are involved in all phases of the cardinal signs. The tumor, the dolor, the calor, the rubor. Just mark histamine and bradykinin. That saves you a lot of headache. So for the rubor, which is a redness, and calor, which is a warmth, both of them, occur due to vasodilation, and you have increased blood flow to that area. And due to the vasodilatory effect of histamine, bradykinin, nitric oxide, and prostaglandin, like prostaglandin I2, they vasodilate, the vessel. Nitric oxide is a potent vasodilator, right? And aside rubor and calor, we have tumor. So tumor is like swelling. And again, I'm going to mark the register for histamine and bradykinin to be involved, right? But because of the word swelling, SLL, so I remember serotonin from the S, and the L, I remember the leukotriene, the CDE. So the leukotriene, the serotonin, the histamine, and the bradykinin. So what happens in tumor? This is because we have endothelial contraction. Please don't assume that endothelial contraction means that it is contracting. No. So the contraction means that you are opening the spaces in the endothelium. So allowing for extravasation of protein-rich fluids. So plasma protein and fluid, everything is going to travel through that opened endothelium into the tissue, right? Into the spaces in between the tissue, which is the interstitial space. So what kind of effusion do you expect from inflammation? Anybody? Is it going to be oxidative or transudative because of this opening of the vessel?
Exudative.
Exudative. So in the interstitium, the oncotic pressure is going to be elevated. Why? Because you have protein in that area. And don't forget, the opening usually occur at the post-capillary venous. So just after the capillaries, the venous, they are the ones that usually open up. Don't forget that location. We have talked about the factors that contract the endothelial cell to allow the vessel to open so that the fluid can travel, into the interstitial space. That is histamine, serotonin, bradykinin, and leukotrienes. That's tumor, which is swelling. So you notice if there's an infection, it could be swelling in that area. Bee sting, it could be swelling. The last is dolor. Dolor is pain. Pain, sensitization of the sensory nerve endings. And it is, we mark our register again. Bradykinin and what? And histamine. So the only one that is left is what? Prostaglandin E2. Now, prostaglandin E2 is also involved in sensitization of the sensory nerve endings around that inflamed site to cause pain. Sensitization of the sensory nerve endings. The sensitivity is heightened because of the effect of histamine, bradykinin, and prostaglandin E2. Now, that is the basis of using some of those NSAIDs to relieve pain. Because if you use an NSAID, it will reduce what? Production of prostaglandin E2, and you can treat pain. Very simple. Then the last is what? Loss of function. So of course, if there is inflammation of the leg from cellulitis, will the person be able to walk? No. So if the person has meningitis, will the person be able to dance? No. So there's a lot of function. So that is the way it works. Then moving on to the systemic manifestation, the acute phase reaction. Like, what are the systemic effects of inflammation? Number one, cardinal sign is fever. Everybody looks for that. You ask the patient, but this guy is not feverish now. We cannot be thinking of inflammation or infection. So that is it. Fever is a cardinal sign of inflammation. And how does it happen? It is due to release of pyrogens. So pyrogens are just like some particular component of the infectious agent. It could be like lipopolysaccharides for gram-negatives. It could be lipoteichoic acid for gram-positive. I'm going to talk about all these things when we get to microbiology. So pyrogens are just components of the infection that can provoke fever. That's it. And once that microbes get into the blood and it gets lysed and it releases LPS, lipopolysaccharide, that is going to be recognized by the macrophage, and the macrophage immediately is going to respond to that by releasing interleukin-1 and TNF. I'm sure Dr. Babainde have mentioned what is the effect that is common to interleukin-1 and TNF? Immunology.
Sepsis. Sure.
No, not sepsis. Like, what did they cause?
Fever.
Fever. Temperature. Yeah.
Fever. So you release interleukin-1 and TNF, and they are going to cause fever. But how do they cause a fever? They are going to go to increase the COX activity in the perivascular cells of the anterior hypothalamus. So they increase cyclooxygenase activity in the anterior hypothalamus. And when they increase cyclooxygenase activity in the hypothalamus, what will happen is that the production of PGE2, which is the one that we said is involved in what? In what cardinal sign of
Pain.
pain.
Hello.
Pain.
So they will elevate that PGE2, and what will PGE2 do? PGE2 will now go and change the temperature set point of the hypothalamus, change it by increasing it. Now, what do you think will be the effect of this increase? Now, if the set point is initially at 36 degrees Celsius, your PGE2 is going to increase it to 38. What do you think your body will think? Your body will now think that, why is it 38? Why is the set point reading 38? That means I have to work hard to meet up with that 38. So the body will assume that it is cold, and it will increase its metabolic rate to generate more heat. So there's increased metabolic rate to generate more heat to meet up with that 38. So that's why you feel feverish. You see them shaking, shivering, because of increased metabolism, to generate more. They are contracting their muscles. That's why they are shivering, so that they can, mediate thermogenesis, generate more heat to meet up with the increased, thermoregulatory set point. Do we understand that?
Yes.
Okay.
I lost it where if the temperature is higher, is that when the body will shiver?
Yeah.
So you said the body will think that it is cold.
Yeah.
Instead of really perceiving that high temperature, why will the body think that it's cold?
So this temperature that is increasing is not that the temperature of the body is increased. It is the set point that is increased. The set point is like the target you have to meet. So the thermoregulatory set point is increased to 38. That is where you should be. That's what the body is saying. Like, this is where you should be. 38 is where you should be. But you are 36. What are you doing at 36? So that's when the shivering, everything will now, come into play to meet up with that 38. So the body is not trying to achieve that, and they become very hot in the process. So leukocytosis, increase white blood cell count. That just depends on the nature of the cell. If it's bacteria, you see neutrophils. If it's virus, you see what?
Lymphocytes.
Lymphocyte. Then we also have what we call plasma acute phase reactants. So these are some reactants that are produced to mediate the acute and chronic inflammatory process. They are produced from the liver, and they are induced by interleukin-6. Please, don't forget this stuff. Don't forget this stuff. It's very important. Interleukin-6 induces production of acute phase reactants. Interleukin-6 mediates production of acute phase reactants. Very important stuff. Oh, I don't have the question here. I thought I put the question there. Okay. So, taking this acute phase reactant one by one, we have some of them that are positively upregulated, and you have the ones that are negatively downregulated. So what they are trying to tell us here is that all of them play a role in inflammation, but you have some of them that are increased during inflammation, and you have some of them that are decreased during inflammation. Now, let us take them one by one and see what they do. So we don't need to cram this, just understand it and you move. You don't need to cram it. There's no need to cram anything. The first one is C-reactive protein. So I want to bring us the information that C-reactive protein is an opsonine. So that means that C-reactive protein can target a particular organism, and it can cross-link that organism with the complement. And the complement is going to be attached to immunoglobulin. And the immunoglobulin is going to be coupled with phagocytes, and they will kill it off. That is why before you take pathology, one should have a very good knowledge of immunology so that you don't get confused. We remember that if we fix complements, what are the two major immunoglobulins that are very important for complement fixation? Anybody remember?
IgM and IgG.
IgM and IgG. And there's something peculiar to the Fc region of the IgG. What did they do? What did they bind to? What did they occupy?
They bind IgM.
Macrophages
Macrophage binding and complement binding of
and complement binding.
Exactly, so that they can be phagocytosed. So C-reactive protein will now come. C-reactive protein will attach to the organism and it will drag complement with it. So complement will now drag immunoglobulin, maybe IgG, and IgG will now drag the phagocyte and they will take care of it. That's opsonization. The next one is the ferritin. So ferritin is also upregulated because it's important. What does it do? It binds to the iron and prevents the microbes from using the iron for its own metabolism. There are some microbes that scavenge iron and they use it for their own metabolism. By the time we start talking about microbiology, there will be some organisms that we mention like Listeria, Yersinia, Vibrio vinificus. So they thrive in environment that is full of iron. So you take them off, and if you also sequester this iron, you are also reducing which reaction? You are reducing which reaction? If you take you are reducing the Fenton reaction, and you are not going to be generating free radicals again. So you are going to be reducing, the inflammatory damage. That's ferritin. Then fibrinogen. Fibrinogen is also very good. It is a coagulation factor because inflammation is associated with so many damage, endothelial damage, blah, blah damage. So, for example, if somebody has a wound, that is a wound. So that requires endothelial repair. So your fibrinogen is going to kick in to form a clot, to repair that endothelium and, minimize the need for inflammation. So it's been said that fibrinogen correlates with erythrocyte sedimentation rate that we are going to look into shortly. It correlates with erythrocyte sedimentation rate. The higher the level of fibrinogen, the more the ESR. And fibrinogen is a marker of inflammation too, because it's positively upregulated. The next one is aptoglobin. Aptoglobin is a mop. That's the way I see it. It is a mop for hemoglobin so that you can reduce oxidative stress. You know that hemoglobin is rich in iron. So just bind to that hemoglobin and prevent it from playing freely in plasma. And again, if you don't mop it out, hemoglobin can travel to the kidneys and cause what type of necrosis? No, I'm not talking about pathologic necrosis now. I'm not talking about maybe coagulative or something. There's a effect
Papillary necrosis.
No.
What's the question?
What are the causes of papillary necrosis? Anybody mention 4 causes of papillary necrosis?
NCAS, sickle cell disease.
Yes. So sickle cell disease,
Diabetes.
NSAID, diabetes, fantastic. What else?
NSAIDs, yeah.
Pyelonephritis, infection like pyelonephritis, diabetes, sickle cell anemia, drugs like NSAID, yeah, they can cause papillary necrosis. But what we are talking about here is not papillary necrosis.
You're talking about acute tuberous necrosis.
Yes. You forgot that acute tubular necrosis can be ischemic or toxigenic. It's both of them. So somebody having myoglobinuria or hemoglobinuria can have ATN, and somebody that has a perennial AKI can progress to the ischemic form of ATN. So that's why if somebody has maybe a blood transfusion reaction, acute hemolysis reaction, bombard with a lot of fluids so that all the hemoglobin will be washed out away and they will not be precipitating in the renal tubules. So very important. So aptoglobin is already there in the body to mop up the hemoglobin so that it doesn't release iron for oxidative injury. Epsidin is very important. Epsidin is also upregulated because it helps to reduce iron absorption by degrading ferroportin in the intestine. I know that Dr. Babandi have explained this. I've been now in hematology. We have forgotten?
No, he did.
No.
We should not forget to. So it degrades ferroportin, and there is reduction in iron absorption, right? And at the same time, because of the degraded Because of the hepcidin, there's reduced release of iron from the macrophage. So iron is not made available at all for anything. And eventually, the person can even come down with anemia of chronic disease. So in anemia of chronic disease, the level of iron is reduced. What happens to the level of ferritin? Anemia of chronic disease.
It's
Is
increased.
increased.
So what happens to the total iron binding capacity?
Increased.
Decreased.
Decreased.
I'm just hearing increase. Something increase.
No,
Decreased.
decrease.
It's a decrease.
Carrying capacity
No,
decrease.
there's not enough iron.
It is what?
I think it's
It is decreased.
Increased.
It is what?
Increased.
Increase.
Increased.
Why?
It said that
Why
it's
is total iron binding? Wait,
Wait,
there's something I want to palm. Okay, now why is it somebody says it's increased, Abby?
Yes.
what I'm hearing is increases in the
So I
comment.
know people are just playing games. People are saying increases. Now, please, is it I or D?
D for
No.
dog.
It is what?
D.
Wait.
I.
Oh my God.
I.
It is I. Okay, so the doctor that said it is I. Why is it I?
The iron in the body is reduced, so
The
there is
iron in the
enough space for the place that the iron is to bind normally is free. So it will be increased since there is no iron to bind to it.
So that is what you expect
increased.
normally. But you are forgetting that in anemia of chronic disease, there's a catch. There's an evolutionary adaptation. If you look at your first aid, that's the way it's stated. Because, for example, if somebody has microcytic anemia, maybe from sickle cell or something, of course, the iron level is, I said sickle cell. Maybe for many nutritional stuff, iron level is reduced. Of course, there is more space, for the transferrin to bind to iron, so it should be increased. But in anemia of chronic disease, it is reduced because the total iron binding capacity is also known as the level of transferrin. So you have to reduce the level of transferrin so that you will not be transferring iron, to different parts of the body. Because if you are transferring it to different parts of the body, it can be available for microbes. So that's why in anemia of chronic disease, transferrin is downregulated. You don't want it to be transferring iron up and down so that iron will be made unavailable for microbial consumption. So, and that's going to drop the total iron binding capacity. Let us confirm so that it's not as if we are moving stoof. Where is it going to be? Where is it going to be?
Hematology.
I know
What's
that.
the question?
The what?
Hematology.
I can't hear.
Oh, okay.
It should be hemat.
Hematology.
Hemat.
You see, that stuff, many people forget. And that's the reason why I asked. So, you see here that anemia of chronic disease, it is reduced. Can you see? It is D.
Yeah.
Now, why is it reduced? Evolutionary reasoning. Pathogens use circulating iron to thrive. So the body has adapted a system in which iron is stored within the cells of the body and prevent pathogen from acquiring circulating iron. Do you understand that? So,
Yep.
Hello?
Yes.
Yeah.
Yes.
So we have to be prepared for that in our exam. Don't get carried away. Just always remember, there's something about this chronic inflammation stuff that does not follow normal pattern. Let me calm down here and process everything one by one. So always be careful.
In 90 seconds.
The what?
Said 90 seconds.
In 90, no, the thing is, there will be some questions that will be bonus. You just spam it, you move. So that will buy you time. Do you get?
Right.
Do you understand? So don't worry about the time. Don't allow anybody to pressure you and tell you that there's no time. You have time. Just relax. There's no need to panic. Take the first 15 minutes, to go through the tutorial, right? So use that one to distress, because I cannot lie to you. There will be tension, right? Because by the time you enter the prometric center, you see people asking for toilet. They are going to toilet every time. So I remember my own time too. I went to toilet because everybody was going to toilet. I'm like, okay, I need to go to the toilet and calm my nerves. So there will be very high tension, but by the time you sit down, you try to analyze the question individually. You don't rush, and you are getting them. You gain back your confidence. So you definitely have time because not all the questions have the same difficulty level. Some are very hard, some are a little bit, easy, and some you have to think again. So that's the way it is. It's fairly distributed. So don't worry about time, but still be time conscious. I'm not saying that we should not be time conscious, but it's not as bad as it might have been painted. Yeah. So procalcitonin, this one is elaborated in bacterial infections. So that's just what you need to know. Normal in viral infections. Serum amyloid A, our guy, we have talked about this. It's a cause of secondary amyloidosis, right? So the negatively regulated ones include stuff like albumin. So why are we reducing the level of albumin? The reason why we are down-regulating albumin is that so that you can channel the proteins, the amino acid that you are using to produce this albumin to, form other things like C-reactive protein, like ferritin, like fibrinogen. So you down-regulate albumin that we don't need. The same thing for transferrin. We have said transferrin. So transferrin is down-regulated so that there's limited iron, available for microbes to use. So the macrophage are going to consume the transferrin so that iron will not be made available. So that's why transferrin is down-regulated, because it's consumed by the macrophages. Then transthyretin too is down-regulated just like albumin, because transthyretin is a pre-albumin. So pre-albumin and albumin are both down-regulated so that it can conserve amino acids for the positive reactants. Do you understand this? Or there's any area that is not clear?
Is it the same, Doc? Is it the same principle for the anemia of chronic disease to conserve the iron so that it will not be all consumed? Is that the same?
Sorry, I
When
could not follow.
It's negative in the transferrin, when you were explaining it in this negative.
Yeah. So I said that the transferrin is reduced so that, because transferrin contains iron, right? So we consume the transferrin so that we limit the amount of iron that is going to be available for the microbes, to do their metabolism and be generating free radicals.
Transferrin transports iron, isn't it?
Yes, it binds to the iron and transports it to baby bone marrow, to other things. It's like a channel for distributing iron. So if you down-regulate transferrin, do you think iron will be distributed to any area?
No,
which is good for us. So more power that transferrin so that you have limited transfer of iron. So do you understand? Is it clear to us now?
Yeah.
Okay. I think we should take like a break, and we come back 15 minutes, right? I'll come back in 15 minutes time. So that's 7:50 in my own time. Okay.
Okay.
Okay. So we'll continue with the by talking about the erythrocyte sedimentation rate. And don't forget, we have mentioned already that the ESR is correlates with the level of fibrinogen. So and the ESR is just talking about how fast the red blood cell sediment within a tube that is spinned. So we take the tube to the lab and we try to spin it, and we try to measure how fast the sediment, to the bottom of the tube. That's, essentially what ESR is all about. Now, there's something we need to know, and that is the fact that the red blood cells normally are separated by negative charges. So they have negative charges in them that separate them. And once they are separated and they are not clumped, the density is not as large as if they are clumped together. So because of the negative charges, they are repelled and they are not clumped. And they find it very difficult to sediment down the tube. So the ESR is less when the red blood cells are not clumped, which is, the clumping is what we call the Rolio, I can't pronounce that stuff very well, the Rolio formation or something. So, and that's when fibrinogen comes in. So during inflammation, fibrinogen is one of the acute phase reactant that is elevated, just like we have discussed, because it helps to repair the endothelial injury. The fibrinogen neutralizes these negative charges and it allows the red blood cell to aggregate together and form the Rolio pattern. And in that clumped form, they can easily sediment down the tube. So that means that the more the level of fibrinogen, the more the ability of red blood cells to aggregate and the higher their erythrocyte sedimentation rate. So that means that high ESR means high fibrinogen, and there's a possibility that there's an ongoing inflammation. So that's why it is tested with CRP, which is a more specific marker of inflammation, because the fact that ESR is elevated doesn't necessarily mean that there's inflammation. There are other things that can elevate ESR without inflammation ongoing. So what you do is that once you say that, okay, the ESR is elevated, let me test the CRP. If CRP is elevated too, you can say that, okay, this is likely to be inflammation. So what is the function of CRP? Anybody remembers? What did we say is peculiar to CRP?
Okay, that it's also an opsonin.
Yes, it is an opsonin. So let us look at the causes of increased or elevated ESR. So I think the acronym here is a picture of a pregnant renal cancer patient. So pregnancy, renal disease, cancer can all elevate ESR. So most anemias can elevate ESR except sickle cell anemia, and I'm going to explain. Infections, inflammation, cancer. So let me start with pregnancy. So in an individual that is pregnant, we know that during the third trimester, the level of fibrinogen is usually elevated because the body of the pregnant woman is getting prepared for labor and delivery, and we expect a lot of blood loss. So the fibrinogen concentration in the plasma at that point is elevated, and the more the fibrinogen, the more the charges, the negative charges within the red blood cells are going to be neutralized, and there's increased tendency of the red blood cells to aggregate together, right? And they form, clumps that can easily fall through the tube, increasing the ESR. Do we understand that?
Yes.
Yeah. So that's pregnancy. The next is renal disease, be it end-stage renal disease or nephrotic syndrome. Now, one thing that is peculiar to them is that, especially nephrotic syndrome, is that there is loss of protein. We know in nephrotic syndrome there's a lot of protein, particularly albumin and some globulins. Fibrinogen does not really escape because fibrinogen is larger than albumin and globulin. So the concentration of fibrinogen is increased because it becomes the major protein in the plasma that dominates, in nephrotic syndrome. And in some form of end-stage renal disease, you have chronic inflammation, elaboration of fibrinogen, the explanation goes on and on like that, neutralizing the negative charge, increased red blood cell aggregation, and increased ESR. The same thing for cancers, metastasis and multiple myeloma. They are chronic inflammatory states, So you expect what's it called? The fibrinogen level to be increased in cancers, because of chronic inflammation and increased ESR. The same thing for inflammatory stuff like Janssen arthritis, polymyalgia rheumatica, they are inflammatory states. The level of fibrinogen will increase. Same thing for infection. Infection can also provoke inflammation, so ESR increases too. Then most anemias, so except sickle cell anemia, because in anemia, the concentration of red blood cell reduces when compared to the proteins, particularly the fibrinogen. So because there's anemia, it means that you have less red blood cell. So the fibrinogen concentration overweighs out of the red blood cells. So they can easily neutralize the charges and you have more red blood cell aggregation and increased ESR. So that makes sense. Do we have any question?
So, you said you were going to explain in sickle cell why that is not so.
Yeah, so I'm going to go back to the reduction now. So I just want to be sure that we understand the...
Okay, yeah.
Take that to our name again, please.
The what?
The what you explained regarding anemia and fibrinogen.
So anemia, anemia, reduction in the number of red blood cells. So that means that the concentration of the protein, which is the fibrinogen, is going to be more compared to the red blood cells. So the proteins will dilute all the negative charges and you have increased red blood cell aggregation and ESR.
Okay, thank you.
Do you get that?
Yes.
So the reason why ESR still falls in sickle cell anemia is because of the shape. So that shape doesn't allow for clumping. It doesn't allow for the red blood cell to adhere together. So that is the reason, why, despite the fact that there's anemia, there's reduction in the number of red blood cell, and the fibrinogen count is relatively increased, the cells does not still find it, they don't find it easy to adhere together. So that is because of the alteration in the shape. So that's the reason why they don't cause an increase in the ESR. So that by convex or by concave shape is lost, and that sickling doesn't allow for the red blood cell to adhere together. Just imagine that you are trying to pack something that's sickled together; they will not fit. So that's the reason why the ESR is reduced. And the same thing also applies for anything that causes microcytosis, anything that reduces the surface area of the red blood cell. It also, doesn't allow for proper adherence of those red cells together. And in that situation, the ESR2 is going to fall. Polycythemia is a cause of reduced ESR because...
Yeah, in microcytic anemia, does what you just said, does it mean that in microcytic anemia, the ESR2 is also low?
Will fall. Yes, that is what it means. So anything that causes microcytic anemia too would have... I'm accepting the question. So it can bring about a reduction in the ESR, yeah. So the only one that will fit is maybe there's macrocytosis. Okay. So, but once there's microcytosis, there is reduction in the ESR. So when we say most anemias, it means that we are saying anemia that is nomocytic and macrocytic.
Okay.
Do you understand, Doc? So, but once it is microcytic, then ESR will reduce. So the ESR drops in polycythemia because the concentration of the red blood cell is now more compared to the fibrinogen. So the fibrinogen cannot dilute all the red blood cells. So they are more than the fibrinogen. So that means that you are still going to have some negative charges that are not, occupied. So they will be repelling themselves and they will not be able to aggregate and the ESR will fall. So polycythemia is the cause of reduced ESR. Heart failure is a cause too because heart failure, there's a lot of fluid in the plasma, fluid retention. The fluid will dilute the proteins. When the proteins are diluted, there's nothing to neutralize the charges. So the charges are there, red blood cell repelling each other, and there's reduction in the ESR. Hypofibrinogenemia is self-explanatory. No fibrinogen, nothing to dilute the red blood cell charges. They are repelling, and there's reduction in the ESR. I think that's clear, right?
Yeah.
Okay. So moving on to
Doc,
acute
the
inflammation.
reduction in Doc, can you hear me?
Yes, I can. I
Okay.
can.
Reduction in ESR meaning when the RBCs drop, isn't it?
Meaning that the RBC does not drop fast.
They don't drop
It
fast.
is a rate.
Okay.
Erythrocyte sedimentation rate. The rate at which they sediment.
The sediment.
The rate at which they drop. You know, which one do you think is going to drop faster? Something that is clumped together as a whole, or something that is separated? Which one do you think is going to weigh more?
The one
If something is
that's joined
separated.
Together.
Exactly, the one that is joined together.
So
So it means that if they are joined together,
they will
the ESR is going to be high because they will drop at a faster rate.
Okay.
They drop at a faster rate because they weigh more. So ESR is going to be elevated.
Okay,
But
then
if
why is ESR not elevated in sickle cell disease since the blood they're clumped together?
so they are not clumped together in sickle cell disease. What you are just saying is sludging.
Okay.
In sickle cell disease, the blood, there's just like more like what's the word to use? Like more like sludging of the vessels. Like you have slow movement. It doesn't mean that they are clumped.
Okay.
So they are not clumped together in sickle cell anemia because of the shape. So the shape doesn't allow them to fit into each other to clump. So they are not clumped. The situation where you have clumping and these rollers being described is something like multiple myeloma. I don't know if Dr. Randy mentioned it. That's where they will tell you that red blood cells are actually clumpy. Did he mention something like rollers in multiple myeloma?
Yes.
Yeah, so multiple myeloma, Waldenstrom, that's where you see the rollers, the clumpy, true. But in sickle cell, they don't clump. They can just sludge the blood vessel, you know, or like what you have in leukemias because of the abundant what's it called, myeloid cell being produced. It just cause leukostasis and sludging of the vessels. That's what you have. The slow movement of blood, but they don't clump together. They don't.
Okay.
So it's because of the altered shape, just like we have the shape. So in acute inflammation, this is more like a transient and early response to infection or injury. So that's the first initiating, response to any form of infection or somebody getting injured. Acute inflammation is what is going to happen first. Although it in a way depends on the type of the insult. So if somebody is having like tuberculosis now, it's not going to be acute inflammation that's going to happen first. It's going to be a chronic inflammatory process. So because the cells that are involved defines the type of inflammation that is going to occur. So, and we are going to talk about them shortly. So the major cell in acute inflammation are the neutrophils. And the neutrophils appear blue. This is the way they look like. Once you see a tissue like this, with all this blue stuff, just you in like 80% of the case, you'll be right to call it acute inflammatory response. Just like all this blue dot thing, on your slide. Okay, this is like neutrophils infiltrating a tissue. It could be an acute inflammatory event. So it's rapid in onset and it resolves very fast. And it involves cells of the innate immune system. So when we say cells of the innate immune system, it means we are not talking about cells of adaptive immunity. So that is, we are not talking about the T cells, we are not talking about the lymphocytes, we are not talking about the plasma cells, right? We are talking about most of the myeloid cells like the neutrophils, the eosinophils, the basophils, the mast cells. Those are what we are talking about, the innate immune system, the complement, right? They are not as specific as, the plasma cell, the B cells, the T cells. We know that from our immunology knowledge, the B cells, the T cells, they are always very specific, right? Hope we remember.
Yes.
Yes.
Thank God that we have even done immunology because it will have been very difficult. So we understand all these things, so it's very easy to explain. So what are the stimuli for acute inflammation? infection, is the number one that you don't want to forget. It could follow trauma, necrosis, foreign body. We don't need to cram all those things. Nobody's going to ask us all these things, but it's just good to know. Necrosis, foreign body, trauma, infection can all provoke acute inflammation. And what are the cells that are involved? We talk about the toll-like receptors. We talk about arachidonic acid metabolites like the prostaglandins, leukotrienes. We talk about neutrophils, just as I've said, eosinophils, antibodies, the pre-existing ones, not the one that we are producing in response to a specific antigen. The pre-existing antibodies, the eosinophils, the neutrophils, mast cells, basophils, complement, and the Edgeman factor for clot formation. And there's also something we call the inflammasome. So that inflammasome is just more like a protein complex that can recognize some foreign bodies, some microbial products, some dead cells, and it can release interleukin-1, TNF, and they can kickstart the inflammatory response. So they are just there, standby in the cytoplasm. And when there's any form of necrosis or microbial infection, they can quickly respond to it, release interleukin-1, and drive the inflammatory response. So don't forget the cells. Just remember the granulocytes, neutrophils, eosinophils, basophils, depending on the type of cell, depending on the type of stimulus. So if it's allergic stimulus now, you'll be talking about eosinophils, basophils. If it's normal bacterial infection, neutrophils. So and the complement. So those are the cells. So what are the phases? The vascular and the cellular phase. The vascular and the cellular phase. So the first thing that happens in any inflammatory response is vasodilation. Number one thing is that the vessels need to vasodilate. And the idea is so that we can bring in the cells, the neutrophils, the eosinophils, or the basophils to that site of injury, and they can respond to the insult. So once they get there, once they get to the site of the insult, there's going to be stasis. And the stasis is there to allow them to travel, to migrate into the tissue. So let me just assume that this is the site of the injury. Now, that area is going to be supplied by vessels, by blood. So these are the vessels. So the first thing is that these vessels here are going to vasodilate. They are going to vasodilate so that you can have neutrophils, everything being brought in here. Then once they get to this area, they are going to slow down. Blood flow is going to slow down, stasis. Then the next thing is that they are going to elaborate some cytokines, right? The swelling, what's it called? Serotonin, leukotriene, histamine, bradykinin, and that will open up, contract the endothelium. Hope you remember, they'll contract the endothelium. Are we following what I'm saying?
Yeah.
And once they contract the endothelium, they can have a pathway to enter into this tissue. So once they contract this endothelium and this endothelium opens, what is going to happen? There's going to be extravasation of the neutrophils and also release of proteins, fluid rich in proteins into the interstitial space. So this is the interstitial space here, space in between the tissues at the interstitial space. So proteins are going to be released here. The lymphocytes are also going to enter, and they are going to try to eliminate the microbial cause of the problem, or the foreign body, or whatever is triggering that reaction. So the first phase, which is vasodilation, the increase in the endothelial permeability, is called the vascular phase. So once the leukocyte now enters, which is mainly the neutrophils, from the post-capillary venules, don't forget, that is what I said is going to vasodilate. What is going to open up? The post-capillary venules. Then the neutrophils will now enter into the tissue, and they are going to try to eliminate whatever is causing that problem. So that occurs in different phases, which you are going to look at one by one. I mean, the cellular phase. It occurs in different phases, and my code is Mr. Ade travels wide. Mr. Ade, margination and rolling. Ade, addition. Travel is like, transmigration. Transmigration. Then wide is a migration. So once you remember the travel, transmigration, the last one is migration. So initially, once they get to the edge of the vessel, they will attach to it slightly and they will roll over it. Then afterwards, they will adhere to it firmly. That is the adhesion. So the difference between margination and adhesion is just the firmness of attachment. Then afterwards, the vessels are going to open up and they are going to migrate like across the vessel. That is transmigration. Then when they now get to the end of the vessel, they are now going to migrate to the site of injury. So that is now the migration. Please, you will understand what I've said.
Yeah.
So, first steps, the neutrophils are going to adhere to the edge of the endothelial lining. That is margination and rolling. They adhere slightly and they roll over it. That is margination and rolling. Mr. Margination and rolling. They will not adhere to it firmly later. When they adhere firmly, they release their serotonin, bradykinin, histamine, which will open up and contract the endothelium so that they can pass through. Now, that passing through is called transmigration. Now, once they enter into the tissue, of course, the tissue is very wide. They need to go to the specific side of the inflammation in the tissue, the specific side of the injury. So they migrate to the focus of the stimulus. That is migration. Do we understand?
So it's not migrating to the interstitial space.
No. See, this is the site of infection here.
Okay.
This is the site of infection here.
Okay.
This is the blood vessel. This is the blood vessel. This is the tissue space. All what you have here is tissue space, right? But this is the site of infection.
Okay.
It will adhere to this place first. They will attach to it firmly. Not just attach to it slightly, margination, and they will roll over it. They'll be rolling. It will get to a point they will attach firmly. That is adhesion.
Okay.
They will contract the endothelial space and they will migrate across it. That is transmigration, right?
Yes.
When there is transmigration, they will get here, right? But this is the site of infection. They're already in the tissue, but this is the site of infection, right? So they need to travel to this site of infection. That is migration. Do you understand? So now, what are the outcomes of acute inflammation? So it can easily resolve, and the healing is done. So the neutrophils can just enter, go to the infection site, take care of it, and that's all. Now, once they are done, they are going to elaborate interleukin 10 and TGF, transforming growth factor beta. Now, who can tell us, according to knowledge of immunology, what is peculiar to interleukin 10 and transforming growth factor beta? Anybody remember?
They are anti-inflammatory.
They are anti-inflammatory. So that means that once healing is done, they will just release these guys so that you suppress inflammation. Don't forget that. Sometimes the infection might be difficult to eradicate. Maybe the person is having methicillin-resistant Staph aureus, that even the drugs, everything is not working against it, and the acute inflammation does persist. So there's going to be elaboration of interleukin 8. Interleukin 8 is one of the chemoattractants for neutrophils. We are going to see them shortly. It keeps dragging the neutrophils there. Interleukin 8. Persistent acute inflammation. Sometimes they might form an abscess, particularly when there is what form of necrosis? Liquefactive necrosis. So they are going to wall off that infection as an abscess, which is very common in Staph aureus infection. They are notorious for forming abscess. Now, sometimes it can progress to chronic inflammatory states, in which it might be difficult for the what's it called? The neutrophils to eradicate it. So it can progress to chronic inflammation. For example, an individual having acute hepatitis going to chronic hepatitis. That's a form of progression from acute hepatitis to chronic inflammation, right? And in that phase, you're already utilizing your macrophage and you are getting your CD4 cells involved. Now, if chronic hepatitis persists for a long time, what do we think is going to happen afterwards? What's going to be the complication of chronic hepatitis? Anybody remembers?
Maybe amyloid deposition.
Fibrosis.
How can chronic hepatitis cause amyloid deposition? How?
Fibrosis.
From
Fibrosis, carcinoma, and carcinoma.
Hepatocellular carcinoma.
Okay, yeah, that's correct. But before we get to hepatocellular carcinoma, there's something that will happen.
Liver
Cirrhosis.
cirrhosis.
The cirrhosis. And cirrhosis is associated with, scar formation, fibrosis, and nodular regeneration. So they can be scarring. So these are the complications or the outcomes. It can resolve. It can be persistent, driven by interleukin-8. They can form abscess depending on the organism. They can progress to chronic inflammation and eventual scarring. So during the early phase of acute inflammation, what are the cells involved? The neutrophils. During the later stages, the macrophages will now come around and they peak within 2 to 3 days. They peak within 2 to 3 days after the onset. Very important stuff. So by the time the macrophages are coming around and the inflammation is not still residing, it's going to progress to chronic inflammation and you can have eventual scarring. Now, that stuff that I've explained now, this migration, blah, 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 they can ask you very, very important stuff. I'm very serious. They can ask you, and don't panic. You should be happy when you see it because it's very simple. So, leukocyte extravasation. How do they leave the vessel to enter into the tissues? Don't forget, we have talked about the site where they live. They live at the what? The post-capillary venous. Some people would think that this is not important. They would, gloss over it, but I have emphasized it. The post-capillary venous. Okay. So, what is the first step? The first step is margination and rolling, followed by tight binding, which is the addition. Then the diapedesis, also known as transmigration, then the eventual migration. Now, the first thing to know, to remember all these jargons here, is that we have to have it at the back of our mind that all the cell adhesion molecules, the CAMs, be it ICAM, VCAM, PECAM, GlyCAM, they are located in the endothelium of the vessels. So the ICAMs, PCAM, the VCAM, the CAMs are located in the endothelium of the vessel. Now, in the leukocytes, the migration process is basically an interaction between the neutrophils, which is a leukocyte, and the endothelium. Hope we agree with me. Do we agree?
Yes.
So that means that anything.
Question. What did you say? I'm sorry. That's right.
So I said the interaction between the migration process is basically due to interaction between the neutrophils and the endothelium of the vessels.
Yes. Yes.
So there have to be some form of attachment connecting them. So all of them have different things that they express that match together. So I've talked about the CAMs in the vessels, the endothelium of the vessels. I've talked about the CAMs, so we have settled down on. Now, in the endothelium, in the leukocyte rather, the leukocytes have, a very, very handsome man. And that is what you call the Sir Lewis. So they have the Sir Lewis. The Sir Lewis is a very handsome man, which is selected by so many things. Now, if you turn this Sir Lewis the other way around, we are going to get another thing, which is what? L-selectin. So Sir Lewis is SL, so I can change it to the other way around, so L-selectin. So that means that L-selectin and Sir Lewis, both of them, they are within the leukocyte. So within the leukocyte, we have Sir Lewis, the very handsome man, and the L-selectin. Now, Sir Lewis is attracted to the E and the P-selectin in the vasculature. Sir Lewis is a very handsome man and is attracted to E-selectin and P-selectin in the vasculature. So E-selectin is upregulated by TNF and interleukin-1. P-selectin is from the platelets. So it is released by, I should have asked that question, that what is the Weber-Palades bodies? I know that Weber will have mentioned it in, what's it called, in hematology. So they are from the platelets, the P-selectin, and the E-selectin are upregulated from TNF and interleukin-1. Okay. And they are both attracted to Sir Lewis. Now, that kickstarts the first phase of the migration. So the margin and the rolling is due to interaction between Sir Lewis and E-selectin, Sir Lewis and P-selectin, and also L-selectin that follows Sir Lewis and glycan. So if you don't remember the L-selectin and glycan, it's fine. Just remember Sir Lewis, because Sir Lewis is the one that is responsible for a particular disease condition. So if Sir Lewis is deficient, the individual can develop leukocyte addition deficiency type 2. Leukocyte addition deficiency type 2 is due to Sir Lewis mutation. So that means that there's a problem of, don't be deceived that Shebi's addition, the margination and rolling is what this Sir Lewis does now. Why is it now called addition? That's the way they name their stuff. So leukocyte addition deficiency type 2 is due to absence of Sir Lewis on the leukocytes. And the problem is that they cannot perform the process of margination and rolling. In fact, the USMLE, what they will do is that they are going to tell you what is mutated. They will now ask you what phase is going to be affected. Just go and pick your margination and your rolling. Very simple. Very, very simple. Now, moving on to tight binding. So tight binding or addition. What plays a role in tight binding and addition is the ICAM and the VCAM. We have said it that VCAM and ICAM are located where? In the where? Anybody remembers?
The
The
vessel.
glomerulus.
In the
Vascular
vessels.
endothelium.
So the
Endothelium.
vascular endothelium have the VCAM and the ICAM. So VCAM is going to interact with another V, which is the VLA4 antigen, right? VLA4 antigen interact with the VCAM. While ICAM is going to interact with something that contains I2 in a way, which is the CD11 or the CD18 integrin. But the most important here is the CD18. That's the one you can never forget. Because problem with the CD18 results in problem with tight binding or addition, leading to leukocyte addition deficiency type 1. The CD11 and the CD18 are forms of integrin. They are form of integrin, and they interact with ICAM. While VCAM interact with VLA4 integrin. Then the other phases are very simple. The hardest ones are the ones that we have talked about. So diapedesis is the next, which is transmigration. So movement across the endothelial cell. And that is mediated by PECAM. Very simple in both regions. PECAM. That is diapedesis or transmigration. Then for migration. So for you to migrate from here to here, it must be attracted by something. Now, what are these chemoattractants? C5a, you cannot forget. There's no way you can forget. Interleukin 8, you have to know all these things because they can ask you any one of them. Leukotriene B4, 5-HT, kallikrein. Sorry, I could not create an acronym for this. I'm not very good with acronyms. Platelet activation factor and N-formylmethionine. So interleukin 5A, very common. Interleukin 5A, interleukin 8, we have mentioned this one previously. Interleukin 8, interleukin 5A, HT, kallikrein, leukotriene B4, PAF, which is the platelet activation factor, and the N-formylmethionine. I think there's a part of immunology that Dr. Babande mentioned some of this. I think so, right?
Yeah, chill neutrophil is coming. Chill neutrophil is coming.
Chill neutrophil. My doctors allowed me to be struggling with this thing, and there's already a mnemonic, and nobody could assist me. That's not fair enough. So chill neutrophil is coming. So that is Dr. Babande is very good. He's a master of all those things. So so with that acronym, you can figure out all these things. So just don't forget the brother Sally Lewis X and the other things that attract him, which is a E-selectin and a P-selectin. So problem with Sally Lewis X is going to cause LAD type 2. And we know how LAD is going to present. Anybody remembers immunology?
Nope.
Failure
Delayed
of like
delayed
our
separation
cord
of
to
the umbilical
form.
cord.
Present with
Yeah.
pulse without
Go pause.
organism. Pulse without
Cold pause.
Yeah. Okay. Yeah. The delayed umbilical separation and all those things. So that is the way it works. Okay. So let's move to chronic inflammation.
In the presentations between the LED 1 and 2, are there any differences with how it presents?
The presentation,
Yeah.
I'm not really sure.
Oh, okay.
I don't think so. But the one they commonly ask is the LAD type 1.
Okay.
But I don't think there's any difference. I'll check. I'm not really sure.
Okay.
That's a very good question. Thank you, but I'm not really sure.
Yeah,
So,
boss, for the hello?
Yeah, I'm listening.
For the migration, please, can you elaborate more on the PCAM?
Yeah, like PCAM is the structure that interacts, that mediates the interaction. So PCAM is on the vasculature, PCAM is also in the leukocyte. So they interact together to allow for the transmigration. See, this is what they are saying. This is a phase of the transmigration. Look at the neutrophils expressing its PCAM. Can you see? Doc, can you see the way can you see what I'm showing you?
Yes, I can.
So this is a PCAM. This stuff is a PCAM. So it means that all these things are PCAMs. So PCAMs interact with PCAM at this point. Do you get for transmigration? Do you get? It's very simple. Like that one is not just no PCAM. PCAM is the transmigration. Do you understand it now?
Yeah, thank you.
So chronic inflammation. Chronic inflammation just means that the cells that are involved now does not involve the neutrophils. So it's just essentially the macrophage, the lymphocyte, and the plasma cells. Nothing like neutrophils. So, and here the inflammation is very prolonged, and the idea is that they want to repair the injury, but at the same time, they will destroy the tissue. That's chronic inflammation. So chronic inflammation destroys the tissue, and at the same time, attempt to repair. So in some situation, it might be preceded by acute inflammation. So just like when I was giving situation of acute hepatitis, going to chronic hepatitis. So in an attempt to repair, they do that by forming new blood vessels and also laying down collagen, leading to fibrosis. So what are the stimulus or the stimuli rather that can provoke chronic inflammation? So persistent infections, tuberculosis, syphilis, fungal, some terrible viruses like HPV, they can all provoke chronic inflammation. So these are things that we already know, tuberculosis, all those chronic infections, all of them, they can, cause chronic inflammation. And the type of hypersensitivity, it can lead to type 4 hypersensitivity, especially with respect to all these tuberculosis, syphilis and the likes. So because they essentially involve the CD4 cells, the CD8 cells. So type 4 hypersensitivity. In some situations, chronic inflammation can be involved in autoimmune disease, SLE, rheumatoid arthritis, chronic inflammation. There's no way you'd biopsy or you do analysis of somebody that has chronic rheumatoid arthritis and you'll be seeing neutrophils. It's not possible. It's a chronic inflammatory process. Lymphocytes is what you'll be seeing. you know, and because it's even related to type 5 hypersensitivity, just seeing your CD8, CD4. So prolonged exposure to some toxic agents like silica, some foreign materials can also be associated with chronic inflammation. Yeah, silica, you know, from sand. Talc. Talc is one of those products that they use in cosmetics. Beryllium, you know, people that work in, is it aerospace now? What are the causes of berylliosis?
Aerospace.
Let me be sure.
Aerospace, yeah.
Aerospace.
Mhm.
Aerospace, yeah. You know, I think insulating, you know, companies and all those things. So all of them, the response is going to be chronic inflammation, formation of nodules, granulomas, and all those things. So the dominant cells are the macrophage. You know, don't pick lymphocyte, pick macrophage first. Very important, because the macrophage will be the one to be activating the T cells at the end of the day. So the macrophages are actually the number one, the dominant cells in chronic inflammation. And how does it happen? So once the antigen presenting cells captures the particular stimulus, let's say that the stimulus is like what's it called? The stimulus is tuberculosis. So they would capture the antigen of that tuberculosis, and they are going to present it to the naive T cells in the lymph node. They are naive; they have not committed to any pathway, and they are going to release interleukin 12. So interleukin 12 is going to make them committed to a particular pathway. I should be asking this as a question just to revise our immunology, but time is fast spent. So interleukin 12 is going to make them differentiate into the TFR1 pathway. And TFR1 is now going to release gamma interferon. And what is the function of gamma interferon? Gamma interferon is an activator of macrophage. That's what they do. That's all what they do. So they activate the macrophage, and the macrophage will activate the pro-inflammatory phase. So macrophage will start releasing TNF, you know, that will further recruit more TFR, you know, to mediate that inflammatory drive, and that is going to be causing the tissue destruction. Now, when they have now done their destruction, at the same time, after some time, they will now, you know, make a pause with the activation of the TFR1 cells, and they will differentiate to the TFR2 pathway, and the TFR2 will now start releasing interleukin 4 and 13. So these ones too will activate the macrophage, but the macrophage that are activated, they are activated in the alternative pathway. The ones that are activated initially, they are activated in the classical pathway, and the classical pathway are pro-inflammatory. They release interleukin 1, TNF alpha to drive that inflammation on forward like that. But once the TFR2 are activated, they will release interleukin 4 and 13, and they will activate the macrophage in the alternative pathway. And those macrophages are essentially concerned with repair. That's what they do. So they will start releasing, you know, stimulating release of factors to allow for angiogenesis like fibroblast growth factor, vascular endothelial growth factor, platelet-derived growth factor, you know, and, you know, your TGF alpha and TGF beta rather, and interleukin 13, so that they can reduce the inflammation and they can also attempt with repair, usually with fibrosis. So, do we understand this, or should I come again?
Please come again. Thank you.
Do you understand the classical pathway of the inflammation?
Yes.
Yes.
So now the classical pathway is done. Now, one thing about chronic inflammation is that you will notice that it will get to a point, you'll be seeing features of fibrosis with chronic inflammation. So that means that they are trying to seize the pro-inflammatory drive, and they are trying to switch to anti-inflammatory, you know, process. And now they are going to quieten the activity of interleukin 1. So interleukin 2 is going to be evoked. If we check our immunology, there are some interleukins that are released to activate the TFR2. I can't really remember them very well now. But those macrophages are going to elaborate those interleukin that's going to activate this interleukin, this TEPA2. And once TEPA2 are activated, they will release interleukin 4 and 13. Now, once they release interleukin 4 and 13, they are still going to activate the macrophage. But the macrophages are now activated in an alternative pathway, and the alternative pathway is different from the classical pathway because alternative macrophage activation is concerned with repair, not destruction. So they will start repairing by releasing platelet-derived growth factor, fibroblast growth factor. So they will start, forming new vessels, laying down collagen to repair that area. Do we get it now?
Yes. Yes.
Okay. So what are the outcomes of chronic inflammation? So scarring, of course, from fibrosis, amyloidosis, which you have said, from SAA, right? Neoplastic transformation. Of course, we know that chronic hepatitis can go to hepatocellular carcinoma, just like we have rightly mentioned. And, still on the course of the neoplastic transformation, Helicobacter pylori can lead to chronic gastritis, which can lead to both multilymphoma and gastric adenocarcinoma. So don't forget, scarring from fibrosis, amyloidosis due to SAA, serum amyloid protein A, and the neoplastic transformation. Those are the outcomes of chronic inflammation. Unlike acute inflammation, in which the outcomes include what? Resolution, includes what? Persistent inflammation from interleukin, from chill, neutrophils are coming, Abby. Then
Abscess formation.
abscess, yes, abscess formation. It can progress to chronic inflammation and then scarring. So that's the way it works. So now, moving on to wound healing. So wound healing occurs in phases, and the phases is divided into, ideally, some studies are going to divide into 4, which is the hemostasis, then inflammatory phase, proliferative phase, and remodeling, right? So in case you start solving our U-word, I'm sorry I don't have much questions here. Maybe when I'm coming back tomorrow, I'm going to get some questions to back up all these things. So, but we should try as much as possible to just get the gist. I'm sure by the time we go back to attempt the questions, it's going to be like a walk in the park. Once you understand the gist, that is what USML is all about. USML is not all about the number of questions you have solved, but how much concept you know. That is because once you are talking, you are just talking like authority, because you know the reason why you are choosing your answer. You are not just cramming answers. So, so the phases of wound healing, the first is more like the hemostatic phase. So, which is clot formation. Of course, if there's a wound, you need to arrest that bleeding. There needs to be an arrest of the bleeding. And you can arrest the bleeding when you form the clots. So there's clot formation. Then the inflammatory phase will now begin. Now, what is peculiar to the inflammatory phase? We start talking about the 2 phases of acute inflammation again, the vascular phase and the cellular phase. So the first thing that happens in the vascular phase is what? Anybody remembers?
Dilation.
Yes, vasodilation. Vasodilation so that you can recruit the neutrophils into that site. So then after vasodilation, you have stasis, then the cellular phase is going to begin. So what is going to mark the beginning of the cellular phase? What is the first thing?
Extravasation of the leukocytes.
Yeah, but before the extravasate, like, how are they going to, yeah, like, before the, okay, increase in vascular permeability, yes. Now, but what would they do to the vessel? Like, what would the neutrophils do to the vessels? Like, how are they going to interact with the vessels?
Because
endothelial contraction.
Constrict.
Okay, contraction of the endothelium. Okay, so what is the neutrophils going to do to the endothelium?
Or
They will
migrate
line
and roll.
on the wall,
Okay.
lateral.
No, we
They
are
line up
talking
by the
about the
side.
faces. The line. So what do we call that?
Is it imagination?
Imagination and
Imagination
And
and
We talk about
rolling.
this.
Adhesion.
We have talked about this. Oh,
Adhesion.
We said
Adhesion.
adhesion.
ah,
Then they open up the
Understand the
endothelium.
question.
imagination and
so
rolling. Is it not
It's
I
no.
said,
rolling.
I said, how are the neutrophils going to interact with the vessel? Like, how are they going to interact with the vessels? The first thing is that they are going to marginate, they are going to roll,
Yes.
they are going to adhere, they transmigrate, and they migrate. That is it.
Okay.
That's what I'm asking. So, there's increased vascular permeability, and the neutrophils will try to migrate into the tissues, right? And through those phases that we have talked about, then the macrophages will now come 2 days later to clear up the debris. That's the inflammatory phase. So that means that the inflammatory phase is just summarizing acute inflammation. Do we agree with me?
Yes.
Yes.
So, exactly. Then the next thing is that, okay, the neutrophils have gone in, macrophages have gone in, they have mopped up the debris. So we need to start to repair proliferation. We need to start to repair. And inflammatory phase occurs from day 1 to day 3. The proliferative phase occurs from day 3 to like weeks after the wound. So what happens? The idea of the proliferative phase is that you want to lay down granulation tissue. That is your end goal. If you remember when we're doing our bones rotation, what is going to make the plastic surgeon happy is when they open the wound and they are saying what? They are saying what?
Granulation
Granulation
tissue.
tissue.
And they are saying granulation tissue. They will say that, this wound is healing well. There's granulation tissue. So what is this granulation tissue all about? The first thing is that we have to deposit collagen. We have to create a collagenous scaffold. And what is going to deposit that collagen? Our fibroblasts. Fibroblasts come in and they start depositing collagen. Now, we need to enrich this collagen with the blood vessels so that they will be nourished, right? Now, that is when our endothelial cells are going to come in and they are going to perform angiogenesis. Now, we have created a collagen scaffold. We have impregnated it with good blood vessels. Now we need to cover that injury. So that's when we now start seeing some dark stuff over that wound. So that is epithelial cell proliferation. Cover the wound. What is going to help us cover the wound? Our keratinocytes. Create skin. Cover that wound. Now, the myofibroblasts is going to come in. And what are they going to do? They are going to contract that wound to make sure that they squeeze out any remaining fluid or debris that is there. They contract the wound and make it tight. Myofibroblasts. The macrophages too are going to be there to dissolve any residual clots. You are done with the proliferative phase. So it makes sense logically. Number 1 is to lay down collagen with your fibroblasts. Number 2 is to impregnate with blood vessel angiogenesis with what? Endothelial cells. Number 3 is that you create a covering, keratinocytes, it's epithelial cell covering. Then you recruit your endothelial cells, myofibroblasts rather, myofibroblasts to contract that wound, to make it strong and firm. Then the macrophages will dissolve any, clots that might be remaining. Now this is where USMLE will now come. So they can tell you that there's a delay in this proliferative phase. What nutritional deficiency can be responsible for this? So you have to remember vitamin C and copper deficiency. Now, vitamin C in our biochemistry, what does it do? Anybody remembers? Vitamin C. I know that some people will be like,
Hydroxylation.
some people will be like, this doctor is
Synthesis.
always asking us too much questions. Please just teach us and go. So I'm not going to teach you and go because you must pass. So, and I have to make sure that what we have learned previously is still staying with us. So the vitamin C is what? I can't hear. There was a chorus answer.
Hydroxylation.
Hydroxylation, proline and
Lysine and proline residues.
Yes, that's very correct. The stuff is there. So ensures hydroxylation of the lysine and the proline residues of collagen. Don't forget, the collagen that is first deposited is collagen type 3. I must emphasize that. The initial one is collagen type 3. It's still going to get broken down to collagen type 1, which is the one that we want. That one has a more tensile strength than collagen type 3. Now, so to deposit that initial collagen, we need vitamin C, because vitamin C is very important to form the lysine and the proline hydroxylation. And at the same time, to cross-link that collagen with elastin and the other surrounding fibers, you need copper. Copper is a cofactor for lysyl oxidase. So there's an enzyme you call lysyl, oxidase. Lysyl oxidase. So this copper allows it to function, and it is important in cross-linking the collagen fiber. So without copper, you cannot cross-link the collagen. So that the proliferative phase is going to be defective. Now, moving on to the remodeling. What you are just doing in the remodeling is just that you are just converting your collagen type 3 to type 1. That's it, to increase the tensile strength. So if they ask you why, the reason is because you want to increase the tensile strength. So that activity is mediated by the fibroblast. So they release collagenase that will break down this type 3 to type 1. And that collagenase enzyme requires zinc to function. So that means that zinc is going to cause a delay in the proliferative phase. True or false?
Yeah, if it's
if deficient. Yeah.
I said zinc is going to cause.
No, just in remodeling.
So it causes a delay in the remodeling phase. So copper and vitamin C are concerned with the proliferative phase.
True.
Zinc is concerned with the remodeling. You cannot forget this. Zinc is concerned with the remodeling phase. Vitamin C and copper are concerned with the proliferative phase. So that is why they usually say that zinc is actually with delayed wound healing, but the phase is actually remodeling. So you are going to have a weak type 3 collagen if there is no zinc. So, but if there is zinc, you convert it to type 1 and the strength is going to be increased. So that is that about. Now, there are some mediators that we need to know. Number one is the fibrous growth factor, and it activates the fibroblast, and it also helps in angiogenesis. Transforming growth factor beta is the same thing as fibrous growth factor. Both of them, I just marry them together. Angiogenesis and fibrosis. Vascular endothelial growth factor is the same thing as its name, vascular angiogenesis. So platelet derived is like the baba that can do almost everything. It can activate the platelets for clot formation. It can activate the macrophage. It can, form the vessels, vascular remodeling. It can stimulate the fibroblasts to lay down collagen. So it does almost everything. Platelet-derived growth factor. Platelet-derived growth factor. Then you have the metalloproteinases. So they are there for tissue remodeling. So if you want to, break down some residual, for example, your collagenase will be an example of a metalloproteinase. So they allow for you to break down, collagen from one form to another to remodel that tissue, metalloproteinases. So they are important. And what will be the cofactor for metalloproteinases? Anybody?
Collagenase.
The cofactor.
Zinc.
So that's why they are calling it metalloproteinases. The proteinases here, just like the doctor mentioned, is collagenase. The metal here is zinc. So it makes sense. So zinc activating collagenase, and the complex is called metalloproteinase. Then epithelial growth factor 2 can stimulate, epithelial growth by this receptor. So you don't need to cram anything here. So that is just talking about the epithelialization. Don't forget the epithelialization in the proliferative phase. So EGF can help with that. So moving on to granulomatous inflammation. Hello?
Yes, Doc. Our brain is getting too super saturated.
Okay, I don't just, don't worry, we are going to stop with granulomatous inflammation, then we'll continue from there tomorrow. So let's just round up granulomatous inflammation, then we'll continue from there tomorrow. So granulomatous inflammation is a form of chronic inflammation, and it can be induced by persistent T response to certain infections, like tuberculosis, like immune-mediated disease that I'm going to be describing shortly, and some foreign body. So somebody that has exposure to coal, exposure to beryllium, all those pneumoconiosis, they can form granuloma. Anybody that is exposed to leprosy, to tuberculosis, they can form granuloma. Granuloma too can be formed in some immune-mediated disease like PBC, primary biliary cirrhosis. So anybody wants to let me move so that we don't drag the class. So sarcoidosis, primary biliary cirrhosis, Crohn's disease, they're all immune-mediated diseases that can, be associated with granuloma formation. So the idea behind forming granuloma is that you want to wall off that infection because you cannot eradicate it, you cannot degrade it. So just wall it off and keep it in check like that. So, but the inflammation is usually persistent and can lead to organ fibrosis and damage at the end of the day. So very important. Now, how does the histology look like? Now, if you look at this is granuloma. You can see this is a layer of cell here. This is another layer of cell. And you can see something inside. Will you call this a schizating granuloma or non-schizating granuloma? Anybody?
It's
Schizating
Yes.
granuloma.
So if it's schizating granuloma, what do you think would be the etiology from what we have discussed so far?
TB.
Anybody remember? I know we are tired.
Tuberculosis.
Yes.
Tuberculosis.
So we should not say tuberculosis, just make it broader. Infection.
Infection.
Because it's not only tuberculosis that can cause schizating. Once it's schizating, you are sure that it is an infection. If you are seeing a granuloma that is not schizating, don't pick infection. Just pick something else, maybe sarcoidosis, Crohn's disease, or something else. Now, what is the pathophysiology of okay, let me explain what it contains first. So you typically see epithelial cells. So epithelial cells are just like macrophages that are transformed to like cells that appears to be like epithelium. That is it. They are macrophages. So they are surrounded by the epithelial cells, surrounded by fused macrophages that forms multinuclear giant cells as well as lymphocytes. So 3 cells: macrophages themselves, epithelial cells, which are type of macrophages, multinuclear giant cells, which are fused macrophages, and the lymphocytes. So all of them, they will surround the granuloma like that, putting the organism in the middle. So we have 2 forms: the schizating, which is associated with the central necrosis, right, which is characteristic of infectious etiology, like TB, fungal, like histoplasmosis, and the other ones. And the non-schizating means that there's no central necrosis, so it's likely to be non-infectious. So think of sarcoidosis, think of Crohn's disease. So how do they form? So they form just like what I've explained initially when I was talking about chronic inflammation and activation of the macrophages to the classical pathway and the alternative pathway. So the first thing is that the antigen cells are going to capture the antigen and they are going to present it to the CD4 cells. Now, the CD4 cells, when they are going to present it to the naive CD4 cells. Now, these antigen presenting cells are going to release interleukin 12. These interleukin 12 are now going to make the CD4 cells differentiate into THR1. Do you understand that? I've explained it initially. They are going to commit it to the THR1.
Yes.
Now, this THR1, they are now going to release interferon gamma. And I said it that interferon gamma is an activator of what? Macrophages. So, and what did I say the macrophages are going to be releasing? What did I say the macrophage are going to be
Well,
releasing when they are activated? Eh?
TNF. TNF.
Yes, TNF.
TNF.
TNF. Don't forget. Don't forget. TNF. So the TNF are going to activate other T cells, and at the same time, they're also going to change the macrophage themselves into epithelial macrophages and giant cells, because the macrophage will start fusing together. So let us take it step by step again one more time to be sure that we get it. Tuberculosis enters. The first thing is that it's going to be captured by antigen-presenting cells, and it's going to be presented to naive T cells in the lymph node. They are going to release interleukin-12, which is going to change the naive T cells to a particular pathway, which is the TEPA1 pathway. So they become TEPA cells. The TEPA cells will start releasing gamma interferon to activate the macrophage. When the macrophage are activated, they will release TNF. TNF is now going to act on the macrophage too, and going to convert them to the epithelial macrophage and giant cells. So that is why the most important cytokine here to maintain the granuloma is what? The TNF. So that makes sense for us that if you want to give somebody a TNF alpha inhibitor, you have to ensure that there's nothing that can form granuloma that can destabilize. You have to rule out like tuberculosis. Because if that individual has a tuberculosis that is maintained by the TNF, and you go and inhibit the TNF, what will happen to the granuloma? It will break down. And what will happen to the tuberculosis?
To
disseminate
activation.
Activate.
Exactly. It will activate. So that's why you have to, before you give anti-TNF therapy, you have to ensure that you have ruled out latent tuberculosis. Very, 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 very important stuff. Very important stuff. So I want to ask us what latent tuberculosis is, but maybe some other time. So, and there's also another phenomenon that we have mentioned, which is elevated level of 1-alpha hydroxylase activity in the activated macrophages of any granuloma whatsoever. They are going to have increased 1-alpha hydroxylase. That is why sarcoidosis is associated with this. So resulting in increased vitamin D activity and hypercalcemia. And that hypercalcemia is going to cause what kind of dystrophy?
Metastatic dystrophy.
Metastatic calcification. That's what I meant. Sorry, I think we get what I'm trying to add. Yeah, thank you. So metastatic calcification.
Sorry, Doc. Does this also happen in case of TB? You said in any granuloma there's an increase.
Yeah.
So does that
can
mean
happen in TB.
patients with tuberculosis they can have hypercalcemia as well?
Yes, they can have it.
Oh, really? Oh, okay.
So, and you know the source. So once you see it, you know that, okay, this is likely to be the granuloma from the tuberculosis, causing it. But most of the times, with respect to the USMLE, they like linking it to sarcoidosis. I don't know why. But the major thing is not to cram it that sarcoidosis is a granuloma, sarcoidosis is hypercalcemia. It is due to the granuloma. So that in case they give you another cause of granuloma in your exam, and you are not seeing sarcoidosis, you pick that other cause of the granuloma. Do you understand what I'm saying?
Yes. So, it's clear. Thanks.
So that is it. So, so what are the infectious etiology for granuloma? So you don't want to forget the mycobacterial organism like leprosy. Many people don't know that leprosy is associated with granuloma. Leprosy is associated with granuloma. All those gommas that we see, that's syphilis. What do they call? You see them having like, it looks like gommatous lesion too. They will appear like they have a lionine faces. It's because of this. Yeah. So Bartonella and Selle scratch disease can also cause a stellate necrotizing granuloma. So stellate, in that if you look at the granuloma, they will appear star-like. So if the question is telling you that there's a stellate necrotizing granuloma on histology, you are not going to be picking TBO. That is spot diagnosis for Bartonella, and Selle. Listeria monocytogen can also cause granulomatosis infertiseptica, in which you are going to be seeing these nodules in the skin of the baby after birth. So it's due to Listeria forming granulomas, and of course, tertiary syphilis, that one is well known. Then fungal infection too, like histoplasmosis, parasitic infection like schistosomiasis, and catalyst positive organisms in CGD. So I'm sure we know the catalyst. Do we have acronym for catalyst positive organism?
Yes. Snap B.
Snap B.
Yes.
I'll come and be collecting this acronym from us later. So we have to know the reason why catalyst positive organism constitute serious problem in people with CGD and why catalyst negative organisms are not threats. I'm sure we know it. Do we know it? Hope we know it.
Yes.
Okay. So moving on to the non-infectious one. So that's about the infectious one. The parasites, fungal, bacteria, no virus. So the non-infectious one, immune-mediated, like sarcoidosis, very common. Crohn's disease is another one. So that is going to differentiate it from ulcerative colitis. And that one is primary biliary cholangitis. It's very important stuff. And it's also differentiated from which one? Anybody knows? What's the twin brother of primary biliary
Sclerosing cholangitis.
Exactly. So that one you are just going to be seeing onion.
Yeah, onion skin like.
Onion skin.
Yeah.
We are not chorusing this thing. Onion skinning, right?
Yeah.
So we are going to be seeing areas of stenosis alternating with areas of dilatation, right?
Yes.
Okay. Don't forget. Please, I'm begging. Primary sclerosing cholangitis. So what is the what's the word now? What's the malignancy I share with primary sclerosing cholangitis?
That should be
cholangiocarcinoma.
Cholangiocarcinoma. So what is the antibody in primary sclerosing cholangitis?
That's the one that is associated with ulcerative colitis.
Is it Sianca?
Yes, Anka.
Yes,
No,
Sianca.
what do they call it?
No,
It's
P-Anca.
not
It's
Sianca.
P-Anca.
In Dr. Obainde's voice, it can never be Sianca.
Pianca. I just know it's one of the anchors.
It's Pianca. Pianca. So Pianca, ulcerative colitis, just like somebody rightly mentioned, cholangiocarcinoma, and it is the only autoimmune disease that's common in men. True or false?
Yes.
True.
Biliary is for female.
I'm not setting trap today. So primary sclerosing cholangitis is very common in men. Very correct. So there's a lot of questions they can ask you there. Just understand that cholestatic picture. Know the way it presents. Once you are saying this, saying that, saying, that this is likely to be cholestasis, so you are looking downwards. Then subacute thyroiditis too is a cause of granulomatous, lesion. They form granuloma. It's immune mediated too. Then moving on to the vasculitis. So Wegener's, which is granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, which is the Church-Strauss, then the Giant cell arthritis and the Takayasu. I know we know all these things, so we have to remember them. They can form granulomas too. And foreign bodies, variolosis, very common, tachosis, TAC in cosmetics, then hypersensitivity pneumonitis, very important stuff. So Bedfrancia disease is an example of hypersensitivity pneumonitis, true or false?
True.
Okay, the stuff is still there. So, so we have come to the end of pathology today. I know that pathology is very boring. Please bear with me. We should just try to just pick the basic stuff. Just pick it because it's very, very important. You are going to be tested. A lot of questions are going to come from pathology, principal pathology. Please don't say that this thing will not pass 20 pages. You'll be surprised. By the time you come out of your exam, you'll be opening your first and you'll be picking, they ask this, they ask that. I'm telling you. So please digest your principle of pathology, understand it very, very well, because you are going to find your exam easy once you understand the principles of pathology. It's very, very important. Please and please. So, do we have any question?
Yes, I have a question, please. It's just not like on pathology, but I just want to know how you remember all these things. Like you're teaching one thing, you're remembering something else.
I don't remember.
Like, can you tell us the trick so that we too can have that? Is it the ginger now or the ability to synchronize the stuff well?
The thing is, what I would say is that you need to, number one, try to read with understanding. That's the most important stuff. Try to read with understanding, and you know that if you look at the population, just like I usually say, like the percentage of people that fall into the genius category is very small. So everybody, we are like, basic average stuff. So, and I know that the more you look at something, the better you'll be. So it's not, pathology is not something that you just read once. At least try to read like 3 times to 4 times. I know that we don't have time, but if you go through the video the first time, you already have like a baseline understanding. So by the time you are going again, you'll be faster. You can revise the entire neuro in like 12 hours. So the more you look at something, the better you are going to be at it, and the easier it is for you. And the most important thing, just like I'm going to say again, is read with understanding. Like, try to be connecting your stuff together. Look at the way I'm asking us those questions now. Like, ulcerative colitis, what stuff is affected with it? What cancer do you, it's because, we are putting our mind to that particular detail when we are reading it. So it will stay with you. It will stay with you. Just try to understand, okay? If they ask me about autoimmune hepatitis, what am I going to say? Just try to ask yourself, what am I going to say? If you can't say anything, that means you don't understand it. Some people be like, I can explain it, but I don't know how to say it. I'm telling you, you are lying. If you are saying that I don't know how to say it, you don't know it. There's no way you know something and not be able to explain it. So we should just try to, sit down and ask ourselves, okay, autoimmune hepatitis, what do I expect? What are the presentation? What are the laboratory markers? That is just what you need. So that is it. Although that doesn't work for all part of the first step 1, because you have some areas that are very, very volatile. Like all this public health, microbiology. Microbiology is volatile. You can easily forget, but the more you look at it, the better you'll be. And I usually advise people to take volatile aspects like microbiology, like very close to the exam. Read it freshly, to your exam. By that time, you should be done with all those ones that involve principles and concepts like neuro, like what's it called? Pulmonology, endocrine. You should not be revising endocrine at that time at all, because that one should be with you spinal level. You should know that, okay, cortisol, this is what it's going to do. This is the regulatory stuff. But endocrinology is principle. That one is, well delineated. So, but all this pathology, micro, what's it called? Ethics. Those are the ones that you have to carry, very close to exam, because everybody almost forgets them. So nobody has magnetic brain. Me too. I've forgotten a lot of things. I used to say it, but I go back and I try to look at it, revise, and keep myself updated. So, Doc, I know that maybe I've not answered your question. I know that you're expecting me to give you one.
Well, not exactly. Thank you. At least every little detail is very important for this exam. Yeah.
Yeah, pick every little detail, pay attention to it, attack questions. Don't be joining group discussion. See, I'm serious. Don't do that mistake and be joining group discussion. You see, you'll find out that there will be some people in that group discussion that they have solved that question you are solving. They will just be palming the question. And to get to a point, you can just ask them, now, this one that you are picking this answer, why are you picking it? They don't know it. they're always saying it because they've solved it. They're just there to just to make themselves feel good that they are palming question. But I can assure you, the USMLE you are going to see, the exam question you are going to be seeing are going to be different from UWorld or what's it called? In terms of the question, no, I'm not talking about difficulty. I'm saying in terms of the exact question. If you are going to see exact question, it might not be more than maybe one or two. They are going to be completely different questions. But trust me, once you have this baseline understanding with you, you will just be palming that exam, like you'll be smiling. I'm telling you, you'll just be tearing anything. Like it will be so easy. Because you don't need to have seen the question before. Once you have the concepts, that's what you need. That's what the USMLE is all about. Ability to use what you have learned in solving new problems. That is the principle. Ability to use what you have learned in solving new problems. Not you recalling solved problem in the exam. No, that's not what they are going to be testing. So that is it. I know that by God's grace, all of us, we are going to do very, very well. Because of the fact that we are here, I'm so sure that it's going to be, very successful for all of us by God's grace. So let's just go through the videos, note down important points, stick to your first aid. When you have a free time to revise, open your first aid. Don't join group discussion and be solving questions that they have. You can have a small cohort of, discussion, maybe one or two people. You guys just, solve questions together. Have like, okay, let's cover this and solve questions on it. Okay, you can be doing that, but not just join all this general group discussion and be solving, MBME and be doing all those things. And sometimes you might even be failing questions because you have not read that topic, and they will be getting it. But they're getting it because they have solved it before. Not all of them usually have like a baseline understanding. Show them new questions. You'll be surprised at the performance. So that's what I'm going to say. But we have made it to the concept. We've made it right. You can never regret being with us. I can assure you. You can never regret it, because we are going to show you, the nitty-gritty of the USMLE, what you need to pass. And I know that Dr. Babande, will have done a very thorough justice with most of those, stuff. Like the way I'm even sending questions to the page, the way people are responding, I'm very, very impressed. So if you can be, and most of the questions I'm sending to the page, I want to bring us the news that those are step 2 questions. So if you are palming step 2 questions like that, then I don't know how step 1 is going to I don't know how step 1 is going to be. It's going to be very, very easy. So there's no need to panic at all. There's no need to panic. So just, do your best, be diligent in your study, be consistent, and pray to God. That's the most important thing. So, do you have any other question?
Thank you very much, sir. We are really appreciate it
very much.
You are welcome. You are welcome.
Mhm.
So that means we are going to continue tomorrow. I think tomorrow let's meet by this time tomorrow by this time, this exact time that we met today, tomorrow.
7
We'll try to finish up.
7 a.m. Central Time.
I'm not in the US. I don't know.
Okay, that's
but
what
I'm 1 hour behind Nigeria.
okay. That's
So
what they put in the thing. 7 a.m. Central Time. Central Time.
yeah, so that time would send the email so we know.
Dr. Barali,
Hello?
I don't know if you stopped
Somebody
recording. I
said
wanted to
something?
ask you a question. When you
Okay.
recording, yeah.